Okay, everybody, come on into the room. Getting started here. First session of the day. Come on in, settle in. Okay, Anand, great to see you.
Hello, good morning. Can everybody hear me okay? Hi, I'm Anand Valamsetla, founder and CEO of Resilience AI. Today, I want to talk about intelligent systems for health, performance, and resilience, specifically through the lens of behavioral health. This work came out of my work on Resilience AI. This is not about automation of AI or replacing human beings. What do we mean by health, performance, and resilience? In this case, what we're talking about, health is about mental stability, and performance is about cognitive performance. It's the ability to take decisions with clarity. And third one is resilience, being able to absorb stress and come back from those stressful situations. Behavioral health is a very high stakes. Why is it? It's because in behavioral health, there is no ground truth. There is no real right answer. It all depends on the context. We all have different histories, different backgrounds. So there is no the context is really important. And it deals with the trust, identity, and agency of human beings, which are super important. And any harm created in the system is cumulative and most likely irreversible over the long term. For this reason, human accountability is very essential. When we take humans out of the loop, we're not only losing accuracy, but also losing responsibility and meaning. Recently, there is a huge push towards AI as a replacement for therapists, such as AI therapists, chatbots, and other. This is a very dangerous slippery path. Why? Because these AI systems provide scalability without context. Most of the time, these AI systems don't even understand human beings or human suffering, but they still give confident answers. So they provide authority. And when we remove responsibility actually shifts to the human beings, that is the patient, that is the most vulnerable. Instead of responsibility being on the provider, now we're making individuals responsible for this. Finally, engagement. These systems, AI systems, focus on engagement. Engagement sometimes actually goes against the well-being, so we have to be very careful. Our hypothesis is that we should not replace humans. We should not create systems that replace humans, but make them as part of the architecture. We have to put the human center. And these systems should actually augment human judgment, and they should provide patterns so that humans can take clear decisions. Finally, the Resilience AI, our project is actually founded in this ground truth. This is about providing, Resilience AI is about providing mental, body and mind health by combining cognitive, behavioral, biological metrics so that people can understand their state and take decisions for both. It provides intelligence for both the clinicians as well as the human beings. Thank you very much. Any questions?
Right here. Let's to the mic.
Sorry, thanks. You're facing strong competition from big tech companies. And how do people find this information? You know, people, they get into this, I will help you, and you have a data mine, whatnot. It might be even, you have directed information, personal information for people, so that you get hooked on that. So how to do that? You know, it's, oh, and then you should do this, you should get back to us. This is a personal advert.
Yeah, thank you for asking that question. I mean, there is a lot of competition, but however, we think without human in the loop, complete AI automation, we've seen what happened to the 16-year-old Californian students where ChatGPT helped them commit suicide, which is a dangerous truth, right? So we want to avoid that. That's why we want to keep the clinician in the loop so that that never happens.
I fully agree. So thank you.
Thank you. Thank you very much.
Thank you, Nan.
Was there a key I wanted to know? A man is what he thinks about all day long.
Okay, let's see. Let's bring everybody into the main room. Getting going with our second speaker of the day. We want to come on in.
someplace, and we're going someplace. The architect of the universe didn't build a stairway leading nowhere. Well, it's pretty apparent, isn't it?
Okay, ladies and gentlemen, Elias, Arjun, from HealthSpan Productions.
Sure, this is on. Okay, check. There we go. Okay, all right. So welcome everyone, and for I guess people live streaming, welcome to my business of longevity and validating product claims. So first off, before as we get started, who here considers themselves in the longevity industry by a show of hands? Okay, a couple people. So it's an interesting word though, longevity, because what actually is the longevity industry and how does it work? And that's something we're sort of going to explore in the presentation, and then I'm going to talk a little bit about where I think it's going. But 2025 was a absolutely pivotal, transformative year for longevity. It went from something that people were sort of passingly noticing. It kind of, be quite honest, for someone who's been in this for like 8 years, it felt like much of the last several years you were sort of screaming into the void. And then last year, you just saw it everywhere all of a sudden. Our conferences that we had previously, maybe 1,000 people, went to 5,000 people. Everywhere we went, it was in the news, it was in the media, everyone was covering it. But one of the things that was interesting is some of the claims from the more, shall we say, strong advocates of radical life extension started to go mainstream. Right, Brian Johnson with "Don't Die," and this even came in Nature. Nature published, could humans live to 150 years of age? So for those of you who don't know, there's sort of a lot of people consider that there's sort of a biological limit of about 120 years. We've never seen a human up till now live beyond 120. Like there's a woman who passed away recently at 120. Everybody was like hoping she was going to make it one more year because that had never happened before. So there is this belief now, or this goal, or this mission by a lot of people to see how radically could we extend our lives. Could we live 150, 180? Some people propose that AI is going to create this singularity moment where the upper end of lifespan is unknowable. So that is a big conversation that's happening now. I'm really into this. And actually, I have a question for all of you on this. Who here is ready to sign up for that like radical life extension? Who wants to live 200 years or more, right? It's an interesting thing because, like he's like, maybe, it's an interesting thing because there's a lot of people, there's a lot of conferences even now about the idea of the death of death. And what does that mean? But we haven't really reconciled that. with that as a society. But this is my favorite graph. I had this created custom for me because this is sort of this is the world we live in. Is most humans physiologically peak in their 20s and 30s. We cognitively peak in our 50s and 40s and 50s, and then we start this decline, this physiological decline, this cognitive decline, eventually into like old age, infirm, and death, right? Which is not fun. We don't like to talk about it, but it is what we can expect. So the goal of health span is, I think actually, let's see if this works. Oh yeah. So the goal of health span is this, right? More like yellow line there is like we don't decline so precipitously. Maybe we can make it 100 healthy years. But the radical life extension people are saying, well, look, we're going to go and we're going to intervene and we don't know how long we can live. And that's sort of what is the conversation. Is this possible? But health span is not exactly the same as longevity. That's actually why I call my company Health Span, because I feel like that's a goal that is attainable with the current level of technology and science, while there's some of these ideas of more extreme longevity are very theoretical at this point. But what is longevity? Well, longevity in many ways is going to eat the business of everything. And that's not what I don't think a lot of people realize this. Like, if longevity is something that the world moves towards, that includes the entire medical system, right? It's going to change how medicine is practiced. Absolutely. It is wellness, which is wellness and medicine are two of the largest industries in the world. I don't know if you know this, but the wellness industry is a multi-trillion-dollar global industry already, because when we include things like wellness tourism and spas and all of these other things, and then the fitness industry, and then the biotech industry, these are all the largest industries on the planet, and longevity encompasses all of them. But it's changing the whole model of how these businesses operate, because especially in medicine, because everyone in medicine, like I was here for JP Morgan week, and everybody is standing up on stage saying, I need to raise $5 million to do my clinical trial to get the phase 2 so that we can, sell the company to a pharma brand. And is that really the model that humanity wants to live under going forward? That, even these longevity companies essentially have to become disease care? I don't think that's what we want. I don't think that's what people want. So we're in this difficult transition moment where kind of all of this is getting figured out, which I think is great. I mean, I think this is a great time to be involved in this industry. I think it's a great time to be alive. And I think part of what I want to give you today is where I think, as someone who's deep inside this, where the market is going and what's about to happen. This is a statistic all of you should be thinking about if you're in business and in health care, health tech, any of this. 50% of people under 35 have made a decision directly against medical advice. So that means this younger generation does not believe, has no respect for medical authority, right? And COVID broke the world on this, right? The trust in institutions is at an all-time low, and you can't blame them. Right? Like, don't just be like, oh, those stupid kids, what are they doing? No, they have a reason to do this. And they're not just trusting influencers, although that the influencers online do have a lot of power, but they're also trusting friends, family, and they're kind of making their own way through health. I mean, a lot of people are even opting out of insurance and figuring out, like, I'm going to figure out how to take care of myself. So we need to start reconciling with the fact on the ground. We need to stop pretending that this isn't happening. I mean, also too, all these things are happening very fast all at once, right? Like the whole, for people who had to get out of the Obamacare, right, plans are all trying to figure out what to do. And right now, longevity is something that feels very elitist to the common person in America. So we need to also find a way to communicate this and get access to more people. So why are they opting out of healthcare? Don't blame the doctors. Don't blame the scientists. Don't blame the researchers. Have you guys seen this graph? Look at this. Look at this. This is ridiculous. We have almost no increase in physicians, and yet this is how administrative heavy healthcare has gotten. So when people ask, why is healthcare so expensive? Don't blame the doctors, the researchers, the scientists. Don't even blame the pharmaceutical companies to a certain degree, right? I mean, maybe the administrators in the pharmaceutical companies, but I'm sure like many of you, I work with pharmaceutical researchers and scientists. These are amazing people doing good science and trying very hard to make human health get improved. So it's really the administrative system in healthcare that is killing it. That's actually the problem. So if the public has lost trust, who do they trust? Right? And doctors went way down. They still doctors went from about 75, 80% trust in the public to about 50%. So that was a pretty big drop. Scientists, however, went from about 77% to 50%. Scientists are 73%. So people still trust science more than they trust physicians. So that's why, you're starting to see people wearing the lab coat and selling stuff online, which is a scam. That's not cool, if you're not a real scientist. But this idea that if we can speak directly to the consumer and show them that we have the science and this is what it means, and start explaining science to the public. And I think this is really the focus of what we're doing at Healthspan Productions and the Collective and Proven. So all my companies are circulating around this idea that we can bring evidence directly to the public, but we need the right people, the right communication strategy, because just pretending that, healthcare is going to go to the doctors and the doctors are going to bring it to the public is, I think, the wrong approach. Am I already out of time? No.
No, keep going. We got. That was a warning.
Okay. So how do we talk to the skeptical consumer? Because that's really what we're dealing with. We're dealing with a whole population of skeptical consumers. So what we need to do and what people respond best to, and we did this test. I'll share with you this test. We did double-blind, placebo-controlled clinical trial published in a journal on a landing page for a product. Would you buy now? How many people do you think bought that product off the scientific journal and the published paper? Raise your hand. Right? Nobody cares. So all that money you're spending, the general public doesn't care. So then the other thing we did is we turned it into a easier to read, easier to comprehend for the general public white paper, and said, here's the product, and here's why it could help you, and here's the science and evidence behind it. Who do you think purchased then? Show of hands. Yeah, some people. And then at the bottom, the same landing page, same product, same context. At the bottom, we put a video of a person just telling their own anecdotal story. I tried this product, I had X problem, I used this product, it helped me, and I'm very happy. Who do you think bought it then? That number 3 sold the most by far. So this is why an influencer going on TikTok or Instagram and telling their personal story about a product is the number 1 way the wellness industry sells things right now. So that's what people respond to. So again, I have a strategy and I'm not going to share with you right now because it's something we're doing with our clients, but we have a way we think we can merge those last 2 together, and we're working on that right now. So people want brands that they trust. They have high response to video testimonials, personal anecdotes. Our brains, all of us are wired for storytelling since our ancient ancestors. So we don't respond to data, we don't respond to graph. Maybe you guys are like engineers and scientists and hardcore people and you're data people, but the general public is not that. They respond to emotion. But they have reached the point, and this is where we're really focused, is they want clinical effectiveness, right? And they read online reviews. So you need to be an ethical company. So I'm just going to give you a couple examples of brands we work with that have really done this well. Anyone here heard of Fatty 15? a supplement. So they launched 3 years ago. Anybody who's in business, we're in Silicon Valley where everyone talks about business growth. They grew 3,000% in 3 years. And it became the #1 fastest growing supplement brand in the country, according to Inc. magazine. But they did this right. They merged science first with marketing, with testimonials, with a cool brand that made it fun. They did the whole thing. So if you want to go and look at a brand that killed it in the right way, go look at Fatty 15. One of the other brands I'm sure maybe more of you have heard of that we've worked with is Therabody. Anyone heard of Therabody or have a Theragun or any Therabody product? So they did the same thing. We've done research for them. Actually, I did the first study on the Theragun, a sleep study, and they go and they have walked this middle line. They go and they get their devices cleared by the FDA, right? Not approved for disease care, but just cleared, and then they sell them direct to consumers. So they're selling a wellness product, but in a way that physical therapists are using it, massage therapists are using it. They've sold 6.5 million Theraguns. So again, there is a path where you can sell direct to consumer or even through practitioners to the general public and scale and be very, very successful. They're market dominant. But the landscape we're in overall is pretty messy. These two are ads, right? So the GLP-1 craze is really hot. I think it's fascinating. No offense to Serena Williams, but as soon as she came out and said, yeah, I'm on a GLP-1 and it's hard even for me as an athlete to lose weight. And then of course, that's because she's working on a GLP-1 company, right? And she's promoting it. And then this one kind of just shocks me, like add peptides to your clinic with no medical experience. Right? Just start selling peptides to anybody, whoever they want, however they want. This is a great story. If you haven't heard this is done by Apple News. There's a guy who wrote a book about Johnson & Johnson and their billion-dollar payouts. You might have heard that story, right? The baby powder that was essentially like completely toxic, and they knew it for decades and still sold it. So if you wonder why 50% of the people don't trust the system, I mean, again, unfortunately, they have good reason. So I'm almost out of time, but I just want to, somebody reminded me to put this slide up because it's one of my favorite slides to show to people. That is a slide of human metabolic pathways. Okay, so these problems, and then I took this one pill, or did this one thing, and now I feel amazing. You think one pill's going to fix that if it's broken? It's estimated as much as 90% of Americans, 92% to be exact, are metabolically dysfunctional. So if we're dealing with a population that has dysfunction, you think it's just one simple point that's going to fix the whole system? That's the system mapped out. So we also really need to look at the truth of how complex biology is. And we need to remember that what we see online is not real life, right? It's the extremes of opinions. But most truth is somewhere in that middle. So just to end, I'm going to talk about why product claims matter, just to finish up, and why companies fail is because they just say, our product will make you feel better and it's good for everybody. And, again, that doesn't work. So you need to point out a tangible outcome that relates to a problem that I am facing. What's in it for me, and how do you solve my pain? It's that simple, right? So here's a product, very defined. We did a double-blind, placebo-controlled trial. This is a wellness product, increased blood serum glutathione levels. Here's another product, reduced cortisol levels as a functional beverage. This is like a replacement for Gatorade. And this was a study done by the Swiss national football team. And then we did some other high performers. And it was astounding. I mean, I would not have thought a Gatorade-like product could reduce resting heart rate in athletic individuals by 4%. That may not sound like a lot, but when you're dealing with professional athletes, that's significant. For a functional beverage, astounding what we can find when we do the research. So the future of health is preventative, right? We don't want to wait until we get sick. It is personalized. It is not everybody does the same thing. I found the secret pill. I'm going to be on GLP-1s from 16 until I'm 80. That is not a good idea. And it is precise. It is the exact dose and frequency and protocol designed for your biology. And your biology is different from yours, and it all has to be put together. So if you want to know more about what we're doing, or if you want to follow me, you can follow my company, HealthSpan Collective. We have a lot of different things going on. We're really, really busy right now. We're taking advantage of the growth of longevity in this year. And you can stay in touch with me and follow me here. Thank you so much, everyone, for your time.
Elias, you want some questions?
Happy to take them if I have time. I kind of took my time with talking.
You did, but I want to, we've got engagement here, so I want to give a couple people the mic, give them a chance.
Elias, thank you so much. Great talk as always. I want to ask you a question. I asked a Nobel Prize laureate yesterday, and I would like to have your answer. So how do you collect data in longevity space to prove that these interventions really work?
Yeah, this is the biggest problem we have. They have an X Prize right now for longevity, and all they have to really do is prove that there's a certain percentage of improvement over like a 1 year or to 2 year span. So we really aren't going to ever have, in many ways, true real world data until we give a person a treatment and then follow them for like 50 years. So I think everything is still in this inference, right? We do a study on C. elegans or rats or some. Actually, I met a woman at this event who has a mole rat that they say is a better predictor. So unfortunately, we're in this awkward position where we're going to depend on all of these models to predict what actually is going to improve human health until we get the real world data. So we're working on it. Yeah. Okay. Another question. I think I got to get off after that, but yeah.
As far as the studies that you do you work with universities or places like that?
Yeah, so at Proven, we have a network of researchers. So we have about a dozen institutions and 100 researchers around the world. So we kind of focus in on depending on what they're trying to do. So if it's more of an athletic population, we can bring in a specialist researcher for that woman's health, a different researcher. And so the whole idea is to create like an ecosystem where the sponsor comes to us, but we're only doing like preventative health, so longevity and wellness products. We're not trying to be a CRO.
Thank you, Elias.
Okay, thank you. Next up.
Okay, next up.
I'll hand you the mic.
Hey, thank you.
Are you going to present from right there?
Yeah,
let's
clicker situation. Yeah. Yeah.
Where did my iPad go?
The more I can hide from people, the better.
Where did my iPad go?
It's on the table. I sold it. Oh, no. Okay, just go up there and tap.
Tap, tap. Gave away the lead. 1 sec. All right. So bear with me. I'm juggling three computes here. I'll start right now. Okay. So if you've been spending the last few years trying to figure out what's real and what's noise, you're in good company. Because while you're left with making decisions about funding, building, buying, and hiring, everything's kind of moving under your feet really, really quickly. AI will replace this, AI will automate that, and you're under pressure to kind of like figure out how to navigate this whole scene, right? By the way, has anyone ever seen this? AI will replace X job? Only one person? You guys need to go to more conferences. All right. Okay. So here's what actually happens. I think it was like Jeffrey Hinton 9 years ago. He said, you no longer need any radiologists, stop training them. It was like his Nobel speech prize. speech, and he said, we don't need them anymore. And we still have them. We still need more of them. And when you look at the research, it turns out that the best outcomes come from when these radiologists are actually using the AI technology to make their job better, right? And so the pattern, it turns out, isn't replacement of any one job, it's augmentation. And despite all this, what we see is a lot of anxiety about people losing jobs. It's about people feeling risky about even utilizing AI to replace those jobs, because you don't always know if it'll do as good a job. And then who do you blame, right? And I think the reason behind that is we think about AI and some of these toolings completely the wrong way. We're used to, when it comes to any kind of an engineering problem, to say, how do we make this deterministic? Meaning, how do we get guarantees that it'll do the same exact thing, any kind of software, every single time? And that sounds right, because from an engineering point of view, that's how we operate a lot of the times. But in that framing, I'm not sure if medicine was ever deterministic. And I'll explain myself. When you give two separate radiologists the same case, there's a little bit of variability in the way that they understand it, in the way that they and without any clear guidelines, structured training, consistent protocols, that variability can be 10 to 20%. You introduce those protocols, as good hospitals have, good systems have, and all of a sudden it shrinks down to 3 to 5%. And that's the measure of a good system, not just introducing a new technology into play, right? So the profession didn't demand that doctors become machines or practitioners do. It built systems to manage the variance and like make the tolerances a little bit more acceptable. So why don't we use that model for AI? The question isn't like, how do we make AI perfect? The question is, what is the variance acceptable for this use case? How do we monitor drift? And when do we intervene? It turns out that the FDA already thinks this way. So risk-based frameworks, anyone heard of them? All right, definitely look into those if you're working with the FDA. Basically, it's if you have higher stakes, there's tighter tolerance, there's more oversight. You have to prove a lot more that your thing has risks. If it has a high risk, you have to first define that with your medical affairs group and your IRB. And then you have to also be able to step down from like, how do we mitigate this risk, right? And this is mostly true for medical device software. That's where I come from, but it's certainly true in a lot of healthcare and a lot of medtech, right? So lower stakes, more flexibility. And that's not new. That's just how regulated healthcare works. And where AI can create value is communicating updates across team. By the way, can you guys hear me in the back? Because I'm doing this. You can. Okay, good. All right. So communicating updates across teams, suggesting fixes based on past data. That's the best use case. That's how you actually utilize these things to get better and better over time. The more data you have, the better you can get at it. And speeding up practitioners without adding cognitive burden. And I think that's the key. If you can make practitioners faster without making them more tired, you get rid of another really big problem that we're coming up with in our tech world, which is tech fatigue. The more buttons you have to press, the more things you have to log in, the more errors you're likely to make, right? I feel this way about my phone because I'm using it to literally read off my notes right now. But the idea is, if you don't have as many things to do over the course of your workflow, if the user experience is such that you're pressing less buttons, you're dealing with less systems, you're much more likely to have better outcomes overall. Okay, so that's the difference between a tool that gets used and a tool that becomes sort of shelfware. And what I mean by that is if you have to go to a different portal, if you have to sign up for a thing, fewer of your practitioners are going to want to do it. Even if you go through the trainings, they'll know the way that they used to do something really, really well, and they'll want to continue doing that. So that's another thing that we can tackle. Okay, so integration into existing workflows beats a better algorithm sometimes. That's the key there. Okay, one more thing, you have to keep humans in the loop. I think I've been saying this all this time. not just as theater, but actual risk mitigation. This is what we say, experts in the loop or humans in the loop. I think that's got to be part of your strategy, at least in the short term, until the AI overlords take over. And before you fund, build, or buy, you should ask yourself just a couple of questions. I say 3 of them. First is, what's the risk level? Do we need to get everything to be exactly perfect? Or can we deal with the state of AI and where it is right now? And can it help us mitigate enough the risk? Can it produce real value for us? The second thing is, what's the moderate plan? AI eventually drifts, right? Any kind of tool drifts. You have patient data that drifts. You have data that comes in general that drifts. If you're not monitoring these things, specifically when you're utilizing your AI tools, you're kind of moving in the wrong direction. And you're going to, it's just not going to be as good a tool. And finally, where does it live? If you can integrate any of the new tools that you're bringing in, utilizing AI, into existing workflows, you're going to have a lot better success. If you're going to create brand new workflows, you better be damn sure they're so much better than anything else before that people will actually use them. That's the key points that I wanted to make today. My main point was to leave you with a tool. That was these 3 questions. I typically try to work on just reducing anxiety around tech, specifically when people are focused on jobs, when we can talk about augmentation. We can talk about this idea that no one wants everything to stay the same way. And when we talk about getting rid of jobs or anything like that, we assume that we're okay with the current level of progress. And the thing is, everyone wants things to be better, to be faster. And just because of that, we'll create new jobs as we go through the cycle of removing a few. And we'll create new things that we actually need to do. And so that's the gist of my talk. Thanks very much. Why should you listen to me? I am the principal consultant at my own company now. I have worked in medical robotics and medtech for about 10 years. I've had about 10, I want to say we're approaching a dozen really, really happy scientists and companies across a lot of fields, but primarily in healthcare and medtech. Thanks very much. This is my favorite part. Any questions?
Raise your hand if you have questions for Devinder. So my question is, did you, you told me there was like new experimental stuff. What was the new experimental part that you hadn't presented to before?
So the original talk that I had was kind of covered in the last 2 days. So this morning I scrambled to recreate the talk into something I think is a little bit different, right? The whole talk about what actually works for specifically healthcare and how to utilize AI better. My original talk was more about software and medtech software and how to go about doing that better.
Can you expand on the last question a little bit more? Where does it live?
Yeah, so let's say you want to introduce a new AI software of some kind, but it forces the user to create a new app. This is a classic thing. Oh, we have a new portal. What you need to do is you need to log in, and we're going to send you updates through this new portal, so you can't use your normal email anymore. And we're going to add a couple of educational things for you also. And by the way, we have like these 3 other things that we need you to do. It's going to make your life so much better. Forget like the practitioner, even from a patient point of view, you have to think about these things to make the user experience so much better that people will want to adopt it. You don't want to feel like, another app. You want to feel like, oh my God, this is so useful. You want to have that like ChatGPT is saving my life moment, but in a professional setting. Does that help? Yeah. Anyone else? Thanks very much.
Okay, let's give a warm round of applause for Devinder. Thank you for joining us today. And now we have Ashok Babar telling us about a lab in your pocket.
Well, it's still morning. Good morning, everybody. Oh, sure. Okay. Well, I'm here to talk about lab in your pocket. And we have a booth outside. You can come by the booth and understand what it actually all means. But why did we start this company? It's called Medix Biotechnologies. Closer? Better? Okay. So if you take a look at the world population and what goes on in terms of infections, there's about 400 million people that get infected by UTI, 400 million with STI, and then there's a whole bunch of other infections below that. And women actually take the bear the burden of these infections. About 60% of the STI cases are with women, and 80% of the UTI cases are with women. So it's a real problem, and we're focused on preventing these problems with our lab in a pocket. If you look at the United States, it's about 100,000 UTIs a day. 700 women, men and women get hospitalized, and out of that, about a few dozens die from UTI, which turns into sepsis. So we have been working on these, the software and the testing of how to actually do the test at home. PCR, everybody understands what a PCR is? Okay. Well, you give your sample to the lab, and after 2 or 3 days, they will give you the results. That goes to the doctor, and doctor prescribes you a medication. By that time, the pathogen has multiplied many, many times. So every 20 minutes, it gets duplicated. And the way PCR works is you amplify the sample, and then you can detect it. Well, that takes a lot of revenue, a lot of cost. In order to create a lab, it takes about $500,000 to create a small lab. And what we're saying is that with our test, you don't need any equipment. You can actually do it at home, and within 20 minutes, you have your results. That goes to your doctor, and then he can prescribe you the medication. So the underlying technology below this is basically isothermal, which means that you're at room temperature, not room temperature, at body temperature, the pathogens get amplified, and we're able to detect it. And you can detect it 2 different ways. You can either do fluorescence reading, or you can actually do it on a lateral flow strip. And if you do it on a lateral flow strip, you can view it and basically take a picture, comes to our cloud, and then it goes to your doctor. So everything can be done within 20 minutes. And if you take a look at what we're disrupting, you are actually bypassing the lab. You're bypassing all of the equipment manufacturers. So it's a major disruption, and we have proven that the test actually works. Now the next step is going to extra funding, and so that we can actually develop a full panel of UTI, STI, and then basically it's either point of care can do the testing, or a consumer can do the testing. So that's in a nutshell. Can I answer questions?
You have a question?
I haven't raised my hand yet, but I was thinking about it. You lost me on the science, and I'm a physician, and so I'm trying to understand what you're actually proposing, how it's different from like the urine dipsticks we use right now, and why would I, as a physician, when somebody says, hey, I got this result from this company, feel like I can trust that and write a prescription?
Right. So on a strip that you test, you're testing for what? That you have a UTI, but you don't know the pathogens. You don't know antimicrobial resistance genes. So what are you going to prescribe? General broad spectrum antibiotics, right? Yeah, so what we're testing in an electroflow strip, we're testing the actual pathogen and the antimicrobial resistant gene. And with that, we also have a treatment map, which basically translates those results into what the treatment recommendations are. So that you can take a look at and say, oh, this antibiotic is going to be less effective as compared to this one. So that's where we're different. So if you do the same result, you can do the same testing with PCR today, except that we're not using any equipment. We're doing it isothermally. That's the difference. So instead of sending your sample to a lab, you can do it at home. So big difference. Because you want to treat the infection. As soon as you know that you have symptoms, you want to be able to treat it, rather than waiting for 3 days to get the results. Yeah. Well, it's the technology underneath that we've developed. And you can take a look. I mean, it's proven. We have the results. You can take a look at in the booth. Yeah. Any other questions?
Yeah, I've got one. Hi.
Sure.
So this is very exciting. It sounds like, if I'm understanding you right, what you're doing is a kind of radio labeling of specific pathogens and also PCR on the genetic sequence of those pathogens to find a specific infection. And if you can do this, this is really exciting. I'm wondering, how much does it cost? How large is this device, et cetera?
Well, we're all familiar with COVID kits. So it's a lateral flow, and you can have multiple lateral flows, and you can detect multiple pathogens. And the complexity of all this it's very, very high when you think about it. In a PCR, so for example, if you want to test for E. coli, people have, over the years, have identified basically 5 different segments of the genome and say, okay, if this is detected, that means it's a E. coli. With our software, we can detect hundreds of targets and find the most optimal target that will give you the highest performance. And the reason why we need to do that is, in an isothermal, when you at body temperature, when you're trying to amplify, you need the most optimal performing targets. And also within those targets, you also have some antimicrobial resistance genes as well. So you find those with a combination of that, then you can basically detect it with, again, these are enzymes that basically replicate at body temperature. And that's how we can do it. And we have actually proven the result. The entire pipeline from finding genome to designing it, to detecting it, and then creating a treatment map. So it's an end-to-end solution, and our booth is there, and we can explain more. Wouldn't it be nice to have a test at home where you can actually do it in a few minutes, and rather than going in your car and providing samples and then waiting for the results after 3 days? Yeah. Any questions? Yes.
Thank you so much for a great talk. What do you think about the regulatory hurdles you will have to jump?
Good question. So today, if you take a look at the PCR world, the labs that actually conduct the experiments, majority of their panels are research use only. So you take a look at Thermo Fisher, QIAGEN, they're all providing these panels to the labs. And all of them, pretty much all of them, are research use only. So the labs basically take those panels and or kits, and they develop their own test around it. And those are called LDTs, lab developed tests. So you don't need any FDA approval because they are cleared from CDC to be able to do this. So we can initially provide our kits to a lab. It does two things for them. Basically, it reduces their cost of operating it. They don't need any equipment, and it's faster than running a PCR. But if we sell it to a consumer, then we do need an FDA approval. And FDA approvals can take anywhere from 6 months to, 12 months, 18 months, whatever it is. But you can still do the same thing with the lab and get the results faster than 2 or 3 days. Any other questions?
Any other questions? Okay. Thank you.
Thank you.
Ashok, thank you very much. Big round of applause. And Ashok has a Medics Biotechnologies has a table outside, so please visit their station and learn more. Next up, we've got a panel on what we've been throwing away. The power of menstrual fluid. Everything you always wanted to know, but were afraid to ask. Let's bring up our panelists. Olga, here we go.
Thank you very much.
This is your moment.
Indeed.
Okay,
right.
Morgan. Here you go. Yeah, good morning. Here you go.
And we're just waiting for our final panelist. Yeah, she's here. She needed a moment. So
Go ahead and start with intros. You're going to have to do a little mic sharing because we only have 4 that are currently in service.
okay, that's fine. Actually, before we start with intros, I'm curious to understand in the audience, how many of you here are founders yourselves or work directly at startups? If I can get a show of hands. Okay, so that's a great number. And how many of you are investors who are looking for the next big thing in biotech? Very good. Thank you.
Thank you, Nola.
Yeah. Very good. Please.
Riti, I've been dying to meet you. I'm really excited for this panel because these are some of the top menstrual tech companies, at least in the United States, maybe probably the world right now. And there have been a lot that have been coming up in the last year. I think there's like a dozen that have started in the last year. So this field is really emerging pretty rapidly.
No, I absolutely agree with you. So I'd like to thank our audience for being here. And I'd like to begin by highlighting that, yes, we're all here. We've been at JPM all week. There are a lot of buzzwords that are top of mind about novel ways to diagnose disease, novel ways to develop therapies, AI and foundation models for absolutely everything. But there's one element in biotechnology that's really been ignored and underappreciated. It's one of the most biologically rich specimens available. It is easily accessible. It has longitudinal value, it's renewable, and we have been flushing it down the toilet every single month. So we're not here today to talk to you about period products or cycle tracking apps or ways to optimize fertility. This group and I, we want to cast the spotlight directly on menstrual fluid itself, to move the conversation from stigma to signal, from trash to therapeutics, from waste to wealth. And we believe if you take nothing else away from this panel, please understand that menstrual fluid is the next great frontier in biotechnology. Yeah, thank you. So my name is Olga Sazanova. I'm the VP of Computational Biology at Zella Health. At Zella, we're developing novel ways to screen and diagnose disease through multi-omic analysis of menstrual fluid. And we're building an end-to-end portal to help women access this technology, benefit from specialty care, and get the health care that they deserve. I've worked at 23andMe and Grail. I've mined blood, interstitial fluid, saliva for biomarkers of health and disease. And we're bringing that same rigor to multi-omic analysis of menstrual fluid at Zella. But we can't do it alone, of course. It takes a lot of work and perseverance and ingenuity to craft out a new space. And so that's why I'm joined here by 4 of the pioneers in menstrual technology. So I'd like to ask each of you to introduce yourselves to our audience. And if you could start the conversation with this question: what are some common misconceptions about menstrual fluid and menstrual technologies that each of you have encountered in your discussions with potential partners or investors? And how does your own work prove those misconceptions to be false? And maybe we'll start with Morgan.
Could we introduce ourselves and the companies first?
Oh,
and then get into the questions?
Yes, of course. So perhaps you could introduce yourself, and then if you want to, we can move on to that question. Sure.
I'm dying to answer the question too, but.
Sure. I'll just give a brief intro to myself. My name is Morgan Stanton. I'm the CEO of Opal Therapeutics. So we're based here right in the Bay in the dog patch. We specifically focus on harvesting cells from the menstrual blood to grow uterine organoids. These are microscopic 3D models of the human uterus. And we're using those to develop therapeutics and understand the biology of chronic gynecological disorders, things like endometriosis, things like fibroids, that really have not had new drug discovery in a very, very long time. And we want to use this patient-derived tissue to basically jumpstart drug discovery in women's health.
Yeah, let's do it. My name is Juliette Humer, and I'm CEO and founder of Muse Bio, where we isolate stem cells from menstrual blood for developing better drugs, therapies, and aesthetic products. And for me, this all started because I was immobilized by a severe spine injury in my early 20s, and I was in constant pain, and they told me that my only solution was aggressive spine surgery every 5 years for the rest of my life. And I had no other option than to find a better option. And I found one, which was stem cell therapy. But the cost for my procedure would be $250,000. So I had to find another option, and that's when I came across the field of research in stem cells derived from menstrual blood. And millions of women are releasing these cells every month, and they're actually superior to our current cell sources. So Muse Bio came to be. And our tech allows us to capture these cells non-invasively in the privacy of your own home, and at scale, reduce the cost up to 90%. So we're transforming this stigma, as you said, into valuable tools to heal people. And we're a really new company. In the last 8 months, we've raised our pre-seed of $1.1 million. We've set up our donor collection sites. We've built out our labs and our stem cell bank, and we have a donor community, our muses, hence the name. And actually, we now have buyers for our first product, the aesthetic product, launching this quarter. So this is a really big moment for us. And it's all possible because I have a wonderful team. Our CMO is in the audience over here. And we really know how to move fast and execute. So now we're moving into this aesthetic product, and it allows us to bypass some of the regulatory burden, drive that technology into building therapeutics. Of Muse and why menstrual fluid is a vital biological value.
Thank you.
Thank you.
What a story. Thank you.
My name is Mads Lilleland. I'm the co-CEO of Quinn. Sarah Nazari, who she's on maternity right now in Denmark, so you have to deal with me. But this is her idea. She started at 19-year-old when she was going to med school in Denmark, thinking that menstrual blood is just being discarded, to your point earlier, Olga. So she thought, well, what if I could collect it, harness it, and diagnose for a host of women's conditions via menstrual blood? Eventually, she came to the States here and did a fellowship at Stanford, and then sort of that became the foundation of the company, YC Combinator company. What Quinn did was to actually develop the first FDA-cleared menstrual pad for collecting menstrual blood for the connection for diagnosing a host of conditions. We started off through the FDA clearance with A1Cs for diabetes, but we have hence launched a clinical trial here in the US for HPV and STIs, which was launched at the end of last year. And then we're working with research institutions across the world to get many women's conditions on, whether they're ovarian cancer, fibroids, endometriosis. So the more conditions we can get on, the more powerful it is for women for either self-diagnose or it comes through the healthcare system. We've also expanded and going after the international markets, so Southeast Asia and some of the parts of the global South. And that's where we're targeting some of the research, trying to replicate some of this research in those countries. So we see the commercial angle. So there's been a lot of conversation about women's healthcare and should VCs step in or not? We know what the data is, but it's obviously a huge business. But there's a massive impact. I grew up, even though I'm born in Denmark, I grew up in Africa and the Middle East. So lived in countries where women have little to no access to healthcare, and a technology like this can actually be a fantastic tool to diagnose women around the world. There's 1.8 billion women that are going in and out of the menstrual cycle phase. So it's a fantastic market to be in.
Yeah, I think there's 100 million women a day.
Thank you, Matt.
Hi, everyone. I'm Reedy Terriel. I'm co-founder and CEO of a company called NextGen Jane. We are developing a menstrual data platform in order to address, I think, that a much talked about topic in 2026, 2025, which is the women's health data gap. Our probably most interesting aperture that we are trying to build up is the ability to look at inflammatory and immune-mediated diseases by understanding what's happening in menstruation. And there's sort of a fundamental insight that's buried in there, which is that if you think about what happens during menstruation, your period starts off as a massive inflammatory event and moves to essentially perfect wound healing, completely natural process that happens over the course of 3 to 5 days. It's like phenomenally interesting, right? And something that we should be able to leverage to think about everything from better drugs for I&I diseases to better diagnostics. We broadly cover and are trying to address a lot of the diseases you've heard mentioned already on this panel today. Our only sort of different sort of lenses is that things like endometriosis are not just reproductive disorders. They're actually inflammatory diseases that have a strong immune component. The reason that we started down this path was, I&I is interesting. It's a big market, but there's so many unanswered questions when it comes to women's health. And if you know any women in your life, you've probably encountered some of these questions, right? Why am I having trouble getting pregnant? Why are my periods so painful? And all of these questions could be addressed if we had the data to be able to interrogate it. And I think that everyone that recognizes the potential to use this essentially natural biopsy to start to address some of these questions. The problem becomes this is a noisy and heterogeneous sample type. right? And so in order to make data useful, you have to go through the process of trying to standardize it, normalize it. How do you collect it? How do you actually generate high dimensional data from it? And what are the labels you attribute to this data that you're collecting such that you can actually build interesting ML models to use it? So that's really where we focused, is to say, fix the process of how you actually standardize and collect this sample type, and then you'll be able to ask many profound questions of it.
Thank you. Thank you so much to each of our panelists for those really, truly interesting introductions. I actually want to skip ahead because of something you just said, Reedy. I had our opening question, but I want to get right into the meat of it. So your point is very well taken regarding the lack of standardization and the data gap. And I think every one of us who works with menstrual fluid has come up against that in one way or another. And so my question is really toward Mads and Reedy to start. Because menstrual fluid lacks kind of the massive standardized cohorts of blood and urine and saliva, we're all stuck, I think, or not stuck, but challenged by the same question of what does normal look like? If we want to understand abnormal inflammation, what does normal inflammation look like in menstrual fluid? So we at Zealous see this as both a challenge and an opportunity. And I'm curious how each of you have dealt with this reality in the work that Quinn and NextGen Jane is pioneering.
Cool. I love this question. It is absolutely, there are pros and cons to both. I mean, when we started out, there were companies that would go and say, we retrospectively looked at a biobank of, 500 samples and ran some assay and were able to establish X. There were no biobanks of menstrual blood, right? So you don't actually have that opportunity to generate data very quickly. And that is the con, is that people are unfamiliar with it. There's no existing infrastructure that you can leverage. And so you're sort of starting at ground zero when you think about reference ranges that make sense. The second layer of that is that even if you were to start, eventually over time, you saw people start to publish papers, single cell sequencing papers, bulk papers, even proteomic papers. There wasn't necessarily standardization in how they were doing collections, right? What day? What day were they collecting? But one study would do the beginning of the period, another study would do at the end of the period. It makes a big difference, right? How you collect. Are you collecting with a pad, a tampon, a menstrual cup? All of these things add and introduce variability that you have to account for. And so those are the cons. I mean, the only way to address it is to actually build the norms yourself and start to generate the molecular profiles and work towards establishing what a norm is. The pros that I think is really an advantage is generally we come up with reference ranges, that are population based. But one thing that menstrual effluence really gives you an advantage is the best normal range is against yourself. And it's so easy to self-sample menstrual blood. And so the big pro is that even though you have a late start because there's no existing infrastructure, you have a natural biological advantage because you're easily able to establish reference ranges that are personal and not necessarily population-based.
I completely agree with that answer. Mads, would love to hear your perspective.
Okay, so I'll answer it in adding something to it, hopefully. But I look at it, so your question is how much has been done and is there anything done there? I see it in the sense that what I've experienced over the last year and a half is that the doors are opening extremely fast. So if you take the condition like endometriosis, there's research institutions around the world now that's going after trying to find the signals in endometriosis. Mm-hmm. And it's not just here in the States, it's in Europe, it's in Asia, it's other parts of the world. So we take those conditions, and when we have gone out, for example, into Thailand as an example, import license is already there. We are talking to the hospital groups, the research institutions, the lab people, also government side, and I see a opening of what can happen with research into menstrual blood. So it's a matter of time before we have just as much as the data coming in, and it's what Reedy's doing and in her company and others here, and what we're doing is that we're providing now the tools, the platforms for them to do something about it. They've not had these, they didn't have what Reedy's built, what Quinn has built, and what others have built. They now have it.
That's right.
We just need to bring it out to the market. They know about it, and the research can start. We don't think we'll do all the research. Other people will also do the research. So we'll do both.
No, I totally agree with you. And I think the opportunity to set the norms and to really be the pioneers is one of the greatest advantages of working in a new space. I think continuing off of what you point out about how quickly everything is moving, I have a question for Juliet and Morgan. So you're working in a space that has a lot to offer to pharma and to how we develop therapies and drugs, but pharma R&D is expensive. Pharma is notoriously risk averse. And so I want to ask each of you, how do you aim to convince big pharma to step away from their animal models that are tried and true, even if flawed, and move towards the cutting edge technology that you're developing from menstrual fluid?
We, like I said before, we work in these organoid models. For those of you not in drug discovery, getting a drug from like the lab bench to a patient is over like $1 billion endeavor, right? And then throw on top of that, 10% of drugs are all going to make it, right? That's a 90% failure rate. That's a lot of risk already pharma is looking at, so they're very picky about the models they're using, very cost conscious, that sort of thing. When you get to women's health, we actually have an even higher failure rate in chronic conditions. It's 97% of drugs actually fail. We have a 3% success rate. It's very, very tiny. And a lot of this is due to these early R&D models. If you're looking at something like mouse data, and you're hoping that's going to translate to a human woman down the line, are you going to make $1 billion bet on that? I've met many companies that have said no, right? And it's put up this huge roadblock for drug development pipelines, women's health. And so when I talk to pharma, basically we're chipping away at that risk, right? We're starting with human patient data right off the bat. Day one, we're starting specifically with patient-derived cells, these 3D uterine models, with the goal of de-risking and improving that drug translatability, that data translatability when you start to get to clinic. Even something like increase in 25% success rate at R&D could save over $500 million per drug asset, right? And so this is how I try to convince pharma. There's been a lot of news lately about organoid models, not just in women's health, but brain, liver, gut. The Trump and Biden administration both have been pushing it for the past couple of years, and it's just rapidly accelerating. The FDA, the CDC, all are moving more towards these human-based models and away from animal models. And I want women's health to be part of that. And so that's kind of our focus right now and selling point.
Yeah, I agree with what you've said, and I'm really glad for what you're doing. And I think that, I don't have a specific answer as to say why. I think animal models have a place, and I'm incredibly optimistic about where our field in women's health in general is going. I mean, you're creating organoids of the uterine model, and you've passed the first FDA-approved menstrual blood diagnostic tool. And, stem cell therapies have been approved for the first time this year in the US. And for us, there's over 150 clinical trials who've gone through phase 2 using menstrual blood-derived stem cells for 150 different diseases. So there is validation that's happening in the world, and this is happening pretty rapidly. So, how we convince big pharma, I think there are many roads to this destination, and I think we're doing a very excellent job, in my opinion. And yeah, I'm very optimistic for this direction, and there's a lot of support. And women's health is boiling over right now. If you've been walking around JPM this week and gone to any of the, there was no way I was possibly going to go to all of them. There were so many, as I'm sure you resonate with, and they're packed, with investors, with founders. There's so many companies coming out, so many people investing in this space. And yeah, I'm optimistic.
Yeah, of course. Riti, did you want to chime in as well?
in addition to all of the ways that this could expedite drug pipelines in discovery and preclinical, there's so many opportunities in clinical development as well. The $1 billion, the large majority of that is spent in clinical development, right? These are your phase 1, phase 2, and your big phase 3 trials. And we've seen what the impact of failures can be. And so all of you remember during COVID, everyone was racing to get COVID vaccines out there. And one of the things that was missed, it was not catastrophic, was just that the COVID vaccines, in addition to COVID, they do have an impact on your menstrual cycle, right? And this was found not during the clinical trials because it was explicitly being looked for. It was found because there was a outpouring on social media of women who were in these clinical trials saying, my period has changed. There were women in menopause who started to have periods. There were women whose menstrual cycles were longer than usual, heavier than usual, delayed. And so, a real effect was happening. It was completely manageable, but it was real enough that it should have been caught during the trial so that they could try to characterize and quantify it. And there was a huge ex post facto reaction to it, like NIH threw money at it to say, we have to try to understand this very quickly. And you would hate for something like that to be a deterrent to a vaccine uptake during a pandemic, right? You want to make sure those things are on your radar. And you can as long as you can characterize the risk and it's minimal, it doesn't matter. And so fundamentally, I think that was a really great use case of like pharma needs to take these things into account in advance, or there could be serious consequences to adoption. And we were talking, there's so many women now working in so many companies now working in this space. We were talking to one. This is unpublished data. I will just hint at it, but I don't know if you guys know this. This is published, which is that most people that take GLP-1s are women. So there are more women that take GLP-1s than anybody else. They look at a vaginal microbiome, and they noticed a shift in vaginal microbiome in their population that takes GLP-1s. Now, what's the consequence of that? We have to understand it and characterize it, but there's a shift. And so again, this is like your major constituent taking this extremely lucrative, interesting drug is women. And if you've missed something that's going to crop up later, that's going to be a huge liability. And so I think that there are real reasons in clinical development to be really comprehensive in how you characterize the impact and side effects in female bodies.
What a great point. I actually had no idea about the COVID story. So really fascinating. I want to go back and read up on that. I think considering menstrual fluid as a vital sign is a message we should all be getting out there as loudly as possible, because it is so readily available and it can teach you so much about what's happening with the physiology of your patient or the individual at the moment. So thank you for highlighting that. Gosh, time really flies. I feel like we could have a conversation 3 times as long as this, but I do want to bring it back to the fact that biotech is a business and that each of us is involved in young companies, and our commercial strategy is, of course, of the utmost importance. So I'd like to pose a question to each of the panelists. And Mads, perhaps we can start with you. B2B versus direct-to-consumer, these are very different commercial paths, and they have different implications. So where do you see some of the trade-offs between these two fundamentally different models? And can you expand a bit on why you've chosen the focus that your company has chosen?
Yes. The very simple answer is both in our case. You could, because we create a menstrual pad, it looks like a menstrual pad. You all know the difference when you look at it. It has a strip in there, Whatman paper, and it's dry blood. When we think about the distribution angle, if you get all the conditions on, or multiple conditions on, the way I think about it, and one of the things I'm looking at is how do we get to mass market? How do we put into get to as many women as possible? And if we look at the landscape, which I was alluding to earlier, where are women? Obviously here in the Western world, others, global South. You have to think about it in completely different ways. It has to come through consumer products. It has to be able to be purchased online. It has to be able to come through healthcare systems. So wherever women go is where you want to get it out, because the element of it is also a self-empowerment, empowering women to self-diagnose. Really was touching on that. So you might have conditions that get caught through the healthcare system. You could use menstrual pads and others to like see what the journey is. Is it what's happening there? So I think of it as both. There's nothing for us. We have to think of it. We may start off one path, but we will go everywhere, and we will partner with very large companies as well as smaller companies to get it out there.
I agree. I agree. It's got to be both. And our strategy, our mechanism that we're moving forward with right now is this aesthetic product. The aim, our hearts are set on therapeutics, but we're starting with an aesthetic product that will be a B2B purchasable good. And one of the benefits of this is that now there is a value put on the actual fluid that is in menstrual blood, the cells that are in menstrual blood, the medicinal compounds that are in menstrual blood. There's 1,200 unique medicinal proteins, and they're unique every single day of your period. And there are stem cells that have this unique healing ability. I could go on, but we're looking to partner with a distributor right now that goes to 700 aesthetic clinics, so that there's awareness that this is a valuable product, and even targeting. This is a bit of a, I can't say the name, but we're working with some celebrities now to also bring this into the mainstream, so that this isn't, just categorized as women's health, or isn't just categorized as a menstrual product, but actually people can know about this. And I feel very lucky because I on the direct-to-consumer side, I engage with donors every day, and I speak to women all the time, and it's the most wonderful thing to get to share some of this information with someone. And I'd say 99% of the time, whoever I'm talking to is I effing knew it. This makes so much sense, and I'm so stoked, and I feel so good right now about this. And it's a main drive for our donors as well.
Yeah.
So a little bit of a tangent, but also to answer your question.
No, I think you're completely right. And I really appreciate your earlier comment too about how the starting with aesthetic gives you a path that's a little quicker to market, because it is subject to less regulatory overhead. And I think that's very wise. Yeah.
Thank you.
Morgan.
So Opal operates directly B2B. We don't have a direct-to-consumer component. And I will say it lets us, focus on the science, focus on our goal of getting these therapeutics out, right? We do have to have that regulatory oversight. So this year we've done 6 paid partnerships actually the past year. And it even speaks to the previous question of how do we show pharma interest? We start working from the ground up, right? We worked with younger biotechs that have therapeutic assets in endometriosis or fibroids, and see how they work together with the organoids. And we only see this as growing over the next few years. More and more companies are getting assets out there, and they need ways of testing them. And so that's kind of our niche. I will say that consumers, or the women that participate in donating menstrual blood to Opal, are a huge part of our community. Actually do a lot more community building than I thought we did. We're not selling anything to these women, but they truly want to understand how their sample is going out into the events, inviting students or participants, whoever, a major part of the company, and why we've been successful over the past.
That really resonates. I think my guess is true for each of our panelists, but at Zella, we've certainly seen so much demand for, the information we're putting out about what we're building. And I think it speaks to how thirsty women are for solutions, in part because of the, very low success rate that you've talked about, Morgan, and just the lack of data and information that we're all handling and dealing with. So, I want to thank our panelists, and we'll have time for questions. Yes, from the audience.
Need a microphone.
Okay.
I'll take this one so you guys can share, and you guys can share.
Sure, and I'm happy.
I'll be the share. Okay. Yes. Continue on.
Well, I wanted to point out that hopefully at this point, everyone in the audience can agree that menstrual fluid isn't an icky curiosity, but that it is in fact the next frontier in biotech. And it can cast such a valuable lens on the inflammatory processes and opportunity for early disease detection. We can derive cell therapies that are curative for menstrual fluid. We have best-in-class models for what's happening in in the body directly without having to rely on petri dishes and animals and so forth. So it really is the next great frontier, and we're very curious to hear your thoughts and your questions today as well. We've got some over there.
All right, thank you so much, Dr. Olsen here. I do have a question regarding the studies you're doing and the women donating the blood. In terms of being inclusive, there's always been in history a lot of concerns about not being inclusive enough of minorities, African American women, of course, Hispanics. And so how are you dealing with that aspect of this and making sure that they are also included in these studies?
So in our case, we launched an HPV STI study, and we've partnered with Planned Parenthood. So we're collecting from 24 sites. We just launched it in the last year, so all the samples are coming in. So we're working with them to ensure there's a broad distribution of women. We're also a recipient through Welcome Leap vital sign program. So one in the UK, we're providing the tools for them, and one of the criteria was that they would have a very broad sample of women. So we do it ourselves, but we are also working with institutions that look at that. And that's also, to my earlier comment, we're going after other parts of the world like Southeast Asia. So we're going after a significant diversity program there.
If I just add to that real quick, what we've learned at Zella is the method of collection is very important to being inclusive, because there are certain barriers to how a woman handles her menstrual flow. So we're making sure the technology we're building is adaptable to different cultural sensitivities and physiological sensitivities about how you're actually getting the menstrual effluent. So thank you for that question. It is very important.
Reedy, you mentioned something about the self-healing nature of the uterus. Can you expand more on that and how standardization could unlock insights?
Yeah, I think that what I was pointing at was fundamentally the point of menstruation is to shed your endometrial lining and regrow a new one. And this is a mechanism and a process that happens every single month in the reproductive years. And so essentially in immunology, the focus for, up until now, in terms modalities has been to try to target inflammatory markers to bring down inflammation, but obviously there are two sides to how you move from a wound being created to healing. One is your body kicks off an inflammatory process, and then it clears it, and you get to a point where you have tissue repair. And so fundamentally, there has been more focus on the inflammation piece of it rather than the repair mechanisms and repair biomarkers. And the thing that I'm trying to highlight is in menstruation, you have infinite observability, meaning you are able to actually access samples as they move from inflammation to repair. And if you're actually generating molecular profiles, so we use RNA sequencing on those samples to watch and observe how they transition from inflammation to repair, you have insight into what those repair mechanisms are and what those repair biomarkers are.
I can add a little to that if that's all right. Yeah, I mean, the endometrium is the only organ in the adult human body that regenerates every month without any scarring. And that's also a key piece as to why we are so interested in this source of stem cells, the cells coming from this organ. The scar-free healing is unique to these stem cells. No other stem cell has this unique secretome profile that results in that fibrosis-free healing. That's why a lot of the studies and clinical trials that are currently going on are focusing on fibrosis diseases, liver cirrhosis, lung fibrosis, et cetera. So, it's an inherent property to the function of the organ. And I'll add one other thing, which is, if you are to become pregnant, the functionality then becomes immunomodulation. There's immune privilege there. They are making sure that the mother and child are not rejecting one another. It's another key component as to why cells from this particular organ are optimal for regenerative medicine.
Hi, I'm Amy. I'm actually Sarah's classmate from Singularity University. So I know Cuban from, at the beginning. I was very happy that you step in when she's on maternity leave. I have a curiosity question. How do you feel as a man sitting on the stage, promoting obviously a women-focused product and travel around the world? That's one thing. Secondly, can you share what contribute to the insight of you guys getting FDA approval? And I'm curious, like other speakers on the stage, is that on your roadmap, and how difficult that might be?
So to tackle your first question, perhaps it's culture. I'm born in Denmark. I've been sent as a little kid to go buy pads, tampons for my mom, girlfriends, eventually wife. I have from my mother-in-law a T-shirt that says "feminist" on it that I got. So yeah. So maybe that answered the first question. I'm happy to be included on the panel. You would have seen Sarah here if she wasn't on maternity leave. But this is an exciting opportunity. So I work a lot with startups and obviously with capital flow and where VCs are spending money. And to me, this is a no-brainer. I mean, we talk about women's healthcare and so forth, but just where the money needs to go, this is where it needs to go. On the second part, you were talking about how the difficulty on the FDA approval cycle. Yeah. Oh, okay. Yeah. So Sarah and Søren, so Søren, the other co-founder, I mean, they, working with other people in the company, of course, went through the whole process to get the FDA approval. But it's extremely difficult. We're an external, non-invasive device, so it's easier for us. But it is a kit, so the whole kit is FDA cleared. And there's two pads in there and a container for the strips that go in, and it's self-label going in there. So it was very hard for us to do, going back and forth with them, but we got through it. And that's obviously helps us as we expand in other parts of the world, because they will look at the FDA clearance. The very critical thing for us, now that we got it, is get moving on more and more conditions ourselves, and then enable other researchers to find the signals for whatever conditions. But it is tough. How long did it? That's a good point. I actually don't know. But it took a couple of years to get it done.
I want to thank this panel, this amazing panel. We're big hand, big round of applause. Unless there was something else that we were missing, anything somebody needed to say up there. But otherwise, we're going to move on to our next presentation. So thank you very much.
Thank you, everyone.
Thank you.
Olga, Megan, we switched slides. Juliet.
Yeah. Before we leave the stage,
yes,
for some
photos.
Picture of us. Yeah. So if you want us off, you better help us out.
Lots of photos. Upload these to the Google Slides presentation. You'll all see an email giving you a link to Google Slides. Please contribute. It's a community effort. And then what we should do is, if you guys can turn around, we'll, here, I'll get you this way. Gather here with the audience in the background.
Oh.
Don't fall off the stage. Use that liability insurance. Okay, thank you very much. Big hand, everybody. Let's grab your microphones. Grab this one. Okay, next up, the Collins slide, please. Okay, Colin. Here you go. It'll come up. They'll have to.
All right.
Okay, let's. Okay, let's give it up for Colin coming up and the panel, the amazing panel coming off. And yeah, thank you. Clap those hands. Bring that energy.
All right. Thank you, everybody. My name's Colin Jarvis. It's a pleasure to be here. I'm honored to be a speaker. That is sure a tough act to follow. That was a pretty incredible panel. But one of the things I've kind of noticed being a part of this conference and that panel and some of the other speakers before that is that many of the founders and the people involved here have a deeply personal connection to healthcare, whether that be through their own personal journeys or a personal mission from somebody that they know. And I think that that's incredibly important when we talk about the future of medicine and what innovative companies and folks like the audience here are thinking about doing. And that's kind of what I'm going to talk a little bit about today, because I'll be honest, I am by no means an expert in the way that many of the panelists that you just heard from are, but I do have a personal story that spurred me into this realm of the forward-thinking healthcare and how we can change things for the better. So I'm going to share my personal journey, which starts back when I was very young. And just to kind of share a little bit of background to give some context of my story is that I grew up a long-distance runner. It is just something I fell in love with as a young kid, and it grew into a passion and opened a lot of doors for me, including the ability to run on scholarship at UC Berkeley. And so I did my undergrad there. I was very competitive, both in the classroom and on the track, but it was my lifelong goal and dream to one day become an Olympian. And the photo that you see up here is from 2012 when I won my first major collegiate championship and was well positioned to actually follow through with the dream of one day becoming an Olympian. And many people often dream of that, but to actually have it be somewhat of a reality was incredibly exciting. And so I kind of threw everything I had in college towards that goal. That included spending months over the summer times training at high altitude. And while I was training over the summers towards my goal of becoming a professional Olympian and track athlete, I was diagnosed. And I'm not sure if many of you are aware of or ulcerative colitis, but it's a disease that affects the large intestine, and I didn't know anything about it, and I didn't have any family members that had anything like it, and so it was very new to me. And initially, it started off as very mild symptoms, nothing too concerning, but some stomach aches, and I was given some normal medications and kind of sent on my way. And this was really my first experience with the medical system as it exists today. And I was trusting it and kind of did what the doctor said, but over the course of the following few months, as I continued to train, my symptoms got worse and worse. And I'm sure it didn't help that I was running 120 miles a week at that point in time. But after some time went by, I did what every doctor and clinician would hope that their patients don't do. And I started going to the internet to try to figure out what is actually going on with me and how do I figure this out. And I went down a whole rabbit hole and learned that ulcerative colitis is very complicated and that there's a wide range of potential outcomes. And I felt at that point I really hadn't been prepared for that, any of that, as I kind of moved into this journey with my own health. I didn't know anything about it, and my doctors didn't really teach me. I kind of had to learn on my own. As time went by, things got worse and worse. And it was actually only about an 8-month period where I was diagnosed to actually needing to have a major surgery done with a septic large intestine. And so I now live life with an ostomy bag. In combination with this challenging medical device, there were all of these questions about what was I going to do with my life and how could I move forward with everything that had happened. Once I needed to have this surgery, it kind of got sprung on me in a way that was unexpected, and I didn't know having a surgery was an option for my diagnosis, but today with this medical appliance that I had was an incredibly terrifying experience, and it took me a long time to adjust to that after doing it, having it. But one of the things that I learned in my time at Berkeley was from one of my favorite professors, and his quote's up here on the screen. It says that only challenge can produce the opportunity for greatness. And as I was kind of navigating my own health journey and figuring out what am I going to do to move forward with this new life that has kind of been sprung on me, I thought back to this quote and this idea, and I think it relates all more broadly to this conference as a whole, because I was dealt this incredible challenge and I was having trouble managing it, but I knew that with challenge comes opportunity. And for all of the folks here at Health Tech Week, we all have, when you're looking for opportunities, you're looking for challenges. Where are our patients or the people that need the healthcare? Where are they challenged, and how can we help them fix those? And those are the opportunities. And so in my journey, I made the decision to try to dive headfirst into this world of healthcare, because I had been so upset with everything that had happened in my own experience and how I was kind of treated throughout the process and was in the dark. It was very reactionary. Everything along the process was just kind of responding to things that had happened, and there was really no forward-thinking assessment going into it. And so when when I graduated college, I went on a backpacking trip to kind of prove to myself that I could be physically active, and that's where I kind of shifted my perspective and had this realization that this challenge was an opportunity, and that it would inspire me to now kind of take the step into healthcare. And after, I was able to actually spend a couple years running semi-professionally, and even with an ostomy, and that kind of helped launch me into this healthcare career, because I helped start a company that helped people with ostomies live a more comfortable, active, and fulfilling life. But beyond that, I knew that my life's mission and my passion is to try to make a change in the way that medicine is practiced, in particular in a way that looks forward and is on a more preventative and an early detection process. Because when I think back to my experience, the disease that I was afflicted with was very tied up to genetics. And if I had known more about my family's predispositions, there are lots of things that one can do to help manage disease and symptoms like this with that prior knowledge. But this is the power of hindsight after having all of this done. I still continue to be a very active participant in the sport of long distance running. I'm no longer chasing any professional goals there, but I think that it coincides really well with the direction that both I'm trying to head and the direction that the companies that I represent are going. And that is so I'm here representing human longevity, and I joined the company about 6 months ago because in much of the way that I've described so far, I believe that we need to be thinking about our health in a proactive and preventative way. And we've heard from other speakers talking about the importance and the desire for patients to have a personalized and precise medical process that is unique to them as individuals, that is not just reactionary, that can actually give you actionable things to avoid these outcomes, so that there hopefully in the future that there will be less and less scenarios of patients like myself who were kind of the victims of the big machinery that kind of runs our reactionary healthcare system today. And with human longevity, we use precision data, including genetic sequencing, full body MRI. We do blood panels, EKGs. It's basically a full body assessment that looks at all of these biomarkers over time. And we're able to, one, make sure that we're detecting some of the major diseases early on as well as we can. And also giving you an idea based on your genetics and those biomarkers, what you're most likely to experience in the future, so that you can make an action plan both for the early detection of those things, but also the prevention of those. And that's guided through with our clinicians that we have on staff. And we've been around for actually 12 years. San Diego was the initial site that opened up with human longevity, and it was started by the famous scientist Craig Venter, who was the first gentleman to decode the human genome, and that was kind of our launching point to build into what human longevity has become today, where it's this comprehensive look at your full health picture. And as many of you know, the ability to diagnose and detect different diseases can be incredibly challenging and complicated. And so we've over years and with hundreds of millions of dollars of investments towards our algorithms and processes have been able to figure out a very consistent annual physical that makes sure that you stay ahead of the major diseases that are most likely to bring you to an early end. And so when we think about longevity, and we hear this term a lot these days, especially in the biotech space and the different utilities that word can bring with it, the human longevity approach is to make the best possible use of the existing technologies that we have today. And so, I think we've got all ends of the spectrums when it's talking about brand new technologies that are in R&D that should revolutionize the way things that are done, but also to use the tools like our genetic sequencing to, apply the types of treatments like cancer treatments that the efficacy is just much higher when you catch those things early. And so I just put a couple pictures of our San Francisco clinic to kind of give a sense of what we do. All of our machinery is in one roof, and it's a kind of a one-day fully comprehensive exam. And so with that said, I just want to invite anybody here who might be interested in learning more about human longevity to come say hello we've got a booth out there in the front room. But beyond that, I want to also just give this hopefully inspiring message to all of the founders and the forward thinkers in the room to remember that what we are doing here in our development of these health technologies does have a real world effect, and that there are people like myself that are on the receiving end of that, whose lives can really be positively impacted. And so, I know that we all run businesses, but I urge you to, think about what is truly best for the patients. And, I don't know that this is exactly the room that needs that reminding, but I also just like to say it because I know that it's a shared mission and vision that we all have about just changing the way that things are done for patients in the future. And so with that, I think I'm running up on time. If you have any questions for me, I'm happy to take them here, or I'll be out there in the front room. But thank you so much for having me as part of Health Tech Week, and it's been a real pleasure.
Thank you, Colin. Thank you. Any burning questions here? Otherwise, we have a burning question.
Okay.
I don't know if it's burning, but I'm curious. I mean, this seems to be a niche market, right? This is people who have lots of money who are going to come to you and get treated. Do you foresee that it's getting to the point that this is actually becoming a cost-effective way of doing healthcare, so that it would completely change the paradigm, and large organizations would say, hey, this is worthwhile doing?
Yeah, great question for one. And my answer to that is absolutely. If you look at just the genetic sequencing, like 10 years ago, it would have cost something like $10,000. And the first time to have it done 25 years ago, it cost billions of dollars. Now that test is somewhere in the ballpark of around $1,000 to have your full genome sequenced. And we expect that price will only continue to go down. And we're the long-term goal is to make this type of treatment accessible to everyone. And I think that there's both the appetite for it and the financial model to make it workable. Because just in the last 5 years, the cost of the service that we provide has gone down significantly, and that's even in the face of the inflation that's happened and the rising costs. So I think that we are trending in the right direction. And with a lot of these health technologies, there is kind of that, I hate to use this term, but trickle down effect of where it gets accepted at the kind of the higher end concierge style, cutting edge, and then it gets more ubiquitously accessible as time goes by. And that's a big part of the human longevity mission, is to make this widely accessible to billions of people, not just the select few.
Okay, thank you.
Thank you.
Thank you, Colin. Give a big hand. Okay, now up we have Dr. Leah Houston. And I think we can all breathe a sigh of relief because AI won't replace doctors. Uh-oh. But what if you're an administrator?
Hi, everyone. My name is Dr. Leah Houston. I am an emergency physician, and I also was trained at MIT in health tech and AI, and how we can apply AI to healthcare. And there's a lot of companies out there that are using it for biologics, for pharma, but there's not enough people out there actually using it for the administrative cost, which is about 30% of our $5.9 trillion healthcare system.
Hang on, Leah, we're finding your presentation.
Oh, okay, no worries. So what most people don't realize is that every single doctor, whether you are employed or whether you're a private practice, you have to go through this long manual process called credentialing that actually makes you verify whether your license is active, whether your DEA that allows you to prescribe controlled substances is active, whether or not you actually went to residency, whether you got a degree. And that 4 to 6 month process is manual, it's friction filled, and it's a big bottleneck to actually patients getting care. And I can go through it without the infographic, it's no worries. Oh yeah, okay. And so when you factor in the human labor, the lost revenue, the errors, the redundancies that go along with this process, which I will, it's partially, yeah. It's actually a $150 billion problem. And so that includes the actual human labor. So when you think about the administrative cost, this is mostly like payroll for dozens of administrators. And so if you look at our healthcare system, administrators actually outnumber doctors on a 10-to-1 basis. So when I started this company, our healthcare system was $3.9 trillion, and in only a couple of years, it's jumped up to $5.9 trillion. And so this is like a runaway spending, mostly due to some of this administrative cost. So what we're doing differently, and what's allowing this to become a more automated process, is that we're giving doctors a wallet of pre-verified data that allows them to own and store it from the day they graduate until the day they retire. So when they share it, it's automatically and permanently perpetually verifiable, because we're using domain-trained AI agents to actually go do that manual verification for you. So we can shrink that 4 to 6 months into moments. And why should you care about this? Who cares? Well, if doctors aren't actually working, patients aren't getting care. So you have a friend or family member who is recently diagnosed with a brain tumor, waiting for brain surgery. You have a neurosurgeon sitting on the sidelines, ready to go to the OR, but unable to for 4 to 6 months because of this problem. And so this will speed up the ability of doctors to move between systems, to get to the OR, to actually deliver care. So it actually is one of the few things that touches every fabric of the healthcare system. And so that's why it needs to be taken care of with automation. And so we actually have doctors upload their data. We use AI to extract the data. We structure it, normalize it, and then we actually have the agents go out and verify that data. And this is actually something that needs to be done repetitively for regulatory compliance. So it's not just something that people are doing because they want to or because they think it's important. It's because the federal government is actually refusing to pay hospitals and health systems unless they do this repetitively. And so right now, our go-to-market strategy is to really serve independent practices. Physicians used to be independent, and now they're more employed. And so a lot of these practices are outsourcing this overseas to people who are then manually doing this. So we're going to serve them first, and then as we scale up, we're going to actually serve hospital systems. And so we recently launched in September. We launched our wallets. We have over 400 doctors on the platform. We have LOIs signed with 6 systems, anywhere from 12-person gastroenterology group to a 700-bed hospital. And we can save those systems about, for around 1,000 practitioner hospital, we can save about $2 million a year in administrative costs. And for smaller practices, we can save $20,000 to $30,000 a year. And so this is the team. Mark is our Chief Product Officer, and this is me. And so if any of you guys want to talk about workforce automation, agentic automation in healthcare, how to get doctors back to work, how to get them to work and move freely, feel free to reach out to either of us, and happy to take any questions.
Hi, Leah. Good morning. This is Dr. Dipali Saxena. I'm a radiologist and I'm exploring AI in healthcare now. I had a question. When you first began this, like you are extracting a very private, personalized data that is regulated by a lot of authorities. So how did you first get into this space, and how did you manage to get that data from each institution, or how did you go about it?
You're a radiologist, you said, yeah?
Yeah.
Great. So actually legally, last time you were credentialed, you probably remember they actually had you sign a document saying, hey, you have to give us the right to check all of this stuff, but first you have to give us your data. They asked you for your credentials first. And so legally, the regulatory requirement is that you have to own and control your data already, and that you have to give permission for validation for the stuff. And when I say credentials, we're talking about everything from your background check to your procedure log. So for example, as an emergency doctor, I have to have had delivered babies in case somebody comes in labor in the emergency department. So they have to check and make sure that I've actually delivered babies before I'm allowed to work in a hospital. That's one example of all of these different things. And so legally, we're required to give the data anyway to them. So that's why we're taking the approach of giving doctors a wallet to store and verify their data in a perpetual way, so they don't have to keep continually doing this repetitive, redundant, manual administrative process of sharing their data over and over at each place. It's actually done automatically.
That sharing of data each time manually is overwhelming here, I said.
Yeah.
So
I mean, it's one, these administrative burdens are part of why doctors are leaving medicine, quitting, refusing to work, going into, non-clinical spaces. And so if we can reduce the burden for them, we can actually get them to actually be taking care of patients more. And so that's why I say people are saying doctors are going to be replaced by AI. I say administrators are more likely to be so.
Raise your hand if you have a question.
Great, I can repeat.
Oh, you need a
I can
microphone.
repeat
I'm
it.
sorry, we have rules here. Everybody gets a
I'll follow by the rules. Okay. So question, and how are you dealing? There's a lot of physicians in this country today that are qualified in so many ways, but they have international records. And so how are you verifying them, and how are you connecting with those international institutions?
So international medical graduates go through a process where they are, one of their credentials is ECFMG. So I forget what it stands for, but it's something for medical graduates. So, it's hard for the US government to discern whether or not your medical school gave you the appropriate training to be able to treat people here at the level of care that people expect here. And so they've basically indexed most of the global institutions, and the ones that they haven't, they actually have to go through a longer process to become ECFMG certified. And then even once you're certified, even if you've been practicing medicine for 20 years, and even if you were the dean of a hospital system in some other country, you still actually have to go through a residency here in most places. Now, there are some regulations that are starting to allow people to come in, but residency is the bottleneck. The actual training that you get as an OBGYN or as an emergency physician. And that's part of why we have a shortage of physicians. That's actually the main reason we have a shortage. It has nothing to do with number of doctors available. It has nothing to do with people who aren't capable and qualified. It has to do with this residency requirement bottleneck, and there's the fact that there's not enough spots. And so we actually need to also increase those spots. But also a lot of the doctor's time is being misappropriated to administrative stuff. So that's part of the slice that we're working on. But ECFMG certification is the credential you're talking about. Complex stuff. Very exciting.
Okay, if no other burning questions, we'll let Leah thank her very much. Warm thanks and applause. And then next up, we want to invite Albert Chen, founder of Vitalium, talking about scientifically proving energy healing. Maybe even heal some people today.
Hi, how are you? I'm Albert Chen. Thanks for having me. So I'm here to talk about kind of energy healing, and I want to talk about how I got into it. So about almost 30 years ago, I herniated a disc in my lower back doing deadlifts at the gym, and it gave me terrible sciatica. I had it for about 3 years. I tried everything to fix it. I went through the normal process of physical therapy and electric stimulation and all that kind of stuff, and nothing worked. And I ended up getting introduced to this guy from China that was able to not touch me, but he's able to do something where I could feel this like almost electrical pulse move down my spine, around my hip, and then down my leg. And about 30 minutes into this session, he told me to stand up and see how I felt, because my pain level was probably like an 8, like it was debilitating. And what happened was incredible. Like actually I stood up and my pain was completely gone, and I was in complete disbelief. It definitely wasn't like the first thing I was looking at. It was probably the last thing I was looking for, because it was something I just completely didn't believe in. But it worked, and it was just crazy. So it really changed the direction of what I thought was possible with the human body. So for the next about 27 years, I've been kind of researching and studying and finding energy healers around the world that could do these kinds of things. And I just realized that it's a very rare kind of like ability, and it's a very wide spectrum of practitioners of Reiki, Qigong, kind of like just general energy healing, things like that. So about let's say 7 years ago, I started training people, and I trained with the person that kind of healed me, and I thought it was kind of like amazing. And so I started training people and healing people. And so we've healed about 400 people of mostly chronic pain-related conditions, and some neurological things, some organ-related things. And I think we have a lot of insights and findings of like how this like system works, and it's pretty remarkable, kind of like the results that we're getting. So from a research standpoint, scientific standpoint, I think the thing that was over the last 20-something years, I've met with a bunch of different researchers. I didn't really think anyone was really kind of like a tier A level researcher until more recently. About 4 years ago, the Subtle Energy Funders Collective started and contacted me, and I started working with them on research. So I think the hardest thing in this field is that they're not able to measure mechanism of transfer. And that's kind of the energy that kind of leaves my body and goes to a healee. And because they're not able to find that, I think that's like the biggest thing that's holding this field back from being accepted in a more mainstream basis. But the thing that is starting to happen is we're getting kind of like more research studies happening kind of like over time. So each year, this thing is becoming more and more interesting to researchers and more acceptable. And if you're ever interested, there's a biofield science evidence map that you can kind of look at. This actually looks at all the studies that have been done over the last decade or two, just around kind of like the field, and kind of like even maps and shows what has positive results, what has mixed results, and what has results that have been non-significant. And the one area actually, which happens to be the area that I focused on, is called external Qigong, is probably the one that has the most positive results in terms of the study results. And so I'm working with the Subtle Energy Collective right now. We're doing a research study, Cambridge and Stanford IRB study. It's going to be a dual hyperscan, high density EEG reading. It's going to be on the healer's head and spine, and also the healee's head and spine. And what we're going to try to pick up the pain signal from a back healing. And just so you understand kind of like how it works, is I project energy into someone else's body. I can feel what's going on in their body, in my body, in the same place. So when I'm healing someone's spine, I can feel their spine when there's an issue in their spine in the same place in my spine. And then that's what I use to kind of diagnose and kind of like work my way through with the energy to kind of heal their spine. So I have a really good indicator, almost like a feedback loop of whether I'm actually in the right place, whether I'm actually how deep into the healing I've gotten, how finished or complete the healing is. So this is a study that's happening kind of like mid this year, and so we're excited to do this. It's gonna be a pilot study of about 45 patients that we're gonna be healing. We're recruiting for the study, so if you have back pain, you can apply to be part of this study. And separately, there has been a lot of work in this area called bioelectricity, where they're doing ion channel research. And so probably the most well-known person in this field that you should look into is a guy named Michael Levin. He's been studying its regenerative effects kind of like on the body. Another company that I'm working with is called BioDaVinci. They're working with bioelectricity gut lining repair. And I think what they're finding is that they're able to kind of modulate the ion channels, and they're able to increase wound healing. They're able to even kind of do limb regeneration on a frog, where a frog's leg normally doesn't grow back, but they're able to kind of create a concoction of bioelectricity and kind of like some chemical concoctions that are able to kind of help with the regeneration process. And I think the study that recently got published in December of last year, that was probably like the thing that tied it all together, was done by Lorenzo Cohen at MD Anderson, where they did a pancreatic cancer cell study, where they basically had a biofield practitioner work on mice and cancer cells, and they found that they were able to reduce the growth rate of the cancer cells in a pretty significant way. So I think this is the first thing that actually is tied kind of like the scientific understanding of kind of like and energy healing closest together than anything we've ever found. So I think we're excited to see that, like, going forward, there's a little bit of activity and motion here. So this is a conclusion of like what I want to talk about on the science side. If there's anyone that has like chronic pain or back pain or neck pain and wants to do a demo, I'm actually happy to kind of like do an energy healing demo with anybody. Anyone interested? Yeah, come up. I can do one at a time. What kind of pain do you have?
Just like neck stiffness.
Cool. Okay. Let me grab a chair real quick. Can you? This is going to be a short demo, but I think it's nice to kind of like do a little bit of an explanation of like kind of how it works. So what's the pain level now? Like 0 to 10? 2. 2? Okay. Let me know if you feel anything. What do you feel?
I don't know. Energy. It's like pulling me back. It feels like expansive.
So the energy training I do actually doesn't use your mind at all. It's purely physical. My training is all kind of comes from like a martial arts type practice. If you ever saw Karate Kid back in like the 80s, it's kind of like what that guy did to kind of like fix that guy's foot. And so all I'm doing is I'm not using any intention. I'm not using my mind at all. I'm actually just straining my muscles in a certain way to actually allow this stream of energy to kind of leak my hand. So I can move things around. If I move my hand, you can probably feel it a little bit. So the characteristics of the energy are kind of interesting. It typically feels like tingling or heat, a little bit of a magnetic, like a pull. So I can actually move someone off balance without touching them. And it was used primarily for martial arts to kind of identify targets, strengthen the body, and be able to kind of feel what was going on in someone else's body, know where they're kind of like, if you had like pain or you had like a damaged shoulder, I would actually use that information to kind of like to go after your shoulder if I'm in a fight with you. The healing thing was kind of like just a side thing. And there's a lot of different kinds of ways to develop energy, and the modalities are very broad. A lot of them are kind of like mindfulness-based or meditation-based or consciousness-based. My training is purely physical. All I do is actually, I hold a squat like this, and I basically hold my hand out like that, and it generates this like pulse in my hand. And if you guys want to try it later, you can feel it. And then I can feel what's going on in his neck. So I can actually feel the tension is a little bit, probably looser, I hope. And do you want to move your neck around, see what you feel?
Feels a little better.
A little better, okay. It's typically a 30-minute session, so we'll see what we can do in 5 minutes. Yeah, all I'm doing, so my hand is about 5 inches from like your neck right now. And I'm trying to feel kind of like where you have tension and whether I can actually use the energy to kind of like break through it. And I think people used to say that the meridians used to be blocked or things like that. And that was like the reason why, you know, the energy kind of had to like pass through and like break through, kind of like that blockage. I don't know if there really are meridians or not really meridians. I actually think that maybe, you know, thousands of years ago, they didn't understand human biology, and potentially what we're doing is we're affecting the nerves. So I think that's the area of study that we're trying to like understand what's going on. All right, you gonna try moving your neck around again?
Yeah, feels better.
How much better?
Yeah, it's loose. I got some cracks in there that I haven't been able to get in a while.
Okay, we'll do a little bit more. We'll see. Okay, I'll see if I can get it down to like a 1 or a 0. Do you have any questions?
Do I keep moving around? Like,
you can stand still for now, and you can move around once I'm kind of done. Because when you move around, it's harder for me to sense kind of like where the damage is. And sometimes like this healing can be really quick. It's just like one little thing kind of holding it back from being able to kind of like be healed. Sometimes it's more complex. And I think one question I get a lot is like, how long does it last? And I think it really depends, because a lot of times what's going on is your neck pain or back pain comes from some kind of damage to a disc, and that disc is kind of hitting a nerve. And although I'm able to maybe potentially help repair the nerve, I don't think I'm able to repair the disc. And so people will go running again, or kind of like it could come back again. So ultimately, what I suggest is we can do a number of sessions to kind of really break it down. And then I teach people how to like develop the energy themselves so they can train themselves. So you can train to kind of heal yourself. It's kind of like a micro healing kind of on a day-to-day basis. It's not as fast as someone else kind of directing the energy directly into that area. But you can train yourself, and then over time, it kind of like breaks through. All right, you want to test it again?
Yeah, a lot looser. That's nice. That's
yeah.
Good.
All right. Okay. A little demo. Typically, it's like a 20-minute, 25-minute like session. So yeah.
Yeah. Well, we actually have a few more minutes, Albert. So if you wanted to do another one or just go into QA, I think Dave right there. Dave is needing some. He's been hard at work. Everybody, give Dave a hand. And you two have never met before, just in case somebody thought that might have been a plant.
Yeah. Okay.
And while you get ready, while you're preparing, I have a question.
Yeah.
Because I've seen this work empirically, lots. And what are your theories, and what are you measuring specifically to? You may have gone over a little bit of this, but just wanted to ask in that realm.
Now let me ask, what's your pain first?
I've got chronic lower back pain, and I've got shoulder pain that's actually got an actual injury.
What's the shoulder pain? Is it like a
tendon?
Okay. So I'll work on that. So torn tendon, it's a rotator cuff tear?
It's already getting too hot. I've been doing Tai Chi since the 80s. So
Oh, okay. Got it. This is typically a more complex healing, because what I have to do is I have to kind of find the pathway that kind of goes from your neck down to kind of like your, I assume it's the rotator cuff? Is that what it is?
And rotator cuff and biceps insertion plug, which actually completely torn. So now
Completely torn.
It's that tore about a week ago, and now it's just rotator cuff.
Okay.
Feeling a ton of heat.
Okay. So this is typically not as simple, but we'll see what we can do. I think like, whether I'm able to kind of fully heal it or today, I'm here just to try to give you a demo to see if you can feel a difference. But what happens is almost all my healings start from the spine. And there's some pathway that goes from the spine down to a limb, an organ, up into the head. And I just need to find that pathway. So I feel what's going on is that we're basically we're working down like a nerve pathway. And the energy is somehow able to either repair or affect and somehow kind of like change that like pathway. So if you were to give me kind of like a discovered score 0 to 10 for your shoulder, what would you tell me before when we started?
Probably about a 4 or 5 or some movements I couldn't do.
4 or 5, okay.
It's a lot better.
Yeah. So when I put energy into his shoulder, I can feel in my shoulder a pathway kind of like light up. And then when I feel that there's something that kind of is almost like stuck in his shoulder, I'm able to just try to work on that. I try to like just put more energy in the area, try to break through it. Okay, do you want to test it?
Yeah, wow, it's a lot better. It's about a 2. Yeah.
2? Okay, hold on, let me see if I can get it down to a little bit lower.
Actual partially torn supraspinatus tendon, so it's quite impressive. I couldn't really do this before.
Yeah, I should have you test it. It's interesting, like for some reason, we're able to affect torn rotator cuffs, and it's something I didn't think that we were able to affect. All right, you want to test it again?
Yeah, wow. I want to say 1, but really it's a 0 actually. That's
A 0
impressive.
or 1?
So what's a 1? You know. A 1.
Okay, hold on, a little bit more.
But I couldn't do this before. I couldn't lift my hand before. So.
So right now we have just hundreds of these healings. We have stories. We're trying to collect data for like how long these healings last and what the efficacy is. It works pretty reliably in terms of like how often I get initial kind of like a pain reduction. And then whether it lasts, it kind of depends on a lot of factors. Mostly we need to put more energy into it to kind of like to get deeper into kind of like the healing. All right, so how are you now?
Yeah, it's I feel a little clicking there, but it's it's definitely a 1 or a half or something like that.
1 or half, okay. Okay, just
my shoulder's much more open. I was holding it. I was guarding around here, and stiffness feels like it's gone.
okay. Okay, one last test. See how I feel.
Wow, that's impressive. I mean, I actually have MRI evidence of tear over there, and I couldn't do this before, so that's impressive. Thank you.
You're welcome. Yeah, so there's something here. I don't think I fully understand what it is yet. I think we're trying to like research it and understand it better, but we're able to affect people pretty reliably, and hopefully we can figure out how this is working and what's going on, and we can help more people. So thank you very much. Oh, yeah, any questions? Sorry. Can you, Mike?
Mike is flying in.
Thank you for the presentation. I'm wondering, I've practiced some of this like Qigong and stuff. So what do you practice to increase your like healing energy in your hands? And what do you feel exactly in your hands when you're doing that?
So Qigong is a very broad term. Thousands of different practices, all completely different. My guess is the kind of a qigong you do has like movements or something like that, or that's like the typical like Tai Chi-ish kind of like practice. My practice actually is purely one thing. We just hold a squat like this, and that's it for about 40 minutes a day. And
Your hands are how?
my hands are typically like this.
That's it. Whoa.
But there's a little trick. You kind of need a little bit of an activation in your hand with like this electricity. If you don't get that, it just takes a long time. When I mean a long time, I mean like 20 years to kind of like be able to develop like enough power. But if you can get this like activation kind of going with someone else that's got the energy, it jumpstarts the process. So for example, I can train someone new now. If they train every day and they kind of come to class like weekly, it takes maybe about 6 months for me to get them to healer.
Oh,
So it's much faster than my kind of like 20-something year process.
wow. And all they're doing is this one?
There's a little bit more complexity than that, but that is just building power. And then you have to learn kind of like sensitivity, how to use the energy, how to direct the energy. The energy direction it doesn't use my mind at all. It really is just the direction of my hand. So if I want to get the energy to go down, I just angle it down. If I want it to go left, I angle it left. That's the only kind of like change I make. Outside of that, I'm actually taking a feedback signal in my body for what's going on when I project the energy in, and then I can feel what's going on in my body, in what's going on there, but I can feel it in my body. And I use that to directionally kind of like move the energy, add more energy, or move it back to find kind of like the right place where the damage is.
Okay. But it's a little bit similar like Reiki or like magic hands, but if you like sticky hands.
It is a little bit like that. I would say that all the modalities have so many different ways of developing energy. I think the one thing that's different about this modality that I practice is the power level. And the power level is really important for healing. So you can get like sensitivity and you can get things that kind of work, but to get power, it's all physical. You actually need to kind of like create strain in your body. And that's kind of probably the one difference from what we do. Any other questions?
I actually have just a quick one.
Yeah.
Do you think when you are doing it, is it in the same field as Reiki? And when it comes down to the squat, is the whole process more physical or mental or spiritual? Are they all the same?
So it's not mental or spiritual at all for me. It doesn't use my mind at all. Actually, if you try to use your mind, it works against you. So it's just purely physical. All I do is hold the squat and I'm building this kind of like feeling under my hand. And when I heal someone, I just literally turn my hand sideways. And that's the only difference. Wow. So it's actually a very, very simple practice. Almost anyone can learn it. It's not like anyone's born with any special skill. It's just whether you want to put the time into it and whether someone's willing to kind of train you.
But it's still like an abstract yet simple connection that you're making with the next person, like if they're in belief, right?
There's no belief required. Like actually, I typically heal only skeptics that don't believe in it at all. So I actually don't like healing people that believe in it because they start wandering their mind of like, believing different stuff.
Awesome.
Yeah.
Cool. Thank you.
All right. Thanks a lot.
Thank you, Albert. Thank you for bringing the science to what a lot of people are skeptical about and believing in, but bringing that empirical data and going deep. Thanks a lot.
All right.
Killed it.
Yeah. My hand's all cold now.
Everybody, we're going to have a little break, midday break. We have lunch for folks, for speakers and VIPs and folks with the blue wristbands in the speakers lounge there. That should be open any moment. We'll be back actually at 1:40. We have our next session at 1:40 p.m. So we got about 35, 40 minutes here to stretch your legs and grab some nourishment.
There'll be pizza coming through.
Sula.
Okay, folks, in just about a little over 5 minutes, we'll be starting our second half of our day. 2 o'clock on the dot. Please be back in the room in your seats. Ladies and gentlemen, we're going to get started here. Please come on back to the main stage. Let's bring the voices down. Come on out. We've got a great presentation here. Okay, everybody come on back to the main stage. We've got a presentation coming up. Who had it last? It's not in my pocket. Okay. And we've got your slides in the back now? Give us a second before you go on. Let's bring up your slides. You got Aubrey's slides up? I thought so, Chief. Okay, everybody, we need production back in the main room here. Can we have production back in the main room? Eric, can you go up the line?
All right. Check. All right. Ladies and gentlemen, HealthTech Summit, final day. I know we have a lot of people in the VIP lounge snacking. I just want to let you all know we have probably one of the most significant longevity speakers that's about to begin. So if you can hear my voice and you're anywhere around the venue, I would invite you to come and grab your seats because we are about to have Mr. Aubrey de Grey. And for those of you who are maybe not familiar with Aubrey, I've had the pleasure of getting to know Aubrey over the last few years as someone in the longevity space myself. If you haven't been paying attention, longevity is big now. And it's because of people like Aubrey that it is, because there's a very small group of people that were talking about this for decades. And I think Aubrey was probably one of the first. And we're in this era now where everyone is talking about, is it possible for us to live to 120 or 150 or 200, or what is the limits? And this is something that I think, I'm not to steal your thunder because you're about to do the talk, but he started talking about this way before everyone else. And now is literally just sort of traveling around the world, propagating this idea, talking about how we're going to research it. And it's a really great opportunity for those of you, if you have not heard Aubrey speak or not familiar with this idea of longevity escape velocity, I would encourage you to come and take a moment to listen to this talk. So I know we have people scattered around. So without any further ado, ladies and gentlemen, you guys have been kind of a quiet crowd, so I'm going to ask you to make a little bit of noise here for Mr. Aubrey de Grey.
Oh, wow. And Elias, I think I found my replacement MC, so thank you for jumping up there.
Anyone would think you'd done it before. So thank you all for turning up and for coming back from lunch. It's great to be here. Thank you so much, Steve, for asking me to speak. So I know that there will be some people here who are quite familiar with what I do and what I have done, and some people who are not. And I've only got 20 minutes. In fact, according to this, I've got 19 minutes and 50 seconds. So I'm going to be a little bit rapid fire, but this is what I'm going to talk about. And I always start with this question. I always say, what is the problem with aging? Why is it so difficult? Because, 200 years ago, we had this situation where literally more than 1/3 of babies were dying before the age of 1, even in the wealthiest countries in the world. And, that doesn't happen anymore. And that's because we figured out the basis of what we now think of as modern medicine. And so, a lot of it's really easy, just figuring out that hygiene was a good idea is, saves an awful lot of lives. So people, you need to ask the question, what is so different about the health problems of late life that means that the approach that we've taken that's worked so well for infectious diseases, for almost all infectious diseases, doesn't work for these things? And people don't ask that question enough. And the reason they don't is because they think they know the answer. They think that it's just the complexity of the situation. Don't worry, you're not supposed to be able to read this slide. The point, of course, is that an awful lot of things go wrong with us late in life, and they go wrong at more or less the same time, and they interact and exacerbate each other. And so people think, well, this is all it's about. The complexity has just been overwhelming, and therefore we've not been able to make progress. And that is part of the answer, but it's not the main reason. And it's important to get to the main reason, which is basically this. People are wrong in the way that they think about the answer to this question: in what ways can people be sick? Most people, in fact, almost everybody, even biologists, even medics, they will answer that question in a manner that pretty much can be set out in this table. They'll say, well, there's infections, that's column 1. And then there's genetically inherited diseases, column 2. And then there's the big one, the chronic progressive conditions of late life, like almost all cancers, Alzheimer's, heart disease, all the things I put up in ridiculously small font a moment ago. And then most people will say that way out in the stratosphere, I'm going to try and use this clever pointer. Is it working? Yeah, it is. There you go. I love these pointers. Is this thing called aging itself, which consists of these rather poorly defined things like, frailty. And it's obviously bad for you, but the prejudice is that it's just not a disease, and therefore it's so not a disease that intuitively it's kind of off limits to medicine, even in principle, which is complete nonsense. And the only reason people think that is because they haven't bothered to come up with a proper, clear definition of what aging is. If you ask 10 people what aging is, you will get at least 11 different answers. It's completely ridiculous. Because it's been the major preoccupation of the human race for the past, 3 millennia. And yet, here we are. So this is my definition of aging. It's the combination of two processes. We have a process that goes on throughout life where metabolism, which simply means the normal operation of the human body, the stuff that the body does to keep us alive from one day to the next, metabolism causes damage. Damage is simply a bunch of changes that happen to the molecular and cellular composition and structure of the body throughout life as consequences of metabolism. And the reason I use the word damage to denote those changes is because of the other process, the right-hand one, where damage is bad for you. Damage is only bad for you late in life because the body is built to tolerate a certain amount of damage without significant decline in function, either physical function or mental function. But eventually, there's more than that. There's more than that threshold amount, and the pathologies of late life emerge. That's all aging is. It's the combination of those two processes. So what that means is that the table I showed you earlier is in one very, very, very important respect. The thing that's incorrect is not any of the columns. If you look at the columns, you will see that they're exactly the same as they were a couple of slides ago. But what I've done is moved that big, thick black line. It's no longer between columns 3 and 4. It's now between columns 2 and 3. What is so important about that? Well, two things. First of all, it answers the question I began the talk with. It tells you why the diseases of late life have been so much more resistant to medical intervention than the infectious diseases that hit us early in life. I said it's not just the complexity. What it is they're just completely qualitatively different phenomena. The things that happen in column 3 are inherently, they're self-inflicted. They're consequences of having been alive for a long time. Whereas the things in column 1 obviously have an external source. But the other thing that moving the black line tells you is even more important. It tells you that there is no meaningful difference at all between column 3 and column 4. The only difference is semantic, that the things in column 3 are the aspects of aging that we've chosen to give disease-like names to. That is all. That really is all. And of course, no one's going to say that column 3 is off limits to medicine. We spend a rather large amount of money trying to fix it. But that means you can't say it's column 4 either, which is nice. And so then, why is all that so important? Well, fundamentally, it's because this is where we are wasting all our money. At the moment, the vast majority of the medical budget of the Western world is spent trying to keep sick people alive and when they're old. And the reason that is what they're doing is because people make the mistake that I've just outlined to you. They pretend that the health problems of late life are like infections and that they can be cured like an infection, which is complete nonsense. And this is what it ends up trying to do. If we think about, if we look at my definition of aging here and we ask, okay, what is the goal? The goal is to separate metabolism from pathology, right? We want to allow people to carry on performing metabolism, in other words, being alive, without getting sick. So we can do that, in principle, by separating damage from pathology. And that's what geriatric medicine is all about. And it's obviously brain dead. I mean, it's just so obvious. Because, the damage is continuing to accumulate, So if you just ignore it and try and deal with the consequences of the damage, then obviously that treatment is going to become progressively less effective as time goes on. So completely brain dead. Now, I, of course, am not the first person to realize this. It was probably more than a century ago that a few people started to get the idea that this wasn't going to work, and that if we really want to separate metabolism from pathology, we should intervene at an earlier point in the chain of events. And that earlier point, of course, would be to make metabolism run more cleanly. In other words, to break or at least weaken the link between metabolism and damage. And that's where the whole field of gerontology came from. It was inspired by the fact that in the living world, we see a huge variation in the rate of aging between different species. So, maybe if we figured out the basis of that, we could use that to develop therapies that would slow down the creation of damage and thereby delay the age at which you get sick, which would have been great. But that too has been a complete fiasco. And this is why metabolism is rather complicated. Anyone here who's ever written software will immediately see that this is the ultimate nightmare of uncommented spaghetti code. There is absolutely no way on God's earth that we're ever going to be able to disentangle this and stop metabolism from doing the thing we don't want it to do, the creation of damage, without having unintended consequences. The creation of damage is just too inextricably intertwined with the things we need metabolism to do. So that's not going to work. But luckily, there's a third approach, which somehow or other escaped the entire field until I came along 25 years ago and pointed it out, which is you can separate metabolism from pathology without breaking either of these two processes, the creation of damage or the consequences of damage. What you can do is get rid of the damage. You can separate the processes from each other, which is what preventative maintenance is. And of course, we know that it works because we do it already very successfully on all man-made machines like cars. This car obviously is more than 100 years old. It's working every bit as well as the day it was built. Why? Not because it was built to last 100 years, not at all. It was built to last like 10 or 15 years. But here it is, and that's because it's had very thorough preventative maintenance throughout its existence. There's no reason whatsoever why we shouldn't be able to do the same for this machine that we call the human body. So that's what I try to do. Long ago, in gerontological prehistory, I came up with this idea and said, well, what does this actually mean? We've got to characterize the damage. We don't really have to understand much about the process of damage creation, because we're not proposing to interfere with that process. We do, however, have to characterize the damage itself in order to get stuck in and eliminate it. So what I did was I came up with this classification on the left-hand side of this table, which is basically all the types of damage that the body does to itself. And I came up with ways that we might be able to repair those various types of damage. That's the stuff on the right. And it's gone pretty well. All of these things have progressed over these 25 years, and they're being pursued in the private sector now, all of them. So that's pretty good news. Also, in academia, the whole thing has become mainstream. Many of you who that came out in 2013 called The Hallmarks of Aging. Couple of figures from that paper. It's by far the most highly cited paper in the whole of the biology of aging this century, and rightly so, because it's basically become the Bible of the field, and it's essentially a not terribly good restatement of what I said a decade earlier. And I'm very gratified that I never have to justify this way of thinking anymore, whereas in the 2000s, it was hard work to get people to even believe that the concept was scientific. So I'm going to spend my last 9 minutes talking about what we do at my organization. I lead a nonprofit called LEV Foundation. LEV stands for Longevity Escape Velocity, which I'm not going to have time to explain. But the idea is that we are interested in implementing this whole approach. In my previous two organizations, I was focusing mostly on developing the more challenging components, in other words, addressing the more damage, so that we didn't end up fixing the easy ones and not the hard ones and actually not getting much of a result. And that's gone all right. As I say, these things have moved into the private sector. We spun out half a dozen startups. But then you've actually got to put the things together. And, because we're trying to manipulate this machine called the human body that we have a very poor understanding of, it's very possible to have surprises when you put things together that individually seem to work. And so we started to do this. 3 years ago or so, we started with 4 treatments, all of which had been reported by other groups to extend life in mice, even when you don't give the thing to the mouse until they're already in middle age. You can see them listed here. I don't have time to go through all the details, but the key goal was to demonstrate that we got an additive effect, that when you gave these mice more than one of these things, that you would get a bigger life extension than if you only gave them one. And actually, rapamycin is kind of not really part of the experiment. It was kind of a positive control, because we know that rapamycin works in mice, even when you start late, but we also know that it's going to be very, very much less effective in humans, because it works as what's called a calorie restriction mimetic. And anything in the calorie restriction realm always works less well in humans, whereas damage repair may very well work just as well in humans, if not better. So the other 3 were very much damage repair interventions. And yes, we got this additivity that we were hoping for. At least we did get it in females. What you're seeing here is the Kaplan-Meier curves for these things. So a Kaplan-Meier curve is simply a graphical representation of how long the individual mice lived. The x-axis is how old the mice were starting when the experiment started, when the mice were, I think, 19 months old. So 580 days or something like that. What the hell is all that? I didn't do that, but anyway, thank you so much. Anyway, so yeah, that's the x-axis. The y-axis is simply the proportion of the mice that are still alive at the given age. So clearly the curves go down to the right until all the mice are dead. And each curve is a different treatment group. The thick red line is the group that got all 4 of our interventions. And the thick blue line is the group that got none of them. So that's pretty good news. The interventions worked. But the important thing is that the other lines in the middle are the groups that got some but not all of the treatments. And as you can see, they're in the middle, which is what we wanted. It means that when you have all 4 of these things, you do better than when you don't. So we're very happy about that. What we're not so happy about is the fact that the magnitude of the benefit that we got was only a few months. We were able to make the mice live maybe 4 months longer than the control group. And, we can already do that with calorie restriction in mice. So, it's not particularly eye-catching. The goal that I've given ourselves, the stretch goal, is to get 12 months. So 3 times the effect size that can be achieved with calorie restriction. And that would totally blow the field into smithereens. Every single expert in the world would say, yes, we are in a different world now. And that's what I think we need to do in order to wake the general public up and get the attitude to aging in the wider world to be the same as it was 6 years ago when this new infection came along. And to take the thing seriously and throw proper effort at defeating it. That might happen if we can get sufficient progress in mouse aging to show that it's plausible, which at the moment most people don't think it is. Males were a bit more complicated. Now, of course, it's very important to actually extend the healthy part of life rather than just keeping sick old mice, frail mice alive for a longer time in that bad state. The good news is that that's impossible, but we still need to check for it. And so that means we did a whole host of different measures of the health of these mice at various time points. Very wide variety of things. This is something we did not have to invent because there have been thousands of studies done over the last century in mouse aging and the ways in which they can be in which they can be measured for their health have been very well established. So we just did things that everybody knows how to do, and that went pretty well too. But what really matters, and this has happened again. This is some of this you can't see because the conversion to running on a PC has messed up the font. But anyway, basically what I'm showing you here is what we are thinking of doing in our next experiment. Because we got additivity, but we did not get the magnitude that we're hoping for, our conclusion is that probably we need to do more things at the same time. We did, as I say, 3 damage repair interventions last time, plus this 1 positive control rapamycin. This time we want to do 8. The first experiment was already really big and really expensive. It was 1,000 mice. This one's going to be 2,000 mice. And, we're pretty hopeful, but it costs a bunch of money. We need basically $6 million to do this experiment. And, we're having trouble raising it, but I'm trying hard. The good news is that this can be done now, that we can actually design such an experiment. 3 years ago, when we started the first experiment, RMR1, we couldn't have done this because there simply were not enough things that had been reported to actually work individually in mice. Whereas during those 3 years, a torrent of reports have come out showing the effectiveness of a wide variety, a very diverse range of other things that are, again, mostly in the damage repair paradigm rather than slowing aging down. And so we are pretty hopeful that this experiment will achieve this dramatic breakthrough relative to what's been done in the past and really kickstart a proper war on aging. Now, of course, this conference is supposed to be about AI, at least partly, so I thought I would mention that we have a bunch of friends in the AI community, and some of them got together and they created a chatbot, an AI agent, which is called Aubrey, and which genuinely, imitates me. It even imitates my stupid, unintelligible British accent. And it's actually not embarrassing at all. I mean, it doesn't give exactly the answers that I would give, but it's pretty close. So, go and have a play with it. It's really rather splendid. We've also got a crypto token that was launched by the same people about 6 months ago. And, the more people buy it, the more money we get. We get money from all those transaction fees. So that's one way that we're trying to fund the next study. And it's got fantastic graphics. We've got actually, we were able to get the people to do a completely pro bono redesign of our website, which is in progress and should be launched fairly soon. Our website does not look particularly elegant right now, and that will change. So I'll stop there because I've only got 18 seconds left. I'll just mention that, well, first of all, obviously there are some people up here that I would very much like to thank. Donors in particular, without whom none of the work that I've told you about could have been done. For those of you who want to know more about the science, of course, you can always email me. There's my email address. But we also published a paper last year that is a kind of review of the motivation for all of this and goes into a lot of depth about the science. And there's a QR code for anyone who contribute to this work. So thank you so much. And I'll just put that up. And I don't know whether there's any time for...
I wish there were. Well, first, a big round of applause. Aubrey, thank you so much. I appreciate you speed rounding this. We'll have to do an Aubrey day.
Absolutely.
Okay. I can
totally do this for a day.
Okay, awesome. Well, I think we can get the crowd.
All right. All right.
So thank you all for coming. Aubrey, if you'll be around, just invite people to come up and say hi. We'll just take conversations. If you want to have conversations, we'll go into the front room with those. And then if you want to hang out in the speaker lounge, certain people can go back there. But if you're in this room, please keep your voices to a minimum. Next up, let's bring up our next speaker. Okay, we've got Eche. How do I pronounce your name?
AJ Connect.
AJ, like AJ, like none of the letters in your actual name in English.
Yeah, it's
American.
deliberately chosen like.
Okay, AJ. Okay, AJ, come on up. We have your slides coming up. As soon as you see those, you can get started.
Sure. Hello, everyone. We're going to talk about decreasing birth rates and how to conquer that with decentralized AI. So in the world today, we're facing a fertility crisis where previously 5 women in the 70s, the birth rate was 5 per 1 woman. Now, to keep the population replacement rate, we have to have 2.2 births per woman. US is well under this rate by 1.6, while other countries like South Korea, Singapore, Japan are also dealing with low fertility rates. The problem is multidimensional, and it does not require one solution from a single stakeholder. It requires multiple solutions from different stakeholders. Could I have the slide? Is it possible? Okay, thank you.
Why didn't you ask?
Well,
I'm just joking. Go ahead.
Okay. I think you have to press the present mode. Steve, press the present, please. Yeah. Yeah. Thank you. Yeah, so this was what I was talking about. The current rate in the US is 1.6, which is well below 2.2 population replacement rate. And we have seen a steep decrease, which we call infertility crisis all over the world. But the question is, why do people have less children? So there are multiple challenges that we're facing. One is the social changes, such as a lot of people are concerned about the political instability and more technology intervention also leads to some of the meaningful relationship development. People have difficulties in finding partners, and just in crowded cities like New York and San Francisco, the housing costs is so much that adults over 18, 30% of them live with their parents or either financial or cultural reasons. And childcare costs are also providing another dimension problem. So the scale of the challenge, when you want to have a child and you try for a year, that's when we call you're facing infertility. So 1 in 8 couples face infertility challenge, and according to WHO report, this is 1 in 6 adults over their lifetime face infertility. Now, as we discussed, the women also prefer to bear children at a later stage in their lives, and that's why you'll see the increase between 35 to 39 years old childbearing age. The fertility journey is not easy today. The cost per IVF, which is the go-to point, varies between 15 to 30,000. And when you go to surrogacy, you choose someone else to carry your baby. That starts around 150K. In the US. And IVF, although it's the first go-to place, the probability of treatment failure is more than 50%. There are social constraints in talking about infertility, and most of the women prefer not to talk about it. That's why we end up in around 30% only, and I think that's an optimized figure, seeking medical help. Now, when we talk about these figures of costs, 58 million Americans who are underinsured or uninsured are probably away from considering any type of artificial reproductive technologies. Most of the problem is also due to care coordination. There are multiple stakeholders that we need to address their problems to find a solution that works for everyone, and incentives should be aligned. While delayed childbearing comes with maternal and fetal health risks, it also adds a profound mental health barrier, while anxiety and depression increases in women and couples who are trying to conceive. The mental health aspect results with 30% more cases in psychiatric diseases. Regulatory barriers is problems for insurers and also for providers, and employers face self-paid incentives where poor health outcomes don't pay the cost. And these are some figures around 25 billion total annually. That is the employer spending. Why do they do that? Because part of benefit package and the retention of the employees. So 15 states mandate coverage. It's also increasing. California is by far the safest place still in the world to do it, although expensive. The law is changing in California healthcare, which makes surrogacy more friendly. So although insurance coverage is increasing, it's still very limited with the consideration of how many IVF cycles end up in success. And the regulatory framework in different states does not add to easing the solution. So what's going on is there's fragmented healthcare system, which is also where private clinics are suffering patient retention, resource burnout, and dealing with regulatory compliance. The ecosystem has multiple providers, as you can see, not only just payers, healthcare providers, employers, and the government arm, but a lot of private, nonprofit, advocacy, research groups, and there is no one fit solution for everyone. Adoption, surrogacy, digital health tools, these are all used in the ecosystem. So what I'm proposing is an AI orchestration agent for the optimization of the patient journey. Whether you use the wearables or patient data or provider data, it comes in to the system. A compliance AI agent is able to check the validity and also data provenance along the care system. Interoperable standards with FHIR makes the patient data communication much easier, and provider matching with medical and non-medical providers is essential for the patient because the journeys are multi-months and multi-years sometimes, especially when you consider repeated IVF cycles. So the value and the solution is not optimization, but it's orchestration of multiple angles and continuous improvement. So if you imagine the patient experience, they should be able to receive the care and the provider whenever they need it and at the exact specialty that they need it. So this needs a combination of complaints, ICD-10 diagnosis, and then their insurance coverage, the PT numbers. It's a system where a lot of interlinks needs to be done, and I propose a personal AI concierge to follow up through the patient's journey, which makes it longitudinal and not a point solution. Responsible AI, as you know, the principles is a necessary and must, and while we're using the AI, some of the boundaries, I think, in any interaction with human, but also specifically in reproductive health, the unauthorized access or emotional dependency. If your AI concierge provides you emotional support at the same time, well, the app monetizes you, well, that's not what the app should do, because that's not for the benefit of the patient. And the app is not to replace a clinician or provide a diagnosis, but improve patients' education in order to support the patient throughout his or their journey. So what I offer is for clinics, employers, and for payer contracts. And that's why the go-to-market, I believe, should be clinical and patient combined application where they both use and it's reimbursable, but it's all patient control, opt-in, opt-out. Then it scales to employers once the clinical benefit is proven, and then the payers, and then global standard or interoperability standards allow it to be used global. So when it comes to fertility and reproductive health, which I do not, again, yesterday I said it's not about women's healthcare only. The question remains, how will we shape the next generation? Thank you very much. And if you have any questions, I'm here for the rest of the day.
Thank you, thank you. Okay, next up, we have, okay, Mina, you ready? Oh no, I'm sorry, we're actually going to Vicky. Way to confuse folks. Vicky, you ready with the panel? Okay, we're lost now. All right, bear with us for a second. No, it is Mina. I don't know why it's wrong on the schedule. So Mina, Amit, Jessica, come on up. And yes, yes. Do we have can we get their thing here? Do you know which way it is? Bring up mics. And we have Amit. Yeah, he's right here. We have another microphone. Okay.
Testing. Awesome. Hello, everybody. Welcome to our panel discussion. We're going to talk about the future. So this is a science fiction panel. Nice to meet you, Amit. We didn't have a chance to chat, but that's where you ended up in, science fiction panel. So in the name of this panel, we have a reference to a science fiction movie, Minority Report. So the way we're going to use science fiction is it's only a springboard to help us jump into distant futures. And we're going to look at what technological advantages we might have in those futures and what does it mean to the healthcare industry. So that's the plan for this panel discussion. My name is Minna Holopainen. My company is Medix Biotechnologies, where I'm a co-founder and chief marketing officer. And I would like the panelists to introduce themselves next. I'm curious about what's your connection with AI. I know all of you have it. And what's your favorite science fiction movie or book? Let's start with you, Amit.
Thank you so much. Very nice being here. Thanks, Stephen, and all of you. My name is Amit Badlani, and I'm mostly been at Stanford Research, where I started my journey with AI. And it actually happened accidentally. So we'll maybe cover some of the lessons that I learned, and I'll try to weave those in to this panel. But my favorite movie, science fiction, has been Matrix. And followed by that, it's been Minority Report. So this is really perfect.
Awesome. Risto, why don't you go next?
Yeah, hi. So I'm Risto Miikkulainen. I'm a professor at computer science at the University of Texas, Austin. And I'm Hookem, yes. That's why I have the logo here, cow. All right. So I've been working on AI for my whole career since the 80s. And it's like being a kid in a candy store now. I mean, everything we dreamed of is happening now, and it's wonderful to be part of it. My favorite movie hands down, was 2001 Space Odyssey, because I wanted to build HAL, but do it right. And this is pretty much exactly what's happening. HAL was schizophrenic or mentally ill because he was given contradicting instructions and it was a logical machine. And now what we have in AI is neural networks. They're not necessarily logical. They can deal with contradictions just fine. As far as book, it's Foundation by Asimov, because there's this aspect of psychohistory that you could actually predict what people do. And we are close to that now as well. So the science fiction is preceding the science, but I think it's coming true.
Jessica.
My name's Jessica Radley. I'm the CEO of Nectome. Come from an AI background as well. I've been working on machine learning systems for many years for natural language processing. Of course, now I'm in the end-of-life health tech section. In terms of sci-fi movies, I guess I want to push back on the prompt a bit. I feel that our sci-fi is somewhat lacking. We, in general, have a tendency to produce dystopic and negative media. And I think this colors the way people think about the future in a rather negative light. So I would say if I have to pick something, I'd go for some of the more hopeful tones of the early Star Trek. I personally would like to see a future that involves striving towards superabundance and meeting the needs of all of humanity and reaching the stars and other sorts of perspectives and things.
Thank you, Jessica. Thanks, all of you. I would also caution you to be aware of the universe of meaning that comes with the science fiction as a framework for this conversation. So it's often very dystopian, and we don't have to go there. In addition to the looking to the future, I would like to start with a couple of definitions of AI. So maybe 18 months ago in one NVIDIA keynote, Jensen Huang had this cool timeline of AI development from all the way from machine learning to generative AI to agentic AI, which is kind of where we are, reference to a previous company. then artificial general intelligence. What happens after that? So I'm inviting Risto as an AI scientist to give us definitions, working definitions for these discussions for artificial general intelligence, but also superintelligence and singularity. So after that, we're going to explore possible futures for healthcare industry. The way I'd like to have this discussion is you not to wait for your turn, but jump in. But I also invite you to participate in that conversation.
Yeah, so the definitions are not uncontroversial and they are different for different people, but these are just working definitions so we can talk. So I think AGI could be construed as being general intelligence in the sense that humans are generally intelligent. They can do music, they can do poetry, they can do math, they can do literature. So having AI systems that cover basically all of these human endeavors, that would be an AGI. And superintelligence then is doing it better than people are doing it. And of course, that's already happening. They do payroll better than we do, but reaching superintelligence in many different areas is really the goal. And then the singularity would be runaway improvement like that. The AI itself starts to self-improve without having humans to program it to do it. And that could be a singularity point when that starts happening. But again, there are different aspects of it, different areas, but those working definitions, I think, is something we can run with.
Okay, thank you, Risto. So I'd like to start with Amit. What do you think the industry, healthcare industry, and everyday life, health, and longevity looks like in the age of AGI?
Yeah, so I think what I see right now, I think you pointed out, we're in that age of agentics, and then Risto talked about AGI, right? So I feel like with respect to AGI, obviously, it's a moving milestone, but what we do see is that agentics is helping us automate a lot of the tasks that maybe humans don't want to do. And maybe some tasks where humans are actually not the best. For example, like we've seen documentation, we've seen complex tasks like surgery, especially with respect to certain surgeries that machines are way better, and we're able to now benchmark it with data. So I think in the last 5 years, there's been two explosions. One is we've had explosion of both synthetic data, as well as we're able to get readouts of actual data streams and organize them really well. So that helps really inform the models very well, which earlier wasn't possible because, as you know, healthcare has been very, very regulated, and rightly so, because we're dealing with lives at stake here. But I think from simple documentation automation, we've gone to automating some of the tasks that humans are maybe not so good at because of the access to data. So that's what I see being a ubiquitous theme driving the next maybe 3 to 5 years till we achieve super intelligence.
Thank you. Jessica, you have a super interesting field you're working on. Would you like to say a few words about that and then maybe give us a vision about how AI factors in later?
Sure. Yeah, so where we're coming from in Nectome is that there's a lot of really interesting potential in the future. And certainly things are changing in the way that we can handle things with AI now. But it's going to be a while before these translate into actual cures for the very complicated biological system of the human body, and before this translates to the kind of promise of medicine that we're really looking for, which is the sort of world where we're able to cure all of our diseases and to stop aging, reverse aging, et cetera. These things all appear to be quite a ways off, even with developments in AI. And so the question we have as a company is, what do we do until then? What's the option for people who are dying now, who are reaching the end of what the medical system is able to provide? And so what we're trying to do is preserve those people with what amounts to essentially a very fancy embalming. And then the check on this is, what kind of quality do you get in terms of the preservation of the brain itself? Can you preserve the brain well enough that you can say with confidence in our understanding of how memory works in neurons and the brain in general, that we've preserved those memories and that person in that state? And so we've gotten to a point now where the level of preservation we're capable of achieving meets that criteria of synaptic traceability across the entire brain, which strongly implies that the people are still in there once they've been preserved. And we're able to hold them in this state for hundreds of years. And so this is intended as a kind of backstop on the medical system at large, where, given whatever capabilities we have right now, there will inevitably be a point for people alive today where this is the last option that they have.
Risto, you had an interesting conversation with Jessica about this earlier. Could you summarize some of it and maybe continue from those thoughts?
Well, yeah, I was asking about all the technical details of it because it's really fascinating. And my special interest there was, we quite didn't get there, we could continue, is how could we possibly then download that data somehow or revitalize the person? What are the opportunities there? I know you're not working on it, but I'm sure that you're thinking about it. So one aspect might be that we somehow digitize it, that we actually understand the synapses, we understand the structure, and we create a digital twin somehow. And that would be a really fascinating way to get started, or else then somehow downloading the physical structures. But have you thought about it? But potentially I have, but it is, I understand it's not something that you're already working on, but it's fascinating to think about.
Sure. Yeah. So, I mean, the ultimate goal of all of this is to revive people in whatever way is possible. And in a very long-term framework, many things become possible that are not possible now. And I think a lot of people might want to be revived in the flesh, which is going to take quite a while. It's going to be very difficult to do. And so if you're looking for more near-term strategies, I think the nearest term option you're going to get is what some people call uploading, where you essentially extract out the connective graph of the neurons and their relationships to each other and convert that into a computer simulation. And this obviously is somewhat philosophically complicated for people, and people's opinions vary quite widely on whether that's worthwhile, what it means, and what you might be able to do with that. And again, we're not working on this directly, but this is one of the earliest term applications for something like a preservation.
Yeah, and I think the tokenization really helps provide that standard where digitization is becoming easier. Earlier, I think we had like a ton of machine learning models relying on different data sets being trained on specific, modality. Now that we're able to have multi-modality and multiple data sets be speaking the same language and be broken down into the same tokenization standard, even if philosophically we might not be able to evolve at that point, at least through tokenization and digitization, you're able to create that vision and give people the options to either upload themselves or like if someone wants to actually create I shouldn't say clone, but like create some version of themselves in both a digital and a physical world, that's possible today. Yeah.
Yeah, and even though downloading a whole human mental picture might be a little far off,
right,
the first steps are not that far off. Yeah. That we already talked about, that fruit fly connectome has been outlined, and you can simulate it computationally. And there's also work. We actually did some work on digital twins of patients who had stroke. And we had computational models of individual patients in a clinical trial, NIH clinical trial, testing different treatments on digital twins. So the first steps already are there.
Yeah, absolutely. And there's some really interesting implications to the ability to simulate a system like this, in that you might be able to do experiments that are not possible in the physical world. You may be able to modify individual neurons and see the effects rippling throughout the remainder of the network and how that affects behavior, how that affects your overall well-being, depression, et cetera. There are many different kinds of experiment that become possible that aren't possible now.
And I think going back to simulation, I think it's really to Risto's point. We've had fundamental breakthroughs. So when I started, I know Omniverse was a platform that we were trying to grow at NVIDIA as a simulation platform to create digital twins of like Earth and planetary aspects, and also try to mimic particle physics. And we were to a certain point obviously able to get to particle physics easily because of game development and simulation technologies being around for a couple of decades now. But wave mechanics was a very big challenge. Now that we've had significant breakthroughs to be able to represent sensing modalities and wave mechanics, you're actually able to have embodied systems like humans and like other cellular organisms be able to represent themselves accurately. So I think that is another wave that has led to most of these things to be possible in the digital realm. Yeah.
Yeah, and if you're talking about what the role of AI might be here, you alluded to that already, that when we have this digital model, we can mess with it. We can change something in it and see what the effect is. And in particular, we can run algorithm methods, AI methods, that are discovering things that you don't already know. They are searching for solutions that might not occur to human, say doctors, for instance. And that's a very good role. Having a digital twin is a starting point, and then doing discovery with AI is the second step.
Risto, evolutionary algorithms is one of your specialties. Would you, because you alluded to the creativity of AI, how can AI be creative, just for those of us who are not as familiar with it?
Well, yeah, it's exactly what I just talked about. I mean, I didn't mention evolutionary AI because that is a search mechanism. It's an exploration mechanism. So you have a way of representing potential solutions, and then you use this evolutionary computation technology, which is really just an intelligent search mechanism, trial and error. You try out perhaps different treatments, and then you test them with the digital twin. How good is this treatment? You can't do that with patients, but you can do it with a digital twin. And that way you can find new solutions that humans might miss.
At this point, is there anybody from the audience who would like to jump in or have comments? Just checking because we promised. Yep. I don't know.
This is an amazing conversation. I really appreciate it. You don't need to necessarily, but yes, I invite the audience, and if you guys can do a little mic sharing.
Hi, Jessica. Who are your customers right now?
Yeah, that's a great question. So this is something that I think once people properly understand that it's an option, there are a huge number of people out there who may be interested in using it. It's the sort of thing where, in America alone, 2.5 million people die every year. And of that set, any number of them might be interested in considering this sort of thing. The question is it a post-death option? And that's correct. This is the sort of thing where it's not something you would do now if you're alive and healthy and enjoying your life, right? It's the sort of thing where when the medical system has run out of options and you're diagnosed terminal, this is sort of the last option available. And we're essentially expanding the space of potential options and treatments that could exist, giving you more time for medical developments to occur.
So is it something that could be done within the 9 minutes after you're passing before you're experiencing brain death?
So essentially this is correct. It has to be very close to time of death. It is a post-mortem procedure, but there's a short time window there to do it correctly, to do it with enough quality that it is able to say that the memories have been preserved.
Hi, interesting conversation. This is a question for Professor Risto, but for everybody as well. I mean, there is a lot of hype about AGI, but I'm kind of skeptical. When is it actually coming? Because the definitions are also changing and the timeline is constantly shifting. And what are the modalities it will excel at? We don't even understand what consciousness is. So I don't think AGI without understanding that would make any sense.
Yeah, this has been a problem for AI forever, that as soon as we understand and know how to do it, it's no longer AI, it's considered something else. Then that's why the definition is very fluid. But in principle, you could imagine it as being like an artificial human being. So it might be somebody in your household that you collaborate with. It might do household chores and manage your life, basically, or be a companion. But absolutely, it's a very fluid definition. What do you include in it? Well, you could try to come up with operational definition. For instance, there are intelligence tests for what they are worth. They define several different dimensions of intelligence that are tested separately. And it started with just a couple of reasoning tests, but now there's a emotional intelligence and social intelligence and other aspects. So we could adapt some of those tests and evaluate AI systems along those lines, and that might be an operational definition.
Might one say, I LLM, therefore I am? We have a right here. I'm sorry. Next question.
This continuation question. What is the date I'm putting for AGI? Well, okay. So now I have the operational definition, so I actually have to make a guess. It's going to be right after I retire, so nobody's going to blame me.
There's one more.
I can maybe add something to that. So I think it's obviously the most asked question because, people are wondering when the singularity is. But to me, I feel like one of the litmus tests, again, there's plenty of tests, but one was the Turing test. And you can think of a Turing test be applied to many fields. So of course, conversation is one where we've already passed the Turing test, but we didn't even notice that we passed the Turing test because it was just that one conversation, AI that it was applied to. And I feel like we are very close to embodied AI, where we might pass the Turing test with robots being more productive than humans. And I think we won't even notice when we pass because, to your point, we don't understand a lot about our human conscious, what makes us human. So I feel like it's going to be a series of milestones and a forever journey towards figuring out what consciousness and what life is as we abundantly try to, expand. I'm guessing there's going to be many Turing tests that will pass.
I think we have time for one short question. We have about 6.5 minutes, so I'd like to wrap up after.
Oh, yeah. So I'm a long-term futurist, so I'm very happy that you mentioned uploading because I organized a conference 15 years ago, talk about uploading and freeze your brain like Alcor. I'm kind of curious, given the rapid growth of Gen AI, how do you see the whole concept of uploading now might be more realistic? And then with what you're doing, have you reached out to Alcor potential partnership? Is there a possibility for that or not?
So uploading is a very interesting field right now in neuroscience. We're not working on uploading directly, but what we're doing is the minimum level quality that you would need as a initial step to uploading. So previous techniques haven't had the kind of brain preservation that is possible for this. Specifically, the thing you need is synaptic traceability. If you can't see the synapses and the relationship of all the neurons to each other, you can't translate that into a simulated system. You'll simply be guessing what they might have been before they were destroyed. And so we've been working very hard to get the quality to a level where you can actually see all the synapses, you can see all the neurons, and you know if you put an enormous amount of work into scanning through an entire brain, which we're many years away from doing still, technologically speaking, as a scientific community. If you do that, then you can extract out the connective network of weights and run them in simulation. This is what they did with the fruit fly. And so this is surprisingly effective. They took a pretty simplified model of the weights of the network of the fruit fly and mapped it against what we know about what the fruit fly's neurons do. And they were able to feed it sugar, and it stuck out its tongue to eat the sugar in a way you might expect.
Yeah, on the other end of the spectrum, it's not that far that we could, say, prompt an LLM with an entire history of an individual, like all their writings, for instance, and maybe recordings, videos, and have the LLM copy it and represent that person and respond like that person. And we'll see how close it will get. But my guess is that it's not that far, that a person interacting with somebody, their dead grandmother, for instance, it might really feel like a real connection. That is probably closer than some of these physical uploading events.
You know, I disagree with you. I think that what you're going
Finally, disagreement.
I think what you're going to get when you do something like what you described is you're going to get something that is essentially ChatGPT pretending to be your grandmother.
Yeah, of course, it's pretending. It's not your real grandmother.
Well, right.
But what do you mean? What's the difference?
What I mean by this is that it's going to differ quite significantly from how your grandmother would be in many ways. Ways that are not going to be easily recognizable by anyone from the outside doing training and validation, but would be pretty obvious to somebody who knew that person well.
Let me jump in here. We have 3 minutes left, and I'd like to close by each one of you answering 2 questions. What's your biggest concern, and where would you put your money if you invested in the future of healthcare?
Yeah, so I think I can agree with Jessica that I think hallucination is one of the biggest concerns. Of course, we've done a lot with retrieval. We've also done a lot with guardrailing, but there's still obviously limitations. I mean, Jessica was talking about just a mere limitation with respect to both uploading and making sure that whatever memories are uploaded, you have accurate representations of those, right? So of course, LLMs as we see them today is more or less approximations. So they will still continue to have those inaccuracies. So we got to be watchful for that and be able to guardrail against it, or we might be able to have some better systems for it. So I definitely see that that's going to be a big challenge.
And where would you put your money?
I think longevity in general and expanding human consciousness, that would be my take. Yeah.
Okay, thanks, Amit. Risto?
Yeah, so the biggest concern is that AI will run amok somehow, that we can't manage AI adoption in society. It's a terrific tool to improve society, but it can also go wrong if you don't have the governance structures. And where I would put my money, we got so lucky with LLMs. I mean, if somebody told you that, yeah, this is always what we thought would work, they are lying. I mean, it was a huge surprise that it worked so well. We can just predicting the next word, and all of a sudden we have all this technology and all these abilities. So neuroscience, psychology, understanding humans, and then building new architectures based on what we already know that are actually based on a more biological foundation than the LLMs.
Thanks. Jessica?
I think I would say that my biggest worry is that we'll get too distracted by chatbots to focus on the more important core issue of understanding how biology works from the fundamental level.
Where would you invest?
So from that perspective, I'd like to see more invested into the specifics of modeling how the protein pathways work, the interactions between cells, the fundamental core science of this, and to apply the AI techniques that we have towards developing a better understanding of that base level.
Okay, thanks. Let's give a big hand to our panelists. Steve,
Thank
to
you,
your delight,
yes.
we ended up on time.
Oh, you did great, and I had actually given you a little buffer, so I'm okay to. But that was such a great roundup and applause. I don't want to undo that yet. I want to savor this amazing conversation. This is like one of the most interesting, deep conversations, and I don't know if this is relevant, but I posted it to somebody's a response on LinkedIn recently that was like, I think that for me, the next Turing test is when, actually I think it was the Chris Ye, is when the LLM completes your sentences with more accuracy than a spouse of 20 years. All right, hot take on that. Go down the panel. What do you think? What's the next big leap? What do you think the next big leap is that we're going to see is? That we're going to be like, oh, that's a milestone. Like, oh shit, I didn't see that.
AI is going to be the spouse. That's my answer.
Yeah, I mean, when we see AI controlling robots in the real world, doing things reliably, that's going to change a lot of things. I think that one will be big.
I think personalized medicine, we can finally come up with treatments that are for you specifically.
Yeah, and I think for me, it's just going to be like, more accuracy and grounding. That's something that I definitely see going forward.
I'm just going to push back on Amit because I think hallucination is a feature, not a bug. Because well, let's give Amit the microphone so he can retort.
Yeah.
Because we all, what are our memories?
We do hallucinate
memories
quite a lot.
Perfect.
Yeah, I agree with you. Yeah, sorry. Go
Some
ahead.
more than others.
Yes, some
in this
more than
town. Okay. Okay, with that, everybody, big hand. Thank you very much. If you want to speak to, most of the speakers are hanging out because this is basically a room full of people who are experts and interested and enthusiasts. So I look forward to hearing not only the conversations that happen on stage, but the conversations that happen amongst each other. So look forward to hearing your feedback. Love to get that afterwards as well. Okay, next up we have Vicky. And we're going to give you microphones. We'll get your team up on the slides. Grab a microphone from Dylan here.
Oh, we have extra people on here coming.
That's not you?
Those three are. I don't know who those two are. Are they coming?
Oh, Alex, we got to take off. No Alex, no James. Those are just our luminaries that have been here, and we like to appreciate them by putting them up on everybody's panel. Come on, join the...
Perfect. Hello, everyone. While they're fixing that, how's
introduce
everyone?
your guests here for the panel?
Yeah, I will in a second. We're just going to get everyone on your feet for a second because you've all been sitting down for a bit. So we're hoping to just get everyone to stretch a bit, move your arms, get some blood flow. Just, move. Everyone's been sitting in this room for a bit of time. So boost your energy. And then, very excited to have you all here today. Feel free to take a seat whenever you're ready. I'm Vicky Powell. Nice to meet you all. I'm the CEO and co-founder of Loom Health. And we're building the first ever continuous hormone monitor. And I'm going to be hosting this panel today with Danny and Jonathan. And we're going to be talking about health data and specifically new types of wearables. So let's all take a seat. And I'll hand it over to Danny to introduce himself.
Great. I'm Daniel. Good to meet you all. I've been involved in the longevity space for about 3 to 4 years now and was at the Vitalist House in Berkeley earlier this year, so see some familiar faces. But really excited to share what we're building here at Loom and also talk a little bit about the future of continuous wearable data and how that's going to be really important for building the foundational model for human biology that we keep hearing about in the longevity space.
Hello. Great.
Yeah, I'm Jonathan, Vicky's co-founder. Before starting Loom Health, I was a medical doctor. I worked in trauma surgery and then got shifted into COVID care when the pandemic started. And that's where I realized that we just don't have the tools to usher in this new era of healthcare. And I wanted to be part of that solution. And that's what brought me here to San Francisco. My accent is South African, so excuse it.
Awesome. All right. First question I wanted to ask the audience, how many of you have some kind of wearable today that you use? All right. Yeah, most of us. Okay, we're all health conscious. So yeah, essentially what we're building at Loom is a new type of wearable. It's something that's quite different to what you might already be using. And what I wanted to first start a conversation with is essentially what do we think is missing with the current wearables? A lot of people might have Whoop or Aura or an Apple Watch, Fitbit. What is missing from those and what do you think is going to be in this next era of wearables?
So yeah, we get a lot of questions here at Loom where people ask, what's the difference of your product versus Aura, Whoop, or 8 Sleep? So when you think about those types of wearables and sensors, they're really using just two basic core technologies, which is an optical sensor that looks at your heart rate and a movement sensor, so an accelerometer. So it's really using these powerful models we have, but the data that it's getting is just movement data, like steps, or it's a bit more than steps at this point, and heart rate, and then basically combining it in matrices and looking at it in different ways. Some of the new sensors that we've talked a lot about at Loom are temperature, exposure to outdoor light. There's even some sensors that measure like your voice and things like this. So as we get new data types, we have more to basically feed to these powerful models. But we really don't have the molecular data available yet. And so just to give a little bit of more background on what is being built at Loom Health, it's basically a wearable sensor that can read the molecules that are in your body through your sweat continuously throughout the day. Yeah, that'll actually tell you kind of basically think about if you could have a blood test all day, every day. And so that'll just give us a lot more granularity on what's actually happening in the body.
Yeah, and maybe Jonathan, building on that, from your time in medicine, in hospitals, and as a practicing physician, what was missing from the tools that you had to be able to monitor individuals that you really feel is needed in this next era of development?
Of course, the molecular level data would have been a complete game changer, but more than that, I'd never recommended any wearable to any of my patients because, well, back then it was mostly sleep focused, and most people know that they're sleeping badly, and none of the wearables really told them what to do with that information. So yes, you can want to sleep better, but you cannot will yourself to sleep better. And none of these wearables had actionable next steps as to what you can really do right now in order to improve your night's sleep. And I think that's also a big thing that we're doing differently here at Loom, right, Vicky? Yeah. So what have you learned through like our interactions with our early users in terms of actually giving them data that changes behavior?
Yeah, this is something I think about a lot, and something that I've really come to appreciate is sometimes it doesn't really matter what the data is. Like, a lot of people use Aura and Whoop to measure HRV. And sometimes you ask people, what is HRV? And they're like, I don't know, I just know it needs to be high. And I think what I've learned is humans really want to be able to measure something about themselves that they can track and improve. And I think that quantitative metric about how they're doing really creates almost like a game. And that's what I think the metricization that a wearable does and the data that we get allows people to do that is so powerful. It allows them to gamify their health to make them motivated to do something that they wouldn't do without this wearable. Something I say all the time is health is really simple in many ways. It's eat vegetables and healthy food, get good sleep, and move your body. But in a world that is really distracting and so many things pulling at our energy every day, it's sometimes hard to do that. And I really think that is the power of data for improving health outcomes. It's enabling you to stay on track with what you want for your body and to find it exciting and motivating to do that every day.
Maybe I have a follow-up question there. I'm one of the people that gets quite anxious when I'm overloaded with data. And what is your opinion on that problem? Do you not want to, because you don't want to cause worsening of this category of people called the worried well? So what is Loom's, hypothesis there?
Yeah, I think that's a really big issue. And that is the responsibility, I think, of these wearable device companies, is to present that information back to the individual in a way that doesn't actually harm them by causing worry or concern in a way that isn't necessary. And I think that's actually what determines a lot of the success of certain wearables in this category, is how they present that information back to the user. Whoop and Aura have very similar sensors at the end of the day, but how they deliver the information back is very unique. And I think that that's really where a lot of the innovation honestly comes today, is how we can motivate people without worrying them and how to make being healthy fun. And I think I'd love to ask you guys, with the wearables that you do use already, what do you like and what actually does improve your health the most out of the current data that you get from your wearables? Maybe Danny.
Well, I'm biased for Loom, but okay, I'll talk about my Apple Watch, I guess. I think the main thing, the way I kind of think about the data you're getting is there's input data and there's output data. So I usually just try to track my input data, which would be the consistency in which I'm getting outdoor light in the morning, how many steps I'm getting in that day, the amount of zone 2 I get in a week, things like that. And then the output data, really the only thing we have is HRV. And so that's why I'm excited about getting, the real-time hormone measurements. Yeah, that's what it is for me.
Nothing to add.
And then now I want to sort of make a bit of a pivot towards hormones, because I think, as you can hear, that's what we're really interested here at Loom. And I know many people in the audience are interested in it for various reasons. We have people all the time coming to us sharing their concerns and their problems that they're having with their hormones today. And so I wanted to start a discussion really on what are hormones and why are they so important to measure? So maybe Jonathan, from the medical perspective, what is a hormone and why is it important to human health?
A hormone is a functional classification, so it can look like many different things, but it essentially is your body's way of communicating from one group of specialized cells across the entire body. So, for example, your adrenal glands, which sit above your kidneys, secrete cortisol, and cortisol interacts with a variety of cells across your entire body to perform different functions at different times of day, at different cell types. Other examples of hormones are testosterone, estrogen, progesterone. All of those hormones that I've just mentioned now are cholesterol-derived. They're called the steroid hormones, but you have other classes of hormones as well that have specific functions and different structural characteristics. That's a boring answer. V, maybe you give your, higher level answer.
I give the 5-year-old version. The way I say it, really hormones shape who we are as people. They shape how we feel, how much energy we have, how well we can sleep. They also obviously shape our reproductive capability. There's many functions for hormones within our body, and they're almost like little chemical messengers, is how I describe it. It's like that your body is having this constant conversation with itself, and the way they have that conversation is through hormones. So your brain will either release or suppress certain hormones at certain times of day to say, hey, Danny, you need to get up and get moving for the day because the sun is up. So it releases a lot of cortisol in the morning to help you do that. And then as the sun goes down at night, your brain then starts to release melatonin to say, hey, it's time to sleep, rest, and recover. So I like to think of them like these little animated characters traveling around your body, directing different organs to do different things during the day. And maybe the next question back to both of you is, what do you think people can do about hormones when they know that something's imbalanced? So if you're, for example, Jonathan, if someone's to come to you and they've now got a cortisol reading or a pattern of readings that's imbalanced, what are some things that you would recommend they do to rebalance those hormones?
I'll let Danny answer the rebalance question. I just want to touch on a point before we get there. I have seen during my medical career, thousands of blood results of these spot measurements of hormones that are always normal. They're just invariably normal, and it's because that normal range is extremely wide. So if you look at the normal range for cortisol in the morning, it goes from 1 nanogram per mil to almost 10 nanograms per mil, depending on the assay. But that's basically the entire range of cortisol. That's whether you're unhealthy or not, that's the entire fluctuation of cortisol. So of course it's going to be normal. But where the truly meaningful information comes is when we get these hour-to-hour measurements of cortisol. Exactly. That's exactly it. And that's when we see, okay, your cortisol is not spiking in the morning to take you from sleeping in bed to, running to catch the bus to work. And that's an incredibly important process to occur in your body to coordinate all your other physiology to perform all the different actions of daytime as opposed to nighttime. And yes, we actually do have really good control of how to improve your cortisol spike. So Danny, maybe you can shed a bit more and then I'll add on.
Yeah, and maybe before you do, I'd love to hear your story with monitoring cortisol and how you've seen that change your own personal health. I know that you have that. But just quickly to the audience, how many people have had their hormones tested? And have you ever seen that they have a normal result even though you don't feel normal? That you don't feel like, you feel something's wrong, but it just comes back normal and your doctor says, well, you're in the normal range. That's something that we get a lot of people coming to us saying of like, my doctor says it's normal, but I just don't feel that way. And that's really what some of our experiences are, trying to help you feel seen and to help you understand what's going on beneath the skin. So yeah, would love to hear your experience.
Yeah, I think there's a lot of value in the continuous nature of measurement. One thing Vicky and Jonathan both talk a lot about is right now, if you just go to the doctor and get a blood test for your hormones, they just give you a number, but that's just based on that day, maybe the time of day, what you did that day. So it's almost like if you went to the doctor and they just gave you your heart rate. They just said, your heart rate's 80. I mean, it's really not giving you much more information than that you're alive. So the same thing is happening with the hormone data. So for me, I've basically had a tough time sleeping for the past 20 years. And so, I mean, genuinely. And so I think like the reason I'm so involved with Loom is I really believe in what they're building, which is, giving you actual insight about what's happening in your body. And then you being able to take ownership of that result and doing experiments. So, one of the things that Vicky and Jonathan have done over the past few months is worked with 100 clients or, early customers to basically walk them through a coaching program where...
Including Danny, he was one of those.
Yes. But yeah, the main intervention was really just to go outside in the morning and get light because, I mean, you should talk about this more, but we're basically just giving ourselves jet lag every day if you think about it. If you don't get access to a really bright light signal multiple times every day, but in the same time every day, your body really has no idea what time it is. So everyone here, I'm sure, has experienced jet lag, but that's happening for so many people every day. So these small lifestyle changes, I think we talk a lot about preventative medicine or AI, all these really complicated things. But at the end of the day, I think if we want to be proactive about our health, it's about being more in harmony with our biology.
Yeah. And one other thing I'd love to hear from you, Jonathan, as well, is we've obviously talked a lot about cortisol so far, but I think people in the audience and people often come to us curious more about reproductive hormones. So things like estrogen, progesterone, testosterone. So can you tell me a little bit about how these hormones are also important to measure continuously and what kind of insights that we'll be able to give to people when we can monitor these things more continuously?
Yeah, a difficult question to answer because we just don't have that data set right now. So there's definitely things to learn, but because it's so difficult to collect hour-to-hour testosterone or hour-to-hour estrogen, we just don't really know. We have hypotheses about what could influence these hormones. Definitely for testosterone, if you perform some sort of anaerobic, muscular contraction, it will spike testosterone. But we don't know that for certain. We don't know. There's obviously differences between individuals as well. And what this continuous measurement will allow people to do is, as Danny said, be the scientists of their own body. Something we like to say at Loom is that you are the expert of your body. No one has all the data you do about how your body works. And we're just adding another, like a microscope, to giving you a microscope in order to better understand how different exposures or activities influence your hormones, and the same for estrogen. Another thing that will this type of monitor will definitely allow you to do is better titrate hormone replacement therapy. The timing that you take your estrogen patch or your testosterone supplementation is incredibly important, and that's kind of left on the wayside now. And our sensor will be able to better tell you, okay, if you take estrogen at this time or testosterone at this time, it increases its effectiveness by 13% is what we expect. And that can be, firstly, much cheaper in terms of people taking hormone replacement therapy, but also just more efficacious therapy.
What do you both think about the big rise that we're seeing in hormone replacement therapy and what that means for kind of the future of human health in general? Like, do you have concerns? How are you seeing this, for example, in the longevity community? Danny, I know you're very involved. How prevalent is this, and what kind of concerns or promises do you see for the future of human health?
I don't like having opinions that I haven't thought too much about, but if I have to answer this question, I'm not too concerned. What concerns me is unmonitored therapy, because everything you put into your body has some sort of consequence, and you need to be made aware of those consequences, and you need to be educated on what you're taking. And a lot of what is taken right now is in this gray market, and so you're not really certain of the concentration that you're taking, the other preservatives and other constituents of the medication that you're taking. And I think that stuff is more concerning to me. Otherwise, just properly following up and monitoring for side effects minimizes my long-term concern for these products.
Yeah, nothing to
add. All right, then. So maybe taking a bit of a different tact here. What about regulatory landscapes? Because I think that's something that's been changing a lot recently. The FDA has been really changing a lot of the perspectives that they've had on how much regulatory pressure they put on wearable companies. Maybe Danny, what do you see as the biggest opportunities here now with how this regulatory landscape is changing?
Yeah, I think regardless of what you think about this administration politically, clearly there seems to be a lot of motivation to liberate health data. I think so far we've mostly seen it through the policy regarding health data records, but I think we've already seen some early movement around health data in regard to wearables as well. Looping back to what Jonathan was saying about kind of these experimental therapies is I think there's going to be more and more decentralized science, let's say, in the sense of, actually, I want you to talk about that as well, the patient burden concept. Like how you think there's too much burden on the healthcare system, so a lot of this monitoring has to happen. Anyway, but yeah, I think people are going to have more and more ownership over their own data, and if we're going to try to do a lot of these novel or experimental longevity interventions, we need to have a way to measure if it's actually working. Like right now, to be honest, people are just on biohacker subreddit saying this peptide worked for me, and that's kind of the best data signal we're getting if a therapy is working or not. And then on the other side, you just have a lot of the institutional research groups doing research, but it can be quite limited, and there's issues with funding and whatnot. So I think there's going to be a lot of movement in the wearable data space.
Yeah, I think that is one of the biggest opportunities in this space. Is with wearables, you get these decentralized data collection units that can now get population level data for us to really understand human health in a way that we've never been able to before. So I'm really excited for things like Loom and many other startups and even bigger companies that are releasing new technologies today. So I wanted to open it up to the audience with the last few minutes that we have for any questions that you have, either about wearables or about health, anything that kind of comes to your mind.
Yeah, raise your hand. We have some questions in the front right.
Thank you, Steve. So, Vicki, right now you're measuring, with Loom, you're measuring cortisol as you're beginning. The questions that I have are a couple. First is, as I understand it, you're using some kind of measurement of sweat. And I'm interested to know more about what the output is in the sweat, because I know there's a difference between what my doctor looks at when he looks at a blood test versus a dried urine test, a 24-hour Dutch test, or what have you, the metabolites, et cetera. So I'm interested in hearing a little bit more about what your technology itself is doing. And then I'm interested and what the output is that you're measuring and how that compares to existing measurements so that we can understand what incremental information is available to us. And then I'd like to know what your time frame is for rolling out things like estrogen, progesterone, and testosterone, because I personally am I'm kind of titrating, and I'm using multiple modalities of some of these replacement therapies because I use vaginal estrogen. I also have a patch. I also take some oral estrogen because from everything that I've read, it seems to me, and I am under a doctor's care, it seems to me that each of these ways of dosing have different systemic effects. So, and for testosterone, I'm completely just titrating till I get zits and chin hairs because I love it. I take as much as, until I grow like a full beard, I love me some tea. So, and most people say take progesterone at night. I find that it's helpful in the morning, so I do a split dose. There's no helpful information out there. You've studied a lot of this. I'd love to hear you address any and all of those, those orientations. Thank you.
I'll let Jonathan answer yes, we'll be really quick. I'll let you answer the second part around like the testosterone and the replacements. But in terms of how we're different to existing technologies. So yeah, maybe you've tried the Dutch test, maybe you've gone to your doctor and got blood work. The really big difference that we have here at Loom is we're not just taking one moment in time or one day. So with the Dutch test, you get 4 points throughout the day. We're taking weeks, months of data. So we actually start to see how your body changes over time and how cortisol changes from day to day, because every day is different. And that's where a lot of the clinical utility is when you start to see, on days when I work out at this time or I spend more time outdoors, I see a measurable difference in my cortisol. And that's where the aha moments happen, is when people can see how their behavior influences their hormones and are then able to make much better decisions in the future. And that's really the platform we're building. And maybe, yeah.
And then in terms of what we're specifically measuring is the free components of all those hormones. So we measure free estrogen, free estradiol, if you want to be specific, free testosterone. In terms of titration of dosages, I think you do it absolutely right. Continue to titrate to symptom tolerance for now. And what we hope to do in the future is that we all know exactly what your therapeutic range is once we have longitudinal data sets. So okay, I need my testosterone between, okay, let me say estrogen between 100 and 150 picograms per mole in my sweat. And I know I need to take my patch at this time to do that. In terms of the different modalities of entrance, obviously your vaginal estrogen will have a lot of local effects and fewer systemic effects, and that's typically the case there. Otherwise, yeah, nothing else to say. I think you're doing it well. Titrate to symptom tolerance.
Yeah, but it is an exciting space. So yeah, that's all the time we have time for today, but please come up and chat to us after this, and we'd love to hear from you. We're planning on launching in 2027, so would love to have you involved. We're doing beta tests in our San Francisco lab, so would love to be in touch with you. But thank you so much, and thanks, Steve, for hosting this conference.
Thank you, Vicky, and Jonathan, Daniel, thanks for joining us. Look forward to getting to know you all better, and Vicky, getting to know you even more better. Okay, thank you. Next up, we're gonna change over here. Next up, we have Nelly Perchatkin, and we're gonna bring up her slide. Great, and we have he's acting like, yeah, but he doesn't know. Okay, Nelly, are you here? There you are. Okay, we're going to have your slides up in a moment, but why don't you get on the stage and do some introductions?
Hello, everybody. I am Nelly Perchatkin. I'm the founder and CEO of Midnight Mastermind Technologies. This is Hope Nalapandidis. She is our clinical director of mental health. And we're here today to talk about how AI can upgrade your mind and improve your life. Let me see if our clicker is working here. I don't think our clicker is working, Steve. We have our presentation. Oh, yeah.
Do you have Sorry, here we've got a little technical communication hiccup.
Just let me know where it's coming into. I'll just email it back again, or I can text it to you. Thanks so much for your patience.
Okay, just go ahead and start talking about what you're doing, and we'll get up the slides to back you up as soon as we can. But we'll otherwise, we're going to talk about the wearables fashion show.
Yes, so after this event, we're going to have an after party with a wearables fashion show. So please join us for that at 6 p.m. So in the meantime, let's get back to our Upgrade Your Mind talk. So Midnight Mastermind Technologies, we have a product called Master My Mind. and this is neuroplasticity technology. As many of you may already know, the subconscious mind is what really runs the show about how we feel, how we behave, how we react to life, how we view ourselves, and what we experience in our relationship to others. And a lot of us can maybe resonate with having a habit, maybe a fear, or something they want to change about themselves. And a lot of us can maybe have that idea, tell ourselves that we want to change it, maybe wake up earlier, have better habits. But when it comes down to it, it's very hard for our conscious mind to pick that up. And that's why I created Master My Mind. My brother passed away in a plane crash when I was young, and my first memory was that experience. And I grew up with a fear of flying and a fear of airplanes. And I tried everything to reprogram this subconscious fear that was deeply rooted. I tried psychotherapy, meditation, hypnosis, you try it, or you name it, I tried it. And so what I found was really effective for me was the power of my own voice and induced theta state. Oh, here's our presentation. So, how I reprogrammed my mind was finding the secret recipe. So science research is coming out. University of Kyoto actually came out with a study in 2022 that showed meditators listening to their own voice experience significant changes in their brain versus meditators listening to other voices. So the key here is your voice plus audio entrainment plus a very important component, which is clinically based prompts. So this is our product. It's a psychotherapist-backed approach that can safely rewire your mind privately in your own home. So what we do is induce theta state, add your own voice affirmations that are clinically based by our psychotherapist AI technology. So we'll go into some of the research of why these components are important. So as I mentioned earlier, the study from Kyoto University talking about how your voice is more susceptible, your brain's more susceptible to change when you hear those prompts in your own voice. So when they did the EKG tests of the meditators who are listening in their own voice, they found the prefrontal cortex regions were lit up, neurons were firing a lot faster. So this means that your nervous system registers your own voice as a command rather than a suggestion. The next component is theta state. So we use audio entrainment, binaural beats to induce theta state. And many studies show theta state's very effective in reducing anxiety, increasing focus, and relaxation. And this is the state when your brain is most open and susceptible to new information and change. And the next step is subconscious reprogramming prompts. So the words really matter here, and that's why we have a very advanced psychotherapist-backed AI that creates these very specific scripts, and it all depends on what you want to change personally. So you have a conversation with the AI, and it creates everything specific. And now I'll hand it over to Hope. And she's going to go more into the exact prompting and the psychotherapy side of how it all works. Hi, thank you, Nelly. Hi, my name is Hope Melbourne Davies. I'm a licensed psychotherapist and the director of clinical mental health for Mastermind Minds. In my clinical practice, clients use Mastermind Mind as an additional support between sessions. As Nelly had mentioned before, psychotherapy just isn't enough. And there are really beautiful ways in which we can reprogram the mind, but a lot of times they're intense. And so there's a lot of talk lately about EMDR and somatic practices, and those are incredible. However, they can bring up a lot of the trauma and in the process of healing, re-traumatize you. And so what I've found in my practice is when we use those modalities, again, absolutely effective, they weren't as helpful on the day-to-day basis because it was re-traumatizing a lot of clients who had deep-rooted issues. And so when Nelly asked me to get involved in Mastermind Minds, we talked about the different ways in which I would help clients through traumatic experiences. And so when clients use the app, they experience when they're in thought loops or during inner child and belief reframing work, start to hear their own voice over and over again on a loop. And it is positive affirmations, which our AI therapist has come up with. And it's reprogramming on the subconscious level, but it's also a very gentle way to reprogram the brain as opposed to an EMDR or somatic therapy or a more challenging approach long-term. And so the consistent reinforcement outside the session has helped my clients feel so much more empowered and move through challenges more efficiently. And of course, before I introduced it to my clients, I wanted to make sure that it worked. So I used it for myself. Both of my kids have been in fragile medical states. Thankfully, they're doing great now. But that caused me to have an insane amount of health anxiety. And so anytime my child got sick, I would have a huge physical response, a huge somatic response, palpitations, anxiety, pervasive thoughts. Being a therapist, you would think I would be able to handle it, but I couldn't. And so again, went to therapy, tried somatic work, and none of it was really getting to the root of the issue. I worked using Mastermind Mind, and within 3 days, I was able to handle my child's illness. And so, of course, because the universe works the way it does, 3 days after starting Mastermind Mind, my daughter got sick, which usually sent me into a panic, and this time didn't. My nervous system was so much more regulated. So I called Nelly right away and said, this really works, and I want it. So we discussed the ways in which I can use it in my practice, and I've seen anecdotally, time and time again, that my clients are making big gains in the time between sessions. Because again, psychotherapy is amazing and very important and plays its role, but there needs to be something in between. And what we found is using this in between, the clients come back and they feel more grounded, they feel more inspired, they also feel more empowered, especially because now the voice that was there before, whether it was through their parents or through experience, is no longer the most important voice. Their own voice becomes the most important voice. And so it becomes the lasting change that goes beyond the therapeutic hour. Yes, and that's an amazing use case. Very stressful to have a sick child, and I'm so glad it worked for that. But there's also so many use cases that this is effective for. Anxiety. You can work on your health, be more motivated to go to the gym. It's great for relationships. It's great for you want to change. Also really amazing for manifestation. A lot of the time people will try to do something or achieve something, but they have those negative thoughts telling them, oh, I'm not good enough, it'll never happen. So many different use cases, and your mind is really your greatest asset. So we invite you to take control with Master My Mind. We launch in the App Store next week, so please go to our website, mastermymind.co, and sign up for our mailing list. We are going to send out a discount code at launch, and then also more information on our launch party that will be here in San Francisco. Thank you so much for being here. Thank you, Steve, for hosting. And now we'll open it up for a quick Q&A.
Raise your hand if you have questions. First, I really appreciate you sharing your story. That's a lot of vulnerability. I think healing is about vulnerability and just being able to let it out and share from the heart and feel it while you're sharing it. So thank you.
Thank you.
Hello. For me and the other physicians in the audience, we hear a lot about re-traumatization, but I don't know that we necessarily know what that means and how to tell when that has happened, and particularly in the clinical setting when we're discussing something with a patient. I'm curious, what is that point, both selfishly for clinical purposes, as well as for when one is participating in something like this or in their therapy?
Do you want to take that? I think that's a better one for you, since you have experience with clients and that specific situation.
So a lot of times the brain can't tell the difference between the actual event and discussing the event, because you're going to get the same somatic responses. And so when someone has to repeat the traumatic event over and over again, the body is not telling the difference. And so inadvertently, although we're trying to help, the person gets re-traumatized. And what that looks like is they can have PTSD-like symptoms, lose sleep, more anxious throughout the day. It's a fine line, especially as a physician, right? Because we need the information in order to prescribe. We need the information in order to help. But sometimes that I've found is, can you tell me about the feelings and the symptoms, and not necessarily asking them the details of what happened, because that tends to lessen the response. And that keeps them in the present, as opposed to telling them to recount the trauma. So if you could say, okay, we don't have to get into the details, but tell me a little bit of how you felt since, what's coming up for you. And then a lot of us have been doing this a really long time, so we can kind of piece together what happened based on the symptoms without knowing the full breadth of the story, because a lot of times we don't need the full story. We just need to know how it's impacting them today in order to treat. Does that help? Okay.
Great. Well, thank you very much. And again, our website is mastermymind.co, and you can also follow us on Instagram, mastermymind.co, and we're also on LinkedIn. Thank you, and we'll see you at the after party. Does anybody have
Thank
any
you.
questions?
What's that?
Any more questions?
No, we have to.
We're
at
done?
time. Yeah. Sorry about that, but thank you so much. That was perfect. Really appreciate it. And next up, we get Dr. Dave's slide going. I'm on it. Oh, temp wearables. What are temp wearables? I don't like disposables. We're going to fix that on the fly, but at least we have the right person on the card. Okay, Dr. Dave Rabin, are you here? Oh, right here. Okay, we're going to get your slides up there. And then while your slides are up, we'll fix the title of your presentation. The ecological type. They're recyclable temporary wearables.
Oh, they get the real title now. Great. Can everybody hear me okay?
Automatically.
All right, awesome. Okay. So if I hit next, will that do anything? I'll see them over here, or?
Don't hit next before your slides come up. It'll be the next person's presentation.
Oh, okay. Well, it's nice to be here with you all. I hope you're having a great week. I'm Dr. Dave Rabin. I am a board-certified psychiatrist and neuroscientist, translational neuroscientist, actually, which is a bit unusual in that I've done my time at the bench in the lab and I've done my time in the clinic. And while I still spend many years in the clinic currently seeing patients, what I actually focus on in neuroscience is literally translating discoveries from the lab into the clinic and into the real world. Because what most people don't realize is that it takes between 15 and 17 years on average to get a discovery from the lab to the real world or to the clinic, to patients. And that's with some of our best, most evidence-based discoveries. So we don't really have 15 to 17 years every time something great is discovered to wait. We need to be able to rapidly accelerate, implement, and get new technologies, new discoveries into the world so that people can use them. And this is a major area that I saw as a weakness in medicine and science, that we were not effectively translating discoveries. They were just stagnating. And my wife and partner, Catherine, who's sitting in the audience, totally unrelated but in background, but did the exact same emerging technologies work that I do in neuroscience and sustainability. And when we started working together, she helped me translate the discoveries we made in the lab, which turned out to be very complicated to translate into real world product called Apollo, which I will talk about here. In the meantime, if anybody wants to try it, because I was going to have a slide share with you, you can get a head start. Go to the App Store on your iPhone and download the Apollo Neuro app, APOLLO space NEURO. And this will upgrade your iPhone for free with neuroscience that we took out of the lab at the University of Pittsburgh. And so, you know, one of the things I think that we can talk about while the slides come up is that, you know, I've been practicing trauma and addiction medicine for the better part of 20 years in psychiatry. I'm also one of the few psychiatrists worldwide that's trained in both MDMA and ketamine and cannabis-assisted psychotherapy. And these techniques are really on the forefront of what we're talking about in terms of the next generation of what does mental health look like in the 21st century. Because in the 20th century, mental health has been, and up until now, a terminal illness. When you're diagnosed with a mental health condition, you're told there's no cure, you're going to have it for life. But now, thanks to discoveries in both the technology sector and in the psychedelic assisted therapy sector, we're seeing that we can get people into sustained long-term remission from mental illness that we never thought possible before. And the evidence showed that with our prior treatment programs, the programs we were taught to use in Western medicine, the programs that many of my colleagues still use, we were taught that cure is impossible. Treatment for life is standard. And that's a pretty devastating thing to hear. And so what we really sought to look at was, how do we get to a cure, right? How do we rethink the way that we approach mental health, not as a terminal illness, the way we looked at infections in the beginning of the 20th century before antibiotics were developed? How do we start thinking about the star, right? The shining star guiding us to the goal. And the goal is not treatment for life or just stagnation of where we are. The goal is cure. The goal is healing. And that's what we want to keep our sights on and aiming for. And over the years, I've learned that healing is very interesting, because it's like walking into a room with many doors and none of them have labels. And everybody's like, oh, just walk through this door, you're going to feel better. Walk through that door, you're going to feel better. And have no labels. So how do you know which one's right for you? And so what I sought to do in my work was try to figure out, how do we start to label these doors with evidence so that people know what's right for them? And the first door I'm going to take you into is an app. So anybody who hasn't downloaded the app yet, scan this QR code with me real quick. I'm using it right now on my chest, so I'm here with you. And then when you download that app with this QR code, you're entering the door of healing that is gated by the vagus nerve, which is the primary nerve, cranial nerve 10, that governs the entire parasympathetic nervous system involved in recovery and healing and sleep and digestion and emotional regulation and metabolism and sexual health and reproductive health. All of those things are governed by this system. And so when you download this app, sorry, it doesn't work for Android yet. I apologize. If you want to try it, you happen to be an Android user, come find me afterwards and you can try the wearable. This is a live. So when you download that app, put your phone into airplane mode and then open the app, and you feel your phone start to vibrate. And you'll feel your phone start to vibrate differently than you've probably felt your phone vibrating before. And you should feel this gentle, slow ocean wave going up and down. And I want you to just close your eyes for 30 seconds. Don't 30 seconds is up. And just pay attention to the coming and going of this wave. And nothing else, just the coming and going. And for everyone who is doing that, and if you're an Android user, we're going to open the second door to healing, which is breath. Intentional breathing is the first way to heal that we were all supposed to learn as children. Most of us never learned it properly. So whether you're able to do this with the assistance of your phone or not, you can do it without. Just close your eyes for 30 seconds and just take a deep inhale through your nose or mouth for about 5 seconds till your lungs are full, and then exhale for 5 seconds. And then we'll do one more. Inhale for 5. Exhale for 5. You can make sounds. Breath sounds are good. One more time. Inhale for 5. Exhale for 5. And you can keep your eyes closed if you like. But what I want to draw your attention to is that you probably are starting to notice feeling just a little bit different. Maybe a little calmer, maybe your thoughts are a little slower, maybe your shoulders have come down a little bit, or you felt some muscle relaxation in your body. Why do we strive to learn meditation, mindfulness, yoga, breath work? Why have we for thousands of years kept talking about these practices? Why is there a wellness revolution right now? It's because of that feeling of safety and calm and comfort and clarity in your own body that is rapidly induced by somatic sensation. Somatic sensation is that feeling of when you take a deep breath and don't pay attention to anything but the feeling of your breath, or you feel the vibrations coming out of your phone from Apollo that are gently syncing with your breath, which is what you would experience if you held it to your chest. And so that feeling is very powerful because that feeling is healing. That feeling is your vagus nerve turning on. It's your heart rate coming down. It's your breath rate coming down. It's your blood pressure coming down. And this feeling has clinical consequences. People feel happier, depression symptoms lift, anxiety decreases, PTSD symptoms are less frequent. And it actually has an impact on the nervous system. So this is what you all just did. Right? Even just for 3 breaths, or just feeling the vibrations that sync your heart and lungs with the vibrations that the same benefit, you just increased parasympathetic nervous system activity. You improved your emotion control, whether you realize it or not. You will improve your sleep if you keep doing this. You improve your focus. You improve your resistance to illness, which is really interesting. And you decrease your blood pressure and heart rate in real time. These are all the measures of health. And what's even more interesting is that these are just two of the doors. We can get there with yoga. We can get there with massage, soothing touch, music, eye-to-eye contact and empathy with another human being. And then there's these old technologies that have actually been around for over 100 years, but we're still talking about them, which are like electrical vagus nerve stimulators that electrically activate the same nerve you just activated to get these benefits. Then we have other technologies, float tanks, sensory deprivation tanks, biofeedback practices, and even psychedelic medicines, when used properly, can radically amplify safety cascades into the emotional brain, which is how they promote healing when you're with a trained psychotherapist like myself, but why they don't promote healing when you're partying at a rave. Because you don't have the safety to be amplified in the public rave or festival setting that you do in a highly curated therapeutic setting. You rarely hear people coming back from festivals and saying, my trauma, it's cured. My PTSD is cured. I can't believe it. You don't hear that very often, but we hear it all the time in psychotherapy. And so what this led me down in my research lab at the University of Pittsburgh Medical Center in the Department of Psychiatry was to try to figure out what is the common thread between all of these doors. Why would healing from trauma or depression or anxiety all result from yoga, meditation, mindfulness, breath work, soothing touch, psychedelic assisted therapy? Why do they all give you the same outcomes when done properly? And the reason why is because when you do these positions properly or breathe properly or any of the things that I just mentioned, you increase vagus nerve activities by signaling safety to your brain and to your body. And the body thrives on safety. Safety, if fear turns on our survival response, our threat response, safety triggers our recovery response. It triggers everything our body needs to get resources to recover. Again, sleep, rest, digestion, reproductivity, immunity, and metabolism, all the good stuff. And what's really interesting is that of all of these techniques that I just described to you, the one that we do the least often, that is by far, hands down, the single most powerful and free way to heal your body or to put your body and mind into a pro-healing state where it starts to do the work on its own, is soothing touch. Soothing touch. You can give yourself a hug, you can touch yourself nicely, you can snuggle a pet, you can give consensual hugs or get consensual hugs from another person. This is free. We all need it. It improves all of our biology. It improves all of our resistance to illness. And yet we don't do it. And so we had to build technology that could give people not a replacement for soothing touch, but some of the biological benefits of soothing touch that we're just not getting enough of. And it turned out that when we made this hypothesis that you could send through a wearable like what you see or what you see, what you see on my ankle here, you can send these soothing vibrations you just reliably trains the body to be soothed again. And that safety signal activates the emotional cortex in the brain, just like getting a hug and just like MDMA. So you don't need to take MDMA to feel good or to feel love or to feel joy. You just need to do things that soothe yourself. Be in nature, calm your body, take warm baths, hug a friend or a partner more often. Engage in things that bring you joy, that bring your attention back to your body. Apollo is just a tool to help us get there more often. But what's really interesting about it is that it actually is starting to address the burden of many different mental illnesses and also sleep disorder and sleep issues. And insomnia is one of the biggest problems we have in America. There's like 100 to 150 million people estimated to meet diagnostic criteria for insomnia. That's like a third to a half of our country's population. So if you think you're the only one not sleeping, it's not just you. So we decided to track data from wearables, other very well effective sleep tracking wearables, to 1,300 people over 2 to 3 years. We saw that by stimulating the body in the same way as soothing touch, we were actually increasing sleep as much as a 30 over 3 months. That was over each night. 19% increase in deep sleep, improvements in HRV, REM sleep, decreased resting heart rate. And then we saw in clinical trials that were published, that was pre-published data, this came out of the showing that by sending these soothing vibrations you just felt to your body, you're boosting vagal tone and increasing heart rate variability statistically significantly. This shows that same thing that same vibration you just felt through the on your phone through the wearable actually addresses many of the symptoms, particularly the like sleep, fatigue, mood, dysregulation, anxiety and stress, and overall quality of life of people with systemic sclerosis, which is a very severe terminal autoimmune disorder. So this is not, the Apollo is not treating the disorder, it's treating the stress-related symptoms surrounding the disorder so these people can live good lives even though their bodies are in a severely disordered state. And this study just came out showing that using this technology, this wearable technology, actually decreases burnout by 30% in med students and pharmacy students in just 4 weeks, and increases quality of life in that same population in just 4 weeks. We can really tackle some of these hard problems with technology. And I know we have to wrap, I think. So I just wanted to say the future here is that we can now take data from Apollo itself, which tracks sleep, and from other devices, and then create the future of personalized medicine that's actually specific to you based on your data, right? It's not taking a medicine that's dosed for you. We've been able to do that for a really long time. Now we can take your data and understand your HRV is really low. You slept like shit last night. Guess what? We can send you a stimulation that's going to help you feel more energized right now because we know you're under recovered. So why do you want us to tell you that you're under recovered and you slept like shit? You already know, right? You want to feel better. And so now we can close the loop and actually take your data and send you vibrations that give you what you need in the moment and throughout the day and throughout the night. I think you turned this, is this off? Did it die? Oh yeah, oh yeah.
I'll do it manually because we're switching over, so.
Okay. So this is the end, which is basically that from all this data from these sleep studies, we were university sleep studies, thousands and thousands of people in the real world, we were able to build an AI. This is the first AI product that, if any, raise your hand if you've heard of a snoo. So this is a baby crib that turns on automatically when your baby starts to stir in the night and prevents them from waking up with sound and vibration. And we thought, well, this is only allowed to be used with children up to 6 months old. What about the rest of us? We need to have our wake ups that when we don't want to be woken up at night, we need something like that. Waking up in the middle of the night in an unwanted time is when most people struggle with biggest problem with insomnia. So we built that AI and we released it. And we see that that gives people up to 60 minutes more sleep a night, doubling the benefits of Apollo. So this is a very exciting time. It's arguably one of the most exciting times in the history of psychiatry. And I'm really excited to share this all with you. And I hope to chat with you all after the event.
Yes,
thank you.
And you are.
And of course, you are worthy of love, which is the fastest, simplest way that we can all make ourselves feel safe. And so I like to remind us all that whether we don't think about this much often, we can, and it really does make a difference. So thank you.
All right, big hand, yes. And Dr. Dave will be around to take some questions, and we may even see him back on stage before the evening is out. Thank you, thank you. Okay, next up, do we have Rishi's card. Soji on the cable switching. Okay, there we go. Rishi, we're going to go straight to this. Okay. Okay, Rishi Mishra. Good to see you again, my friend.
All right.
Yeah, it's been a year. We have so many alumni. People are asking me, how do I get so many great presenters? I say, well, you got to start early. You got to start small. You have to start with one full day HealthTech Summit, and then you get to see people evolve. So one of the most amazing things for me is having the conversations throughout the year, and then inviting you back and seeing how things like you're going to talk about it. What's in demand? What's changed in the last year? It's like quantum leaps forward every 6 months or 3 months.
Absolutely.
So a year.
Yeah, thanks for having
Mind-blowing.
me back. Appreciate it. My name is Rishi Misra. I'm a product leader at Kaiser Permanente, and I'm going to talk today about wearables, specifically focusing on wearables for metabolic health and cardiovascular health. So why these two areas? It's no secret that both metabolic health and cardiovascular health are huge cost drivers, I should say, in the U.S. healthcare system, which now costs about $4.9 trillion, the entire economy. And I've also got some personal experience with this, and I'll start with that and then go into why this is important for healthcare as a whole. So last year I did the Escape from Alcatraz triathlon. While doing this, or while training for it, I used a continuous glucose monitor. And this is a non-prescription version of the CGM, so there are prescription versions. And this particular one has a metric called the Lingo count, which basically is a metric that allows you to see the metabolic impact of food, activity, sleep, stress, based on the height and the duration of a glucose spike. And some were not too surprising, some were surprising. So while training for the triathlon, my overall glucose went down. No surprise there. My cells are using glucose at a higher rate. But then in the early stages of training, I saw spikes when I went into intense physical activity. So for example, a 6-mile run, I saw spikes happening. And I went to nutritionists, asked them why that's happening. Basically said, are you on a low carb diet? I said, yeah, I'm not eating many carbs. They're like, oh, well, what's probably happening is a phenomenon called adaptive glucose sparing, which is when your body gets really efficient at burning fat. When you're training for a triathlon, it'll go to burning fat right away when you jump into physical activity. So when your liver dumps a bunch of glucose into into the bloodstream, and your body's prioritizing burning fat, then you see a spike. But then, of course, the spike goes down because your body eventually starts burning the glucose. Then I started looking at food. Example here, packaged Trader Joe's coconut water. I think it's really healthy. That created a spike. But then I got a bottle of imported organic coconut water from Thailand. Did not create a spike. Then I was like, okay, what about milkshake? If organic coconut water doesn't create much of a spike, does organic milkshake not create much of a spike? Sadly, no. The organic milkshake created a spike, so that was disappointing. And then I kept the CGM on even after finishing the triathlon and saw these additional insights. So no surprise, stale food in the fridge, so salad left in the fridge for more than a few days, that created spikes. And then a surprise for me, a good one, a certain brand of German chocolate, which I'll be happy to share with you after this talk if you like. That didn't create a spike. So that got me really curious on what Europe is doing in regards to food regulation. And then no surprise if I had lack of sleep, lots of spikes, high ones, and lots of variability. And glucose variability is not a good thing. I'll talk about why. It's because of this concept that everyone likely knows, inflammation. Glucose spikes can create inflammation, and the converse is also true. Inflammation can create glucose spikes. Not all spikes are bad. Spikes over 140 milligrams per deciliter, those are not the good ones. The ones that last long and take a while to get back down, those are the bad ones. And this is true especially in insulin-resistant and sleep-deprived states. Now, why is inflammation bad? No secret there. Inflammation is upstream of many downstream issues like cardiovascular disease to cancer. So what's the bigger picture here? What can AI-augmented wearables that measure metabolic health do? It's actually very exciting. It's really a next generation of health coaching that can give you real-time feedback based on what you're eating, your activity, your sleep, your stress, and give you that guidance in the 99% of the time that people spend outside of the clinic. And then when we think about what it can do for pre-diabetics, which consists about 1 in 3 Americans, not a small number. In fact, the health system is more than likely not taking care of these people. It can empower those people to manage their prediabetes and prevent sliding into diabetes and complications. Even bigger picture, what can it do for our food system? As people become more aware of their metabolic health and what's driving inflammation, what's driving spikes, they likely start to advocate more for better food supply. We know that the European Union is more precautionary in terms of how they regulate their food. The US has an approach that's more, I should say, higher risk tolerance. They don't ban a substance unless it's proven to be harmful in general. And that's a problem. I'm sure some of you have gone to Europe, had their bread there and felt fine, and then had bread somewhere here and felt bloated. I certainly have. So as someone that's been at Kaiser Permanente, I can tell you that the non-prescription wearables have a lot of potential. But of course, to get an organization that large, or for that matter, any healthcare organization to reimburse for it, has to be publications. That'll eventually come. But the bigger problem is staffing. Like I said, there's a lot of pre-diabetics out there, and let alone Kaiser, but the entire US health system doesn't have enough staffing to manage all the pre-diabetics that are out there and help. So what this technology will do is empower people to manage their own health upstream of sliding into a lot of those downstream complications, which is a great thing. Now, the other thing I noticed anecdotally is the accuracy of the non-prescription CGM. It is directionally correct, but magnitudinally, when I compared it to the finger prick glucose, for example, it was lower, a few milligrams per deciliter lower. But I think that'll improve as well as the technology evolves. So inflammation and metabolic health is upstream. Cardiovascular health is downstream. And again, a big issue, huge cost driver in the US healthcare system. 605,000 first events, 200,000 repeat events. Wearables are making an impact here, a big way. In fact, several years ago, Kaiser Permanente piloted a program with Samsung where they used wearables to manage cardiac rehab, which is basically rehabilitation for people who've had their first cardiac event. Very successful, way more successful than traditional cardiac rehab. Drove high completion rates, and then also made cardiac rehab available to people who didn't actually live near clinics. So what does that mean for AI today and how AI can transform this? Now, what I talked about with Kaiser was several years ago. AI is transforming cardiovascular rehab management in particular in bigger ways. For one thing, it's gone from static rehab to adaptive personalized rehab. So an example of that is previously you just have data saying, okay, you got a high heart rate, but now you've got something telling you you've got low HRV and your resting heart rate's gone high, easier activity a little bit. And that kind of personalized, actionable guidance can actually improve adherence as far as cardiac rehab goes. And I've got a personal anecdote here where, a couple of years ago, early January 2024, my dad had a cardiovascular event, and he sits in India. So I've actually been able to look at what's happening with his cardiac rehab through his Apple Watch sitting here in the United States. And it's given me some great insights. In fact, I will know if something's wrong before my dad does, and I can message him, and then he'll go see his cardiologist, which is pretty fantastic. But still, we're a long way, and I think Apple could probably make some great headway in this space in active management of cardiac patients. And of course, the opportunity to manage people and prevent people from that first event is even larger. So I'll conclude by saying that, wearables is not the breakthrough, but what really is wearables combined with good clinical intelligence and behavioral change. That really is the breakthrough. And then second, it's going to empower people to advocate for their health in ways we just haven't seen before. Thank you.
Is she going to take some questions?
We are happy to.
Yeah. So what can you tell us that's on the edge of confidentiality disclaimers? So you didn't tell me about what is going on, but you said, organizations, and probably not just Kaiser, are leaning to, certain areas. So what can you say that would give us all some more, even deeper insight?
Yeah. So, Kaiser's had a lot of focus on using AI to alleviate some of the clinician burden. There's a technology called a bridge. If any of you have been at a Kaiser doctor's office recently, you might see your physician pull out a cell phone and, basically record you. And what that's doing is automatically transferring relevant data into the electronic medical record in fields where the data belongs while the clinician's talking to you. So that's changed the physician-patient interaction in big ways. There's certainly things that Kaiser's looking at on the imaging side to improve diagnostic accuracy. I think, Steve, when you had me here last year, I talked about how I literally broke my back. It was like a spinal transverse process fracture, and it was missed by a radiological x-ray. And then 2 weeks later, I fly to India to go see my parents. Luckily, I upgraded to lay flat seating and found out, for a total of $200, by the way, that I had 2 transverse process fractures in the lumbar spine. So
that was the cost there in India.
Yeah, that was the cost there.
That would cost $20,000 here?
Right. So that included a CT scan, an MRI, and 3 X-rays. That was all included. And of course, a correct diagnosis, which can be priceless. So, there's loads of improvement, and there's a lot of technology that organizations like Kaiser are looking at to improve diagnostic accuracy.
Thank you so much for sharing Kaiser's interest in multidimensional wearables. I'm also a researcher myself, and we're very, very interested in the potential multimodal tracking, particularly with the recent ChatGPT Health, where it empower even more multimodal. I'm curious, have you guys done any study where you do multimodal tracking of integrating multiple wearable data, multiple wearable devices, and then in the example of diabetes, like say smartwatch, smart scale, and kind of map that back to clinical survey or self-report data? Just a general question, and curious what you guys have done.
Yeah, I can't speak to what Kaiser's doing for multimodal tracking for diabetes specifically. I think there might have been a partnership with Omada Health, which really focuses on that. The challenge with deploying something like that at scale is you've got to have consistency. So sometimes, patients will be Kaiser patients, but then they'll transfer to other healthcare payer, and that just becomes a little bit difficult to manage from a study and pilot standpoint. But that said, there's a lot of work going on in addressing cardiovascular disease a whole lot earlier, and particularly addressing some of those things I was talking about, like how do we prevent that first event, especially now that multimodal wearable technologies become available.
Well, I know everybody wants to get questions in, and I hope you're going to stick around. We're going to have a panel come up now, so you're going to stay up there on the panel. We'll invite some other panelists to join you. And we also have Antonio. Where's Antonio? Coming on up. Let's grab the other microphones. And then Amit Badlani is coming back up. Hope you're ready. And Dr. Dave Rabin, come on up. Is it Rabin or Rabin? Dr. Dave. Okay, let's see if we can get everybody here in the room. Can you guys hear us? Amit Badlani, Dr. Dave, come on up. You're back on. All right, we'll just start with you guys. Let's swap out the cards that are up there. All right, let's see where you guys are. I know you're here in the house. Okay, they should hear. Okay, gentlemen. Here we go. No. Yes.
I'm missing two.
I think we have the wrong title up, but we're getting close. We're getting closer. Okay, why don't you gentlemen just start talking? So Antonio, this is your panel. Just because I have to share the responsibility.
Awesome.
And put somebody on the spot. Okay, Amit, come on up. We'll update that title.
Oh, yeah. Okay, so we can get started.
Yeah, just get started here. This is I'll just share what I've shared with the other folks. We do things a little bit. I like controlled chaos, where we're sort of like lacking on a little bit of the control at the moment. So think of this as like a dinner conversation, and we're all eavesdropping. You guys invited each other to get together so you could dive deep. You could share like the commonalities between what you're doing and dive in and have that conversation. And then maybe we even get the chance to ask some questions and engage the audience. But first, ask each other questions. Let's get deep. And what I like to do is, we had a few presentations, and now we can drop in and we can even explore deeper into some of these areas, especially neurosensors and other sensors to, I think there's physiological sensors. We have neurology going on throughout our body. So how does that all come together, and how can we, where is it going?
Beautiful. So maybe I'll do a quick intro about Aware, since the only wearable that we haven't talked about yet. So we're building an emotionally intelligent AI coach. It's a wearable that sits behind your ear. It's a tiny little device, uses EEG technology, electroencephalography, and tracks your neural activity. And then we use machine learning to detect your emotions in time. And so through machine learning AI, we can identify whether you're in fight or flight, and we have different interventions through this AI coach to help you snap out of the fight or flight, recalibrate, box breathing, or more broadly is going to be an AI coach that is fully aware of your emotions. So think like a therapist, but not quite. Of course, there's the human aspect missing, but it's essentially like a life coach that is always available, always on when you need him. And a little bit like to frame these wearable compared to other wearables, I'm wearing most of them, many of them at least. So if you look at the landscapes of wearables, you see wearables for cardiovascular health or wellness, so sleep tracking. You see wearables for calorie tracking, so wristband, Oura Ring. There's another major pillars of wearables, which is metabolic health. And so continuous glucose monitoring, we saw in the previous presentation. And then there's a third pillar of longevity, which is basically mental health, mental wellness. And so that's the gap that we're covering in the wearable landscape. So we have built a device, a wearable that continuously tracks your mental well-being. So maybe we can start by maybe explore that area as well. I mean, you have talked about cardiovascular health and metabolic health. You have talked about mental health, and see how these three pillars kind of so complement each other, what your thoughts are.
You want me to go first?
Why not?
Sure. I'm Dr. Dave Rabin. It's nice to meet you all. I'm a board-certified psychiatrist and neuroscientist. Interestingly enough, mental health and cardiovascular health are overlapping quite a bit now because of this new biometric, which isn't new exactly. It's been known about since probably the 1960s when biofeedback first came around, which is called heart rate variability. Raise your hand if you know what heart rate variability is. Okay, so actually it's like 70% of people. That's pretty good. So heart rate variability is, can everybody hear me okay? Yeah? Okay. Heart rate variability is the rate of change of your heartbeat over time, which is a proxy for vagus nerve activity. And when you measure, what's interesting about this is that, we could talk about this for a while, but I think the key point is that the heart rate variability, when looked at across populations, especially mentally struggling, mental illness, populations of people struggling with mental illness, is that we see that heart rate variability actually predicts outcomes. So if you have PTSD or depression or anxiety, your heart rate variability, if you already have that diagnosis, is more likely to be low, in the lower range of humans. If you have low heart rate variability, you are more likely to get a diagnosis of depression, PTSD, or anxiety if you are exposed to severe adverse events, e.g. trauma in your life. And you could measure that by looking at the heart. Similarly, you can also measure, as with HRV, you can predict other things, like recent papers came out showing that heart rate variability predicts longevity and health span better than any other easy to track metric. And why that's interesting is because heart rate variability is tracked by almost every single modern advanced wearable tracker. So think Oura Ring, Apple Watch, the really advanced Fitbits, I think, track it, Garmin's track it, Whoop tracks it. And so if we understand from a preventative level, what your heart rate variability looks like when you're feeling at your good, healthy baseline. I'm feeling good today. When I feel good, my HRV is usually between like 70 and 120 milliseconds. So when I wake up one day or 1 week, I notice my HRV is like 20 to 40. That means I'm going to be 50% of my capacity for cognitive performance, physical performance. I'm going to recover slower. And if I push myself, I'm going to be more likely to get sick. And that is a really valuable tool. And if my HRV is dropped and I have a diagnosis of depression and a history of suicidal thoughts, I'm more likely to take my own life, right? So this is now a predictive measure that is very, very powerful. That I've never had a measure like this in mental health. And when you do healthy mental health practices, when you're doing the yoga, the meditation, the mindfulness, the talk therapy, you're doing the life changes that make your life better, that we all work with our patients on, or that you hear all over the place, your HRV goes up and your vagal tone goes up as a metric reflecting that you're healing, that your vagus nerve is more activated. And so that's really interesting. And it really creates this new, what I would call like a new way to think about mental illness in the 21st century, in that it's not separate from physical illness. Physical and mental illness are deeply, intimately connected, just like the mind and the body are connected. When we are sick in our minds, we don't do anything about it, our bodies get sick. And when we're sick in our bodies and we don't do anything about it, our minds get sick. And so there is a relationship that must be acknowledged. And I think where that's going, that's so exciting with what you're talking about, Antonio, and what Rishi, I think you're talking about integrating at Kaiser, is this idea of closed loop feedback systems that don't just measure. Because just measuring is not that useful if you don't have a set of actions that are going to follow the measurement. If the measurement is irregular, what is the point of knowing the number? The number just gives you anxiety. It gives you data overwhelm. So what we really are doing now, that's very exciting to hear that Antonio is working on, and that many other people are working on, and we're working on in Apollo, is closing the loop. So taking your data in, understanding how does this data look? Is it close to your baseline? Is it better than your baseline? Is it worse than your baseline? And how do we send you an intervention that's going to prevent a problem or help you excel and get you closer to your full potential, even though you might have slept badly last night? And the same thing with the EEG that you're talking about, like you're directing people to treatments and to different techniques, like breathing techniques that actually help them heal from their brainwave data. It's amazing. So that's the future. To me, that's really going to, radically shift the way we think about personalized medicine. Is we're tailoring it to you based on your biological data.
Yeah, I'll make an additional comment. Really great points there from Dave. I'll make an additional point from a metabolic health lens and mental health. So one of the things that will happen is essentially mapping what biomarkers drive variations in certain stages of mental health. In fact, if you get a metabolic wearable, one of the things it'll ask you is, are you trying to improve your mood through better glucose regulation? And that correlation between how much glucose variability or how much glucose stability and mental health is there. It's actually there. I mean, try it out. Have a really high-powered high sugar milkshake and get in a car ride with someone, and you're probably, I don't know, there'd probably some interesting stuff that happens there. So, I think tying the relationship and mapping what you eat to the mood that creates is something that we're starting to see, and we'll start to see a whole lot more as wearables provide the data.
If I can add a couple of more things to that. So when I embrace this journey with Aware, what really struck me is the power of EEG technology in that it provides an incredible time resolution of your emotions. So every second you can get a sample of your emotions. So the nice thing of HRV is it give you a measure of stress. It's a mix of physiological stress and mental stress, right? But it's more like a long-term type of things. And what I found very fascinating about EEG technology, by looking at 15 years of neuroscience academic research mapping EEG signaling into emotions, was really the time resolution. The ability to recognize in the moment that you are in fight or flight, and then do interventions like a vibration, for example, closing loop with a vibration in real time to bring yourself into a calm state. And so if you exercise the muscle over and over again, now you're really building a muscle of resilience. It's really like going to the gym and exercising, lifting weights. The same thing is for our brain. So if you recognize when you are in fight or flight, instead of getting stuck into this cycle of rumination, which is unfortunately the bug that us humans have. We are the only species on Earth that have that bug.
Quicksand.
Exactly. We associate meaning to our traumatic memory, and so we get stuck into those cycles that no other animals on Earth have. So Aware is a way for you to snap out of this cycle. It's really recognizing the moment when you're in fight or flight and start recovering. So instead of accumulating stress over time, then becomes chronic stress, depression, burnout. It's a preventive tool to all that. And then to close the loop to all things, to all this, so we have all these biomarkers, and they are all useful. I think Rishi showed before, like how many spikes, peaks and valley you get with glucose when you're not sleeping. So that's also is not tracking just your metabolic health, but is somehow affected by your sleep. And so I think the future of preventive care and preventive healthcare is really looking at all these biomarkers in all these three areas: mental health, cardiovascular health, and metabolic health, and really tell the whole story. Maybe combining that with your contextual data, now you can have a really precise information, maybe potentially predictive information on what's happening to you on a day-to-day.
Yeah, I would just add to that, it's absolutely predictive information as long as you're measuring the right stuff, right? And I think that a lot of the time we actually are over measuring because we are trying to grasp for certainty in what is effectively an uncertain or mostly uncertain world. And it's not about how much you measure. It's about what questions are you trying to answer. And if your question is, what's wrong with me that this stuff keeps happening to me, and you're trying to answer that with panels of labs and metabolic tests, you may not find the answer. You may just go down an endless search of thinking that there's something wrong with you when there might not be anything wrong with you at all. So it's really important to have guidance through this process. And, we in the hospital really focus on measuring things when the measurement, if it shows up abnormal, has a decent, what we call pre-test probability of showing up abnormal if we're going to do the test. And if it shows up abnormal, we have a course of action where we already know we're going to take. We know exactly what decisions we're going to change if this test shows up giving us A, B, or C, or D result. And that is not the general way that most people approach tests. And I think it's important to note that tests have a false positive and a false negative rate also. So a false positive and a false negative rate means that if you do a certain test on yourself or track a certain kind of data to do a test, there's a certain percentage of the time that test is going to show you a positive result when the result's actually negative, or a negative result when the result is actually positive. For every single test you do, every single lab test has a false positive and a false negative rate. Some of them are very low, the best ones. But it's really important to recognize these tests are not infallible. They're not the word of God. They are pattern recognition, and you have to ask the right questions, ideally guided by somebody who knows what questions to ask to get you to your outcome goal of health and well-being, or in, like we're talking about, prevention, so that you don't accidentally go down the rabbit hole of trying to figure out what's wrong with you when the answer may be right under your nose.
So maybe I'll ask the next question. What do you guys think is, in 10 years, how's mental health, or how's health is going to look like? Like, are we going to completely bypass doctors, psychologists, therapists, or are we going to completely rely on our own data? Or what are your thoughts around that?
You want to go?
Sure. As I mentioned in my talk, about 99% of health happens outside of healthcare settings. 99% of health management happens outside of healthcare settings, at least in healthy individuals, relatively. And so what wearables AI are really going to empower is how to do that a whole lot better. With the triangulation, with the actionable insights, people are just going to be empowered to manage their health a whole lot better. And then when they do go into clinical settings, they'll be empowered with that data to advocate in ways that they haven't before. I think that's what's going to change. And, of course, when we look at the bigger picture, they'll start to advocate for things that impact their lifestyle, like food quality, like, are there enough yoga classes or wellness classes in my area? If not, advocate for that. So I think those are the kind of societal change people will start to drive, because they're empowered with more information and actionable insights.
Yeah, I would agree with that, Rishi. And I think that the other piece that we're going to that I would expect to see based on looking at this mind-body connection space we're in, where it's a funny statistic that I remember. You guys can't answer this question, but shout out if you know what time of the week most people die of heart attacks. Monday at 9 a.m., where I hear it. There is not a single other species of animal on the face of this earth that dies mostly at the same time of the same illness that we know of on this earth. There is a reason why it's 9 a.m. on Mondays that most people die of heart attacks. It's not because there's anything wrong with your heart at 9 a.m. on Mondays. It's because the weekend's over and it's time to go back to work, right? And that is clear evidence that the mind-body connection is so real. And I think one of the major advances that we've made in the last, I guess 50 years of research is that we've shown that this connection is so undeniably real. And as we start to integrate that into the modern education and medicine, we start to integrate technology, we start to integrate into health systems, we start to change the way we think about mental illness from being, oh, it's just this thing that lives in a box that people make up in their heads, to there is a neurophysiological, biological process going on that we need to think about differently. And when you look at that with the lens of what technology can do and the lens of what we're learning about psychedelic assisted therapy, where we're taking people who had 17 plus years of completely treatment resistant PTSD and just 3 doses of medicine and 42 hours of psychotherapy later, they are no longer meeting diagnostic criteria at 2 months after treatment. And then with no additional treatment 1 year later, that number goes up and even more people are better. Why? Because they feel safe enough to do the motivational healing work, like Rishi was saying. Like when we change the systems and the ways that we think about disease, as it's not there's something wrong with you, it's that, hey, let's fix this together, right? We're on a team. And that team approach, whether it's with technology, team with humans, ideally both, medicine, we have an opportunity to actually start to cure what we currently think of as incurable illness. And I think the core mental illnesses that are on the closest are PTSD, depression, anxiety. And I firmly believe the next 10 years, we're going to see, thanks to the technology that everybody up here is working on, and thanks to all the great work being done in the psychedelic assisted therapy space, we're going to start to be able to tell people that their mental illnesses can be cured. And I don't think there's anything more exciting than that. Could I ask a question?
Go for it.
Rishi, maybe I would start with you. I'm curious, like, because you're at Kaiser, which is like one of the largest HMOs in the country and a major player in health, and kind of like where we're progressing with health policy, what do you see as the most exciting things that are on the forefront of actually being implemented into the patient care setting in this category?
Yeah, that's a good one. The interesting thing about Kaiser, or any large integrated health system for that matter, is they do look for a lot of evidence before they deploy something. But when the technology gets deployed, it scales to levels that typically small providers just can't imagine. I was involved in the early stages of helping Kaiser transition from paper-based care to electronic medical records, and now
lucky you.
Yeah, the vendor that did that is now one of the largest vendors in the country. It's unreal. I think having the evidence outside of large health systems, so that particularly startups that are doing innovative things don't, go to a large organization like Kaiser and then suffer from death by pilot because they're going through so many stages of hoop jumping. It's important for that proving to happen outside of health systems. But the thing about what we're seeing with wearable tech and the AI that augments it and the behavioral trends that are driving it in the consumer is that in itself is generating a whole bunch of data. And I don't know how far we are from this, but if AI can actually generate studies based on crowdsourcing data from some company, that could be huge in terms of accelerating innovation, even for the large health systems. And I think I was at a conference here in San Francisco not too long ago where there's companies that are building tools for AI, essentially having AI write publications for you if the data exists. And that could expedite adoption a whole lot quicker in large health systems.
That's exciting. Are you using AI, Antonio, in your in your work with EEG? Because the data sets are so complex and massive. Have you found help with AI and in breaking those data sets down? Brainwaves?
Yeah. So in our platform, we have 2 layers of AI. So we have a say physical layer where we map the EEG signal with conventional machine learning into emotions. So it's effectively we are looking at 2 different biomarkers, which is stress arousal and valence. So whether emotion is positive or negative, or whether you're calm or alert. And then there's a second layer of AI, which is more LLM. So we are getting all the now that we have your biomarkers in real time, we are feeding into the LLM, which combines with your contextual data, your calendar, if you want to share your calendar, any information you want to share. So the coach can actually have a really precise information, start correlating, every time you meet your boss, you're in fight or flight. Maybe meditate for a couple of minutes. So that's prevention or prediction also. You're about to walk into a meeting that typically, historically, puts you in fight or flight. So that's how we use AI. It's these 2 layers.
Yeah, that's really cool. That makes sense because brainwaves are complicated. I don't know if anybody's looked at brainwaves before here. I'm sure there are a few, but you're looking at what you guys do 14 lead, or how many leads do you have on your?
So actually, it's a single channel. It's a single channel. It's pretty amazing. So, historically, you look at EEG with these complex EEG caps, 32 electrodes, 64 electrodes. And those are really good for getting like a complete brain scan. So what's going on to your brain if you need a localization information. So whether, say, typical example like the seizure, where did the seizure originated? If you don't care about that, if you have generalized events like seizure is a typical one. Sometimes it's more localized in a temporal region, but many of the seizures are actually generalized. And so if you only want to predict, oh, you're about to have a seizure or you're having a seizure, right? So that's a single channel is good enough. And emotions is the same thing. If you look at the fMRI of your brain when you experience emotion, especially strong emotion like high stress arousal, is an entire network of your brain firing. So entire network of neurons firing. So it doesn't matter where you're measuring it. We get a sample from a single channel sample from the temporal region of your brain, but that's good. It turns out that's good enough to detect your fight or flight. So kind of we looked at the other way around. If you look at many of the neurotech wearables in the market, they have multiple channels. So we looked at, when we designed this wearable, was start from the user experience, start from what people would feel compelled to wear. And so I feel compelled wearing a wear while I'm on stage because it's hidden. Nobody probably not even noticed that I was wearing it. And so the idea was, what can I do? What's the form factor that is suitable for our day-to-day life? That I feel compelled to wear. And so by doing that, we built basically, I have here on my phone in the cloud, probably the most extensive EEG data set ever built in history. I have like 12 months worth of data, brain data on my phone, which is phenomenal. And because I feel compelled to wear my wearable constantly, it's probably the only EEG device that can do that right now because I wear it continuously. So I think what's very unique about a wear is the form factor, compared to other neurotech devices. We cannot provide precise information about your brain scan that our device can do, but we can provide some very precise information about your emotions, maybe someday, actually seizure is another big use cases. We've been working with Stanford on a completely different mental condition, delirium, affects 3 million Americans, 40% mortality rate. Today, Stanford Medicine is using a wear to detect the delirium. We are really proud to say that we have saved lives through this wearable. Right now, it's still in research phase. So there's a lot of use cases like this where you have a generalized experience, and so a single channel is good enough.
That's very cool. And I think the core that your theme you're hearing is like the outcome is action. Right? It's not just measure for the sake of measuring. It's measure to make something happen and to change course or to reaffirm that we're on the right course. And this is really the third generation, called the third generation of wearable technology, the newest generation, which is fully closed loop wearable technology, right? Like you measure, you interpret, and then you deliver a intervention or a stimulus or a treatment, something that's changing the system. Then you measure again. How did the system change? Do we get it right or wrong? Do we need to provide a different recommendation, a different stimulus? And so that's where all of this future of wearable tech is going, which is really exciting.
Yeah, I agree with that. And I think I would add one more thing is also personalization is really critical. Like we all have different things. And I get this a lot. Like, some people are just get very anxious when it comes to wearables, just don't want to know it. And other people instead, like me, I like to look at graphs. I'm the nerd that likes to look at graphs and then can really do something. So I think offering the personalized experience, like one of the wearables that I'm wearing that tracks sleep, I have 3 of them here. So it was giving me my sleep score, but I think and this is something you see a lot in AI today, that they tries to be kind of kind with you. I'm the kind of person that I like to know the truth in my face. And I know some wearables, they do it because they want to create anxiety. I much rather say, okay, Antonio, you're not sleeping well. And it took actually a researcher, a friend of mine is a researcher at Stanford. He's a researcher on sleep. And he looked at my data on my app and said, Antonio, your sleep is terrible. And so he made a point. He was because he's a friend, so he was very rough and really direct, right? And so that's when I actually start taking action. The founder journey it's ups and downs. And even if you're looking at your data, to your point, right? If you don't interpret or if you don't have a coach that actually tells you, especially with this very fast-paced life of a founder, you don't take the steps to take actions. And so I think the future of wearable is also about personalization and how you present that information to different people with different personalities. I think that's very, very critical.
That's a really good point. And question for you, Antonio, just based on what you referenced there around anxiety. I don't know if I think everyone over here has probably met some of those folks that have this lens on healthcare data as I don't want to know because I'm afraid it'll freak me out, right? But how do you think we can break through, with those people?
Yeah, it's a good point. I think first of all is I think the wearable actually instead of waiting 1 year until you do your annual and building kind of that anxiety, if you see it day by day and actually start tracking what happened to your glucose level day by day, or what happened to your heart rate, what happened to your stress level over the day, I think kind of remove the anxiety. Like anxiety, if you think of it, is lack of knowledge really. And if you now put a number at it, now you can do something with it. So I think that's the power of wearables. And I agree, you need to do in an ethical way and in a way that is personalized so you don't create extra anxiety. And the user experience is phenomenal. We're constantly listening to our customer, constantly getting their feedback, understand what they say, and understand what they want. So user experience is critical in any wearable. But I think in a way, wearables kind of are breaking that wall of old school medicine versus medicine 3.0. The more knowledge you bring, instead of waiting again 1 year for your annual and be almost afraid of what your cholesterol looks like or all the other parameters, if you know your values day by day, I think it kind of, to me at least, I think it reduced that anxiety, takes it away.
But I think, Rishi, you make a good point in that the other side of that is there are distinct groups of people that just don't want to know. And when you give them wearables, they get anxious, more anxious. The numbers just make them overwhelmed. We see it. It's called data fatigue. And it's why 50% of Oura Ring and Apple Watch users and Whoop users, after 6 months of getting the information that they get, take it off and throw it in a drawer and never put it on again, right? And I see this in my clinic with my patients all the time, that they wake up feeling great, and they're come to see me for insomnia. Then they wake up feeling great. I'm like, why are you seeing me? Like, my Oura Ring told me my sleep's bad. So did my Apple Watch. I'm like, well, how do you feel before you check your data? I felt great. Then why are you here? Put those things away, right? Like, so there's a certain, there isn't a group of people that don't benefit from having more data, but that is, I think, where these actionable tools are coming from, which is now you don't need to know cognitively that your body is in a dysregulated state. Maybe that will throw you off and make you more anxious. What if we just did something about it for you, right? So I think that's when I talk about like the third generation of wearables. I think that's what's really exciting is we can do the personalization that Antonio is talking about and use your data to drive action or to drive outcomes without with being able to skip the you need to look at your data step to approve this next thing that's going to happen, right? Or you need to look at your data and then go take a nap, but you can't because you're stressed now. So that's do we have time for questions from the audience, or are we?
We're kind of up against it, but I see one hand here. Somebody's been really engaged and right up here in the front. Appreciate you.
Thank you for your talk. It was great. So I have a comment and a question. So my comment is, I have the cutest ring. It gives me a crypto token. It has sleep to earn. So my question has to do with another product. It's called Aura Labs. So it's an AQI measurement that you wear. And I just wanted to know what you think about that, because I asked ChatGPT and it said, that has to do with cognitive decline if you're in low air quality areas for too long. So just want to get your comments on that. Thank you.
So you're asking about the air quality index measurements?
Yeah, like how valuable that is as information or as a product. Would you buy that since you have a bunch of
the woman sitting 2 seats directly behind you is probably the leading expert in air quality in this room. But if you, but I think what I've learned from her is that air quality is very, very important, and that many people don't realize that they live in extremely toxic air environments. And if you think about your body as like the fanciest, fanciest piece of a vehicle that you will ever be given to use in your entire life and have the privilege of driving. And if you put toxins every single day through every breath you take in your home that are filled with carbon monoxide and any number of other toxic lead-based paint and other kinds of chemicals that you could be intaking through your air, through your water, through your food, you're toxifying your fancy vehicle, right? And then you have to take and do other things to eliminate those toxins to get back to a fully functional system that's not inflamed by the toxins you're putting in. So I think the wellness community is just starting to catch up on air quality tracking, but it's really important. And many people have been looking at it for a long time. I don't know which product to recommend you there, but air quality, in making sure your air quality is good and not contaminated, is extremely important for health. And especially with mold now, mold is like the big buzzword there.
So we have a couple more questions, and we got to keep it brief. So quick questions, 1 sentence with a question mark at the end, I like to say, and one person either choose who's going to answer, or one person come back with a brief answer. And one thing I just wanted to say, which I get to do because I have the mic, is what really resonated with me with what you said was that, some people, it's not good for them to constantly be checking and stressing over what they're doing. And a philosophy I've had, because I have a specific diet, let's say, when people talk about what they eat, I'm like, well, as long as you're not stressing over it, it's probably okay, because I think there's a cortisol relationship there. So I think what I would love to have in all these devices and in data collection is just let me know when I need to know something. I don't need to stress over the day-to-day. So maybe that speaks to some of this, but just wanted to put that out there. 1, 2.
Just a very quick comment. There's good data on personalizing feedback to make it fit your personality. It makes a huge difference in how you hear something, how you act on something. So it'd be really easy to combine asking a few questions in whatever app you have, like as to what is your personality, how would you like feedback before the app gives the feedback.
That's a great comment. Anyone want to say anything?
Actually, I do that for ChatGPT sometimes. I use this like use a different tone or be more empathic, or it actually works. Yeah, good point.
First of all, this is an amazing panel. Thank you. Really informative. This is for either Dave or Antonio. Are you advocating doctorless medicine through wearables, like the Waymo of healthcare, or like Rishi might have been suggesting that through wearables we'll be better patients and you can advocate for better health with your provider?
Yeah, I don't advocate for replacing doctors, specifically mental health. I think I have an incredible coach, and I will never replace her. She's phenomenal. I think what we're doing with Aware specifically is adding emotional intelligence to the AI, right? That is missing right now. The ability to read your emotions, which is something that a therapist does really well. The therapist does really well is the knowledge about the psychology, the psychiatry, and the neuroscience, right? AI does that really well as well, probably sometimes better than some therapists because it has so much more data. What's missing is the human connection, and that's, I think, the empathy. And there is a really nice book about how emotions are made, tell you the difference between affect and emotions. And emotions, affects are an objective biomarkers. All right, so valence, arousal, those are affects. Those are two-dimensional affects. They're very objective biomarkers. Emotions are the consequence of that, plus your culture, where your upbringing, your context, and that's the empathy. That's where it's basically is the foundation of the empathy of that only human, as of today, as far as I can tell, have. So that's why I think, at least in mental health, that's something that human connection is something that cannot be replaced. So I would say that Aware is just a tool that you have in the day-to-day. You see your therapist once a week or your life coach once a week. You see the healing every time you meet him or her. What if you could keep healing throughout the week, whenever you need it, at the moment when you need it? So that's what Aware is about. But I don't think it's going to replace doctors or therapists. It's going to make their life also easier. They can track what happened during your week, right, in real time, if you want to share the data with them.
Yeah, we're definitely not going to ever replace doctors. The effect that you're talking about with empathy, when you have a genuine connection with another human being, especially like a healing practitioner that you trust, is called limbic resonance. Limbic resonance. It's when your brain, the limbic system of your brain, is literally in tune, in harmony with another human being's exact same part of their brain. And that does not happen with the machine, because the machine does not have a human brain. And it doesn't have a limbic system. Limbic resonance is something that happens between humans and animals when they bond together genuinely. And that is has a healing effect in and of itself, decreases stress in and of itself. It will never be replaced by machines. But right now, we as doctors, as a healthcare system, have too many patients to see. There's too many sick people that we can't see them all. And the healthcare system in America is literally going bankrupt because of two major reasons: mental health and addiction that is not being treated adequately, and chronic pain that is not being treated adequately. And these two areas are bankrupting the entire healthcare system rapidly, and therefore our entire country. And it's our tax dollars that are going into getting wasted, spent on mismanaging these illnesses. So these technologies are really a way to ease the burden and give people independent empowerment and independent boosts in emotional intelligence. Because if we can each manage ourselves independently a little bit better on our own without relying on the healthcare system, then we've just saved ourselves and the healthcare system tons of money and effort and time. And you multiply that times 100 million people, and all of a sudden you've just put billions of dollars back into the government to be able to do better things. And that's what we really need. And so we actually can create a sustainable healthcare system if we allow the proper integration of technology and the proper use of medication to treat some of these really hard to treat disorders like addictions, mental health disorders, and chronic pain more effectively.
Okay, in 2 to 5 words each, starting with Rishi, down the line, what are you most excited about in terms of the future in this area?
Democratizing.
With the microphone, though.
Oh, sorry. Democratizing personal health management.
Thank you.
empowering people to take control of their mental wellness.
Thank you.
Developing cures for mental illness.
Well, thank you all very much. Rishi, Antonio, Dr. Dave, give them a big hand.
Thank you. Nice.
Okay, coming up, we have Surya. Come on up. Can you make it? Here you go. Yeah, we're going to bring that up. Rishi, are you still up there? Clicker. Oh, right there. And come on, grab a... Okay, Surya, very special guest here, one of the developers on the team over at Meta. And we have 16 outdated drivers are found. They were lost, but now they're found. Okay, who lost their updated drivers? Okay, there we go. Anytime.
Ready to go? All right. Thanks for the great discussion just before this. My name is Surya. I am an engineer at Meta, and I'm currently working on AI for wearables and health. I've been working on smart glasses and other forms of wearables for the past 5+ years. So today I'm here to talk about how modern AI wearables are evolving to become ambient health companions. Very much builds on the discussion that just happened in the previous panel, and we'll dive more into the technical challenges as well as what the future looks like with these wearables. So we have 3 generations of wearables broadly right now. We started with fitness trackers like simple Fitbits, which mostly focused on counting steps and simple metrics, build dashboards, show us some trends. And then we moved on to smartwatches. They are more smarter, have access to applications, and have the ability to notify and display more information to the user as well. So they're more advanced in a way. But now we are moving towards AI constellations, which is not a single device. It's a group of devices which can understand all the signals in real time and also coach you in real time by interpreting them based on the context and your personal information. So what this allows us to do is basically move from the notion of episodic care to what we call as ambient support. So we don't really wait for the end of the day or a regular check-in with the doctor, but rather we rely on the AI to give us real-time decisions, timely nudges to do some simple actions to make our health better in day-to-day life. So I want to clarify these 3 terms specifically, what ambient, always on, and proactive AI means. Ambient is basically what it feels like. So the AI essentially blends into the background. It's always with you, around your surroundings, but never in your way. Like when you're doing the action, it doesn't interrupt you when you don't want it to. An example is, let's say you're doing a run with your Garmin watch or your smart glasses on. It can display the speed, and it can also notify you proactively when you're over the target pace, for example. What always on means is basically the system's readiness. It's basically always available to answer your questions, and it is continuously taking the stream of raw inputs from your body as well as the physical surroundings and your personal information. An example, a simple example in a day-to-day life is, for example, when you're cooking, if you have an always-on AI available with you, you could simply ask what the next step is without having to worry about providing the entire context, like without having to describe what you're making, where you're at, giving some images and so on. It's always sensing what you're acting upon, and it is ready to answer instantly. And the third one is proactive. This is essentially who starts the conversation or who starts the interaction. More often than not, with AI, it's us who go and start with the question. So that's user initiated. But a proactive AI actually knows, based on the signal and context, when to provide an action or a suggestion to the user. So that's the proactive nature of the AI. An example for that is what you typically see with your Aura Ring or your Apple Watch, where it proactively nudges you to stand or walk around if you've been sitting idle for a long time. So how can we achieve an AI which is a combination of all the three? So that brings us to smart glasses. This is a device that's been gaining traction over the past 3 to 4 years. And it's truly a game changer, and I'll explain why. So the first point is the additional context that it gets that none of the existing wearable devices can get, which is the true multimodal context in real time. It can actually see what you see because it sits right in front of your eyes. It can hear what you hear because the speakers and the microphones are right around your ears. So it's essentially the perfect hardware form to get the richest form of multimodal context that is essential for a good quality AI. So the interactions are also kind of seamless. It helps you stay in the present. You don't have to pull out your phone or look at your wrist to know what the next action or the interaction has to be. You can have the display on the glasses right in front of you, and you can, in a hands-free manner, get the support you need instantly. The experience is also upgraded because the glasses have context, what you're doing and where you are. It knows when to deliver the information. The phones today depends on your the do not disturb mode or other forms of settings that you have. And the other form of wearables are much less sophisticated. But these, because they have the true multimodal context, can recognize when to nudge you. And it also captures your behavior and environmental signals, not just the body metrics. The second device, which is critical to this, is the wrist form factor. So that is neural bands, watches, because these are required for continuous physiology. We need to keep tracking your motion, sleep, health signals, and temperature. Recently, last Meta Connect in September, we announced what's called the Meta Neural Band. And it's based on high-performance EMG sensors that sit on your wrist, regular watch, but they can read tiny muscle activations in your wrist, and they can enable certain simple actions like scrolling, clicking, or selecting different items in the menu, even when your hand is relaxed. For example, you can have your hands in your pocket and still operate on the display of your glasses. So that's truly useful for a seamless interaction. So now combining these together and bringing the phone into the picture, we have 3 devices. We have the glasses, which gets the context that you need, vision, audio, and location cues. And then it provides glanceable prompts on the display as the output, along with coaching with different actions and capturing key moments from your daily life. And the wrist is for all the metrics that I just described. And in terms of interactions, it can enable subtle interactions like the clicks and the gestures. And it can also provide feedback through haptics. And then the phone is still pretty important in the loop because it connects the glasses and wrist to the internet and to much more powerful models on the cloud. And it also allows these devices to offload any form of heavy compute that is not possible on the device onto the phone or into the cloud by sharing it with different apps and also closing the loop that was mentioned a lot of times in the previous panel and talks, which is basically making these insights useful for clinicians, caregivers, and so on to make decisions upon. Some examples of some current experiences we support with this constellation. For example, Ray-Ban Meta glasses have an integration with Garmin smartwatch, where you can get real-time stats about your heart rate, running pace, and so on with simple voice commands. And we also have a very cool feature which is called auto capture. It uses the different insights in real time from things like your running speed, elevation, and so on to capture key moments automatically. Like you don't have to actually even say take a photo. It takes a photo if it detects that your heart rate went up or your running speed has currently increased and so on. It's very good to share these moments with your friends and family or just look at them in the future to get more inspiration. Similarly, we have some integration with the Strava app as well, where your workout metrics like distance, pace, power, and so on are automatically linked to your workout session. So it becomes like a nice catalog of all the workouts that you do in your daily life. So the loop put together, the proactive loop, has 5 stages, and it happens in a cycle to just make your personalized AI better and better. So the first stage is obviously sensing all the context and all the activities that you're doing. And it goes to the second stage where the AI, primarily the LLMs, both on the device as well as the cloud, try and make sense of these signals, they understand. And then they take the role of the coach in step 3, where they decide in a timely manner what action the user needs to take. And based on that, in stage 4, the user can choose to take an action. And based on the action, the AI can learn and personalize over time and become better and better. And this feeds into itself, and that can create like a more personalized AI in the future. We'll quickly go through a few scenarios in real life, how this would work out. For example, I think this was just mentioned in the previous discussion. Morning commute, say some user is going to office and his wrist detects that he had a poor sleep, he or she had a poor sleep and has an elevated heart rate. And your glasses see, if you have given the calendar access, can see that you have back-to-back meetings, and also senses that your speech is faster than it normally would be. And using these signals, the AI can infer that you might be under high stress. And there's also likelihood that you don't not have enough hydration. So the action suggested could be a simple 2-minute breathing exercise followed by a suggestion to drink some water. And could also optionally suggest you to sort of move your low priority meetings just to make it stress-free. Another example is a live nutrition coach. Traditional labs, like, where you do a lot of manual logging, you take photos or enter how many calories you have eaten, would give you some sort of generic advice towards the end of the day if you choose to. But that's not really always helpful. Sometimes you need in the moment very specific advice to make a better choice. So an example is while the glasses are capturing the menu or the food that you're looking at, and if your wrist spots that you have some fatigue or you did not have enough sleep, the AI could suggest you to pick something protein rich, for example, like a salad, for sustained focus or the remainder of the day. This simple act can improve your daily life quality by a lot. The other is about mobility, safety, and aging. This is primarily for blind and low vision users or aging people and so on. An example is if a low vision user is using the glasses for walking on the road, it could highlight if there is a curb or a stair in low light, preventing any sort of accidents. The wrist can also detect simultaneously if there is any instability in the patterns or if it detects any fatigue from stress. And it can also provide the feedback using the haptics so that the user knows that they could slow down and use a brake. And a step further is escalating these kind of situations. where we connect the insights that these devices get to family or clinicians. But we need to make sure these are very high quality and accurate, and avoid false positives as much as possible. And also closing the loop, as I mentioned earlier, where we can share readable summaries of these video streams, and not really just the raw video itself, because it's not super useful. An example integration we have on Ray-Ban Meta today is an integration with Be My Eyes. It's an app for low-end blind users, low vision and blind users, where they could simply connect with a human on the other side, and they can stream in real time the video they are seeing with the glasses, and the guide on the other end can guide them through real-world navigation. And this could very well be replaced by proactive AI in the future, where we really don't need the human itself. Another advantage with this ecosystem is for clinic experience, where the patients now have lesser load. They don't have to do a lot of manual logging, filling forms, talking to the admin, describe all the things that have changed from their last visit or the recent. We have continuous logging, and we could also fill in the gaps by asking simple questions, simple check-ins on your the glasses. And you could simply answer those using low-effort gestures that are supported with the wrist. And the clinic experience also gets, because they are readily caught up with the summaries of the context that we build over time. And they could use different thresholds and rules to avoid any kind of false alarms and quickly get to the actual treatment in a timely manner. However, all of this doesn't come for free. Obviously, there are very practical and challenging problems. I have listed a few here. There is definitely more. So starting with trust and tone, we need to be really careful about building the users, which is basically about the suggestions are high, reduce the false alarms, essentially. Privacy is a huge concern and also a requirement from the user perspective. Not everyone is happy with sharing all of their health to cloud LLMs and other providers. They care that all of this data lives on the device. So this calls very high capability LLMs and other forms of AI models living on the device of the order of megabytes or up to maximum on phone, for example. The user needs to feel that they have full sense of control over the different permissions they have provided us and where the data is sitting, so that they could delete and take any action as needed. The third one is battery and comfort. Because these are all-day wearables, we need to make sure they are designed for comfort and they don't heat up like if you're using it a lot, and they don't feel like yet another gadget. They should just blend into your daily life. The data quality and bias, because we expect that these wearables work for all types of skin tones and anatomies. The data that we collect to build these models have to be high quality and diverse. Clinical validation is next, where we draw a clear boundary between wellness coaching versus medical support. Discussion as well, can AI truly replace doctors completely? In this case, it's a health companion, so it's acting in real time to provide better guidance in the form of coaching. But it's not fair to assume it could replace doctors completely and start providing prescriptions in real time without any supervision. So we need to be careful about that. And interoperability is basically how we make sure the data and insights can be used with the clinicians and other providers to make quick judgments and basically move the intervention upstream and not wait until you basically see the symptoms. So the path forward to address these challenges is, number one, more on-device intelligence, because this allows the data to be on the device. So it's more private, secure, and also lower latency and highly reliable, which is also available offline. So these devices, if they depend on connectivity, cannot be as reliable as the user would like them to be. If they're going for a hiking with low network, or if they are running with network fluctuations, they still need to work reliably and predictably. The second is rich sensors and fewer devices. This is the last. Second is rich sensors and fewer devices. We need to make sure we don't overwhelm the user with like hundreds of devices that they have to wear and interpret all the time. So the sensors need to get much more higher quality and more signals, reducing the overall user burden. And the third is the closing the loop part that I previously mentioned. So to summarize, so the best health companion is truly invisible until you truly need it. So that's basically what the future of AI wearables is moving towards. And I'm super excited about all the upcoming work and the applications that is possible because of this. Thank you all.
Oh, wait, thank you. Big hand to Surya. Thank you so much. And we'll be including some of the Meta products in our wearables fashion show. And now we're going to do a quick changeover. Let's get Susan's slide up on the board.
All right. Hello, San Francisco. Good evening. Hello. Like two people. I know, you guys, it's been a long day of or a long couple days of heavy thinking. But it's Friday night. We're on Folsom Street. So who's excited and ready to party? A little bit better, a little bit better. So I don't know, who here has seen Susan Bratton speak before? Show of hands. Oh, this is awesome. Susan, this is awesome. You guys have no idea what you're in for. So my name is Elias Serjan. I've been working with Susan for a couple of years. She speaks at all of our events. She is consistently rated one of our absolutely best speakers. Because there's a couple things that I think people generally enjoy. Who likes to have fun? Make some noise. If you really like to have fun, you'd be a bit louder. So how about this? Who likes free stuff? Make some noise. And who likes sex? Make some noise.
Did you say sex?
Yes, I did say sex. Yes. Well, part of being healthy is having a fully vibrant, functioning body that you can enjoy in every way possible. And this is something that we don't talk about a lot of times in the health space. And so that's why everybody loves when Susan comes up and shares with us in a way that's scientific, it's clinical, it's fun, and she gives away more products than any other speaker we have. So if you like free stuff, she has thousands and thousands of dollars of free stuff up here, and it's going to go to the people who are closest to the stage because they're going to move the fastest. So I'm going to give you the next 5 seconds to rearrange yourselves and get your butts into the front, because you could walk out of here with something worth a couple grand or hundreds of dollars. So here you go.
The people in the speakers lounge.
3.
I don't know if the people in the front room heard you. They're missing their spots. I think everybody should get the hell out here, because we're going to learn how to extend our health span with sex tech and giveaways to the front rows.
So yes, if you are in the speakers lounge, or if you can hear our voice anywhere, come on and make your way to the main room, because it's Friday night. I believe this is our closing presenter. You guys are going to have so much fun. And so she's going to be, and she definitely responds to the audience. So if you guys make more noise.
I heard it's all about response.
Yes, it is about response. Stimulus response, right? That's what humans are. So the more noise you make, the more she's going to go give away. So let's start off really good. Ladies and gentlemen, please welcome to the stage intimacy expert, the millions, Susan Bratton. Let's hear it for Susan. Come on.
Thank you, sweetheart. I do love getting introduced by Elias. Thank you so much. He's so sweet and kind to me. Let me move a couple of things back and forth here. These are my things I'm going to show you, and these are my things I'm going to give you. And I'm really excited because this is the first time I've ever presented the idea of quantified intimacy. That's the name of my talk today. And there are now enough products in the quantified intimacy space that I can show you a lot of things. I like to do Susie's sexy show and tell. I like to show you how to achieve your orgasmic potential. I like to talk about how extending your sex span extends not only your health span, but also your happiness span. That's the best thing. I also wanted to let you know I've got some wearables on right now. This is a vibrating ring. It's not quantifying anything, but it's vibrating. It's a vibrator you can wear, which I think is kind of a cute thing by Unbound Babes. I'm also wearing an Apollo Neuro, and it's been stimulating my nervous system so nicely today. You'll see that in the fashion show later. And the first thing that I wanted to do was I wanted to show you your homologous genital structures, because I'm presuming there's some science nerds in the audience. Where's my sciencey people? Where's my healthy science people? Exactly. All right, so let's get this going. You know what else I need? I need somebody to come up here. And what I realized was I have a handheld mic, I've got a clicker, and I've got stuff in boxes. Could somebody come up here and take some things out of the boxes for me? I'd really appreciate that. Thank you. Thank you so much. I've been smiling at you all day. You're my knight in shining armor.
Let's go.
Yeah, I'll flirt all the time. I love to flirt. All right, so let me get that clicker going and show you. Let me see if I can see it down here. Can I get this monitor live? Let me know when I can, and otherwise I will just look backward. Okay, now there's nothing on either one. Ah, that's what I was looking for, some genitals. So, see, I think I'll start with this one. So that's what's really interesting about the penis is that about 50% sticks out of your body and about 50% of it goes in and down towards your testicles. And your penis is almost all spongy tissue, and it gets filled up with blood, and that's an erection. And of course, you've probably heard that we all start out the same in the beginning in utero, and then some of us get a bath of hormones that changes the way our genitals are expressed, innies versus outies. Well, what's interesting is that that entire erectile tissue complex of the penis is exactly the same amount of erectile tissue that we have in our vulvovaginal system. And the vulvovaginal system is 3 erectile tissue systems. One is the clitoral structure, the glands, the shaft, the little arms called crura, the legs called vestibular bulbs, the clitoral body. But we have a second tissue structure, which people call the G-spot, but it's not a spot. It's like a long noodle, like a tube of sponge. Thank you. And then, oh, Vanna White is on the stage with me today. And then the third erectile tissue in the female system is between the lower part of the vagina and the rectum, and it's called the perineal sponge. So we have the same 3 sponges in our vulvovaginal system as our male-bodied partners do in their penis. And that's really important when you get into quantified intimacy.
sexual rejuvenation, sexual biohacking, because what you're working with a lot of times is things like pelvic contractions, blood flow, hemodynamics, which you guys will be happy to know you've got banging hemodynamics. Us ladies, we're more like slow flow. You guys are like, boop. And it's there if you're healthy, where we need that 20 to 30 minutes of what some people call foreplay, but I just call lovemaking. Because intercourse, though it's my favorite thing in sex, I like everything else. It's kind of like all my children. I love them all for different reasons. So whether it's kissing or breast play or oral pleasuring or whatever it might be, they're all equally important, equally erotic, and equally orgasmic. The body has the ability to have over 20 kinds of orgasms, which is just incredible. And I don't want 40% off anything right now. This is the penis and the clitoris, and they're basically the same tissue arranged in different order. It's really, really important to understand how much erectile function is important for pleasure. And then this is the illustration of the 3 spongy chambers in the penis. And there are the 3 spongy chambers of the vulvovaginal system. I can't say vagina because that's just the inside, and I can't say vulva because that's just the outside. So I say vulvovaginal system, or I say the word yoni, Y-O-N-I, my favorite 4-letter word. And that's the tantric love-making word for the whole system of the female genital structures. So you might hear me say yoni as well. Thank you so much. Good job. Looks like Christmas in my house, man. Okay, good. Thank you, darling. Okay, so let's start with a couple of devices. I think I'm good now, baby. Thank you so much. I'm going to what's your name? Mason. I may call you again. Thank you, ma'am. Appreciate it. So, that's the G-spot, just so you know. Where'd it go? I can't get back. That's the G-spot. It's that tube of tissue. It's not a spot. And the genital sensory cortex in both men and women, one of the most important things is that a lot of this quantified intimacy technology is actually stimulating the brain to genital experience. Whether we're talking about corpuscles or nerve endings or mechanoreceptors or the temperature sensors in our cellular system, the way that you have the most blood flow and tissues so that your brain registers it as pleasure. All right, so let me show you a couple of things. I've got the Joy Lux V-Fit. This monitor's still out, just FYI, guys. No worries, I don't mind turning around if I have to. I've got the Joy Lux V-Fit Gold Vaginal Rejuvenation System, and I'm going to show you that first. Got to find it. Mason's got everything out here for me. This is a very interesting company, and I have had great success helping women do restoration of their vaginal mucosal lining, reverse incontinence, as well as thicken that vaginal mucosal tissue, bringing blood flow and engorgement so that sex feels even more plump and juicy and pleasurable. And this also recollagenates the tissue through warmth. Warmth, stimulation for kind of like Kegling, pelvic health, and photobiomodulation. You insert it in the vagina, scroll your Instagram for 10 minutes every other day. It feels delicious, and I really like to use this product as well before I know I'm going to have a date with my husband, because then my internal genital structures are very engorged. Engorgement is the key to increasing your sexual pleasure. So this is a fantastic product. The second product that I want to talk to you about is a vacuum. Oh, and it's app-driven, so it shows you your improvements. The next thing I want to talk to you about, hang on. I think I really need a lavalier. That's okay. Don't worry about it, honey. It's fine. Thanks, Mace. So this is a vacuum erection device, a VED, otherwise known as a penis pump. And what you do is you stick your penis in here. It's currently surrounded by a red light wrap, and it has an automatic electric pump head that pulls the blood into the tissue. And as you're pulling the blood into the tissue, you're essentially exercising the erectile function, the capillary action, and where the capillaries go, the nerves follow. So as you age, you can tend to have sensation loss. This reverses the sensation loss. It's used for reversal of atrophy, but it is also used for male enhancement, which means making your penis bigger, improving overall volume, penile dimension. And that is, I have been quoting 20% overall improvement in penile volume within 10 months to 12 months of consistently pumping a couple of times a week. But we have a Pump Smart app with this brand, Dr. Joel Kaplan Company. And now they have 100,000 data points of men who are actively and consistently pumping. They're seeing overall penile volume in that cohort as 40% overall volume in 5 months, with the most growth in the first month, which is good because it gets everything going again. So if you're either reversing atrophy, feeling like you want more firmness, or you just want a bigger dick, which every guy I know pretty much does. Like I've helped 20,000 men with their penis pumps. I'm in the 3rd edition of my penis pumping protocol book. And even the guys who have giant penises, they're like, I can make this bigger. I know I can. You should see the dick pics I get, you guys. I mean, I think I get the best dick pics in the world. I'm going to lay this down in my little mason pile here. And in case, whoops, that's the clitoral pump. I'll show you that too. In case you're worried that there isn't a cylinder that's big enough for you, if you keep on going, there is. You can graduate to the cylinders as you age. Thank you, honey. Thank you. These are interesting because women can pump as well. Remember, we have the same amount of erectile tissue. This is a vulva pump. Goes right over there. You've heard of Ozempic vulva? Well, good news is you can plump everything back up again that gets flaccid. And there are smaller ones and bigger ones, are clitoral pumps. And I do pump my clitoris because the bigger and meatier that thing is, the better I orgasm. And we atrophy just like our male-bodied partners. So these pumps are quite good. I have some pumps here, so let's give these away. I have 2 lady pumps. If anybody would like to practice pump, it's really fun to pump into the cylinder. Yes, here, darling, right here. You just let me know if you need any help with that. I mean, not hands-on. And then I also have what is called the dual cylinder Whopper system for men. This is the men's pump with the auto grow. Yes, please. It's really fun to pump together. Yeah, it's couples who pump together, hump together, I think is what I should be saying here. I've got another men's pump. Who would like to have? Yes, of course, darling. Please, you're going to love it. It feels good. It makes your penis nice and veiny and super mouth-watering. One more lady pump. Who wants a clip boner? Here we go. Got it? Okay, good. Thank you for your positiveness about this. You guys are doing a really good job. Woo, I'm just throwing my dildos everywhere. Okay, next up is the lioness. Oh my God, I love this so much. So here's the lioness. This is a quantified orgasm. The lioness is amazing. This is a San Francisco company. Anna Lee is the founder. And this is called a rabbit-style vibrator. It goes intravaginally and stimulates the external clitoral and labial structures. And it will help you come better. It measures orgasmic intensity, pelvic contraction, duration of orgasm, and the style of orgasm. And she has an incredible data set and an app-driven experience that allows you to continue to improve and to orgasmically cross-train, to go from having oceanic to avalanche to wave types of orgasms. So I have one of these. Anna sent one over. Who would like to quantify their orgasms? Come on up here, mama. Here you go. Enjoy that lioness. Also, I don't have enough to give everyone. If you want to find out what these things are after I mention them, I put the links to everything at drivedesire.com. Oh, it's not on this slide. Well, it'll be on the next one. So the next thing I want to tell you about is, well, I have to skip the Lilo trainer. I can't show it to you because it didn't arrive in time. But the Lilo is very, very similar to another thing I'm going to show you called the Power Shot. It helps you with, it's a stroker that allows you to solo pleasure and work on your stamina and your Kegels. The Kegels are important because you have to have good pelvic musculature for that force of orgasm. The more force of ejaculation you have, the more pelvic squeeze that you have, the better your prostate works, the more pleasure you have. So semen volume is important as well as the force of your ejaculatory expression. So let me show you another one that's very similar. I'll skip to that, which is the Kiru Power Shot Vibrating Stroker. Let me hang on, I gotta get the lid off. Got it. I got it. You're so good. Thank you. This is very interesting because what it does is it has two motors, and the two motors, actually, you put gel in here, you put lube in here, and then as you're stroking your penis, you can squeeze your penis and you can give yourself sensation down the entire length of the shaft, all the way up to the glands, where, of course, it feels the nicest because it has the most nerve endings. This works with an app, and the app will give you stamina, breath work, musculature control, and nutrition recommendations for improving your stamina. Men's number one sexual issue is performance anxiety, and it's the anxiety that often makes men come faster than they want. So you can both incorporate the Power Shot into your solo pleasuring, routine and build your stamina, which I love. And what's really interesting about this is that this device also works with this. Hang on. You need somebody to hold the mic? No, I'm okay. I'm okay, thanks, honey. Is everything good? Yeah, thank you. Okay, good. Thanks, Lloyd. So this, now, of course, I'm showing a vulva here. This is a stroker, and this stroker is another way that men can have solo pleasure. But what's really interesting is where this is going, which is synchronized sex tech. So this stroker will fit into this device, and this will also fit into this device. And this is called a Keon, and the Keon will automatically stroke you for you. It's hands-free, and it fits. It puts hand job, gives hand job a whole new name. This is really interesting because the Keon will fit in here, And then you can basically just sit here. I think I have it backward. Hang on. I don't have the right equipment for this one. You can basically put this in here. I don't have it on right, but put it in here and you can automatically pleasure yourself and work on your stamina, but you can also attach it to devices. This is my current favorite toy. I have literally been self-pleasuring 3 times more than I normally would since I got this. This has been fantastic. This is called the Pearl 3. It's an internal vaginal vibrator, and it can synchronize to the strokes controlled by an app, and you can parallel pleasure yourselves in the same room, or you can do it over the internet thousands of miles apart. And many of us are in relationships where we're far apart. And so now we have the ability. And what's really interesting about this is that if your male partner is controlling the app and stroking himself for his pleasure, you can feel this up inside your vagina, and you can feel what guys do to make themselves feel good. And I got to tell you, they got some tricks. So this is super fun, and the app has video. So these are really, really interesting. This is the other product that goes with it. That's called the Pro Wand, and I like stacking. I'm a biohacker. I do stacks. I do stacks of peptides. I do stacks of supplements. I do exosomes, stem cells, muse cells, plasmapheresis. And I also use this and this simultaneously. When you activate more tissue, you engorge it, you improve your orgasmic response, and it gets better and better. At 64, I'm having the best orgasms, the best sex of my life. Your sex gets better with practice, not worse as you age. You got something to look forward to, mama. I heard her go, oh, I thought it was going to be all over for me. Okay, next thing I want to show you, and I've just got 2 more quick things. This one's really funny. I know you guys are going to be like all shocked by this. But this is super cool quantified intimacy because it's adaptive AI. All right, let me see if I can get this sucker going. Oh, yeah, there we go. There we go. I hope it doesn't hop off the table. So this is by Tracy's dog. And what's interesting about this is that it is truly adaptive AI. Oh, there, what happened? I don't even know what that was. So what's really cool about this is that the app, AIPHY, A-I-P-H-Y, like AI physical, it comes with like romantic partners that will talk to you. I'm shooting things all over the place here. Thanks, Mason. And you can have you can chat with it. It'll talk dirty to you, and it will learn what makes you have the best orgasms over time. And it's like, it's raining sex toys. I gotta turn this sucker off. But this is a really cool thing too, because it will learn over time what gives you the most pleasure. And then that it's gonna go to like werewolves and centaurs, and that's what we want to have sex with, right? So it's going to be really, really fun. See how I started you guys all off on homologous tissue, and now I've got a giant vibrator up here? It's a slippery slope with me, just FYI. Okay, last but definitely not least, I have it's ridiculous. No, it's really good, don't you think? Are you having a good time? Okay, good. You're not going to faint on me or anything? Are you having the vapors? So, the anti-aging. You feel younger already, don't you? You're looking good, man. Yeah, you're smiling and stuff. That's what we need. Okay, so this is also a really cool thing. This is called the firm tech. Now, you know how they say that erectile dysfunction is like your canary in the coal mine for your heart issues and things like that, like when you start getting soft and the veins start disappearing and everything. Well, it's actually, the thing to track is your nocturnal erections. You want to have a few of those every night, and you really want to wake up with morning wood. The FermTech has a sensor on it. This goes under your penis and this wraps behind your testicles. It's really quite comfortable. You wear it at night, it's app connected, and it keep track of your erectile function and help you see the improvements of your sexual regenerative therapies. The stack is nitric oxide supplementation, vacuum erection device, and acoustic wave. The brand I like, the treatment I like is called Gains Wave, Gains, Gains Wave. That will restore function in almost every man. And by the time you're 40, you're starting to see decline. It's very similar to the female perimenopause, menopause. And so the FermTech Tech Ring is an excellent tracking system for your erectile function. Okay, I think I did my list. I've made a disastrous mess up here, but I have some things. I've got who's gonna take it. Come on down, that's my girl. Call me and let me know how it went and which one you had the date with. Did she choose the werewolf, the centaur, the buffed body trainer, or who knows, the alien from another planet? We're going to have intergalactic sex. All right, who would like this power shot? Pleasure? Yeah, come on down, stamina trainer. Can I throw it? Boop, good job. Who would like to measure their erectile nocturnal erections? All right, enjoy. And I have two. These are performance rings from FermTech. They don't have the sensor in them, but they're very good for holding more firmness in your penis for intercourse, and also for improving your overall orgasmic capacity. Who would like one of these? Okay, yeah, good. You got it. Who's going? Yeah, here we go. This is why you sit in the front row. And last thing I have, and it's not quantified, but it's so damn good, I had to bring one for you guys, okay? So this is the coolest thing. It's tech, so I'm sneaking it in and then I'm done. This is a little tiny clitoral vibrator. It goes on the mons venus, you know, the fur above the outer labia, that part. It sits there. And it's got this little vibrator that vibrates your clitoral shaft and clitoral glands for your lady boner. This is a penis ring with a proximity sensor in it. And as you make love, it goes like this. And what it does is it toggles your parasympathetic and your sympathetic nervous system, so it improves your orgasmic ecstasy. It comes with, we didn't open it, it's right here. It comes with a little harness, a silicone harness. You can wear it during lovemaking. It also comes with these little silicone pads that'll just stick it right on there, and it just stays there, and you just peel it off when you're done. It's lube impervious, and you can also wear this as a panty vibrator, and you can give your partner the app control, and they can give you orgasms. So there you go. Who would like to have the Luxus system right here? All right. Oh, I'm sorry. I said yes to her already. Let me know how you like it. Okay, well, that's it. Thank you so much for letting me tell you about how important your sex fan is, giving you some new toys and ideas. And I really appreciate all the bright smiles and your excellent kindness to me. Thank you so much.
Thank you. Thank you, Susan. Everybody give it up for Susan Bratton. Okay. Well, Susan, that was great. You got the party started here. I didn't know it was one of those parties. This is San Francisco, but we're also professionals. Okay, everybody, we got a full room now. That's what we needed to get this to wake us up in multiple ways. I want to first appreciate everybody who participated, contributed. Eric, can you go for wide shot? Just lock off on the wide. I want to appreciate all of you. I want to appreciate all of our speakers. I want to appreciate everybody who put energy into this. We have people all over the country, world, contributing, participating. I want to appreciate the crew. We're going to invite everybody up here. We're going to take Susan's slides off, and let's put our main slide up, just the awesome graphic there that we've designed into so many permutations. Anybody by the slides? Anybody do that? Okay. Got Tyler going for that. We got Tyler in the booth. We had like 3 Tylers here yesterday. First, I want to appreciate Spencer. Where's Spencer? Can we get Spencer out here? All right, I'm gonna call out people. Where's Spencer? Come on up. Come on up. Get a microphone. Who's got the mics? I got an extra mic. Spencer. Spencer was the most dedicated partner that I could have in putting this together, just taking care of shit, literally. My shit, other people's shit, her own shit. So thank you, Spencer, for saying yes. And if it wasn't for you, we actually wouldn't be at this venue in a weird way. Okay, Soji, can we get Soji up here? Soji's a gift. I want to keep her to myself, but I know a lot of people are vying for her talent. So Soji, where are you? Come on up. Okay, Soji will come on up. Somebody find her, push her up here. Let's get Elijah up here. Dylan, Mason. Start calling people's names. We'll get them all up. Eric, if you're wide shot, come on up. Mason, come on up. And you guys need to take pictures of us. I'll give somebody my phone so you can take lots of pictures, lots of landscape.
All my volunteers.
Got Will Smith now. Come on up, come on up. Tyler, if mics are good, come on up. Manny, come on up. Okay, we have the whole crew here. Are we missing anybody? We still don't have Soji here. Okay. Nobody's allowed to be shy here. If I'm up front, I need some support, some backup. Okay, let's get in here. We got to wait for. We got who else? We have Alex in the Philippines right now. So Alex, hopefully you're watching us on TV. And let's see. Come on up. If you feel like you should be on the stage, come on up. Soji, come on up. Let's see, we have sponsors. Elias, come on up. Gulia, come on up. Everybody who contributed, if you contributed in some way, come on up here. I want to get you guys in the shot. Let me get in here. All right, everybody, make some room. All right, picture time.
Are you ready? 1, 2, 3. Look at this camera. 1, 2, 3. Oh, we got stragglers. Come on in. 1, 2, 3.
Okay, now everybody's hands up. Everybody hands up. Take more pictures. Woo. Don't block faces. Yeah. Now everybody jump in unison. No, just joking. Okay, that'll take down the stage. Okay, so this is what we're going to do. We have to change this place over. We're going to have a HealthTech wearables fashion show coming up. You got a preview of some of those devices. So we need everybody to get up and just move toward the front of the room. Nobody goes this way. We have to close the VIP and the speaker lounge for a little bit. If everybody can make their way to the front room, I believe the bar is open there. Just make your way in that direction so we can clear the chairs. We can change this place back into a nightclub the way we found it. Okay, thank you for your cooperation. Just clear the chairs, make your way out toward the front, and we'll let you back in pronto. Just give us a few minutes. Okay, crew, we're breaking down the chairs. Let's fold them up, get the stacks out here. Okay, video crew, let's clear a lot of the computers off the bar. I'm gonna try to keep the stream going. Let's see if we can do that, but eliminate a lot of this. Eric, if you can come back and we can talk about the strike over here. If anybody sees any trash, please pick up the trash. Okay, AIFI crew, let's take any monitors that are not plugged in. Oh.
How you doing?
Come on, buddy.
Only 10, 12 years.
I know. Any monitors that are not plugged in that are AIFI monitors, just wheel them toward the back.
Check 1, 2.